तुम्हारा बोलो मेरे व्हाट्सएप पे ग्रुप खोल दो उसको। उससे चलेगा नहीं, दूसरी लिंक देने पड़ेगा, कहीं वहाँ नहीं कॉन्टेक्ट कर रहे चलेगा नहीं, दूसरा लिंक देना पड़ेगा। दूसरा लिंक देना पड़ेगा,
राजू नवी के नाम से
आएगा ही नहीं, ऐसे लिंक भेजना पड़ेगा। खुल जाएगा डायरेक्ट होगा। ये क्या था देखो। जल्दी नहीं क्या आप मुझे सुन पा रहा? आ रहा नहीं, ऐसे आ जाएगा ऑटो वो दो। ये बंद कर दिया मैंने।
यहाँ से ऑडियो का भी बंद नहीं
क्या आप मुझे सुन पा रहा? भाई बोले एकदम सही है।
डॉक्टर मानव आप कहाँ पर हो? अच्छा
तुम्हारा नेट ढूंढ रहा था। मेरे को भेजो तुम।
आप दे रहा हूँ
लोकल वर्क तुम कैसे वो बोल रहा था? यहाँ से लॉकडाउन नहीं है, लॉकडाउन नहीं हो रहा है। देखो चल रहा ही नहीं है लेकिन मेरे को भेजिए लिंक। भेजिए
ठीक है।
तो क्यों कर तो कर नहीं रहा था
ये चूचा भी होल के वाली
जो बोल लगा लेकिन सिर्फ
बात सुनो इसमें जब तक वो कल वाली फोटो डाल दो ना अंकल ने बोला कि ऐसा फोटो डालने का इसमें
फोटो डाली थी मैंने, चल नहीं रही थी,
चालू थी
चल रही थी कौन सी फोटो?
जो अंकल ने सेट करके दी
वो थंबनेल ले वो तो
आता ना
थंबनेल है वो तो
वो आदमी
है ना, शुरू करो आ जाएगा। तो मैंने तो चल रहा है इसलिए बता नहीं, रोको उसको, रोके रखोगे तो आएगा, थंबनेल है वो थंबनेल डालो अंकल ने सेट भेजा खुले चार बैठे
है
बैठे हैं हाँ ठीक है।
ये डिस्प्ले बंद कर दो ना बैटरी ज़्यादा चलेगी
चलने तो मैं लगा तो चार बैठ लेगा डब्बा भी लेकर चार लेगा, जब दो लगाए मैंने अगर अरे रहने दो ना, मेरे को दिखता रहेगा बैटरी है कि नहीं हमारी, तो देखूंगा
तो अभी चालू का सिस्टम खोल देना
चलने दो, मैं लगा दूंगा चार बैटरी लेगा वो आपने बनाया ना, उसका लिंक मैंने आपको भेजा वापस। मतलब कल जो आपने लिंक मेरे को भेजा था ना यूट्यूब पे जाने के लिए, तो वो लिंक काम नहीं कर रहा आज। उसमें मैंने वो चालू तो करते लाइव, लेकिन उस लिंक से जब डायरेक्ट लाइव नहीं जा रहा यूट्यूब पे, खुल ही नहीं रहा। वो पहले वाला कल वाला वीडियो आ रहा है। मैंने चलने दिया, लेकिन आपको मैंने लिंक भेजा, वो वाला काम आएगा आपको। हाँ वो
તમે ક્યાં ઓડિટરની પાસે આવી ગયા? ના ના હાલો નહીં આમ
Sub specialization, that is very hard. Unless they go down to the smaller towns and stuff.
ના ના ભલે લઈ જાઓ
Because there are employment approach. Another experience.
ટૂંકમાં આપણે એન્ટર થઈને ત્યાં પૂછી લો.
Rewadi भी कर रहा है.
हाँ 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 नहीं
आपका फर्स्ट बिल्कुल बिल्कुल
Well, good morning, all of you.
Good morning, everyone. Hope you all enjoyed the banquet dinner yesterday. Now, diving into academics again. The first session of the day is on non-muscle invasive bladder cancer and prostatic urothelial cancers. And for this session, the chairpersons have taken their place on the stage. I would also request Dr. Rudra Prasad and Dr. Kshitij Bishnoi to take their place on the stage and invite the first speakers of the session.
Well, good morning. I would like to invite first talk of the session, how to manage bladder cancer with variant histology, Dr. Manav Suryavanshi. He is a senior consultant and head of urology at Amrita Hospital, Faridabad.
They're on? Okay. So good morning, chairpersons and the sparse audience that it is. Still pretty great after such a sumptuous dinner. I am Manav Suryavanshi and I'll take you through bladder carrier cancers and their variants and let's talk about their management. So variant histology includes any bladder malignancy other than pure urothelial cancer. It's a urothelial cancer with the aberrant differentiation as well as a pure non-urothelial cancer. And then they would end up forming 25% of all bladder cancers. The clinical relevance why we are discussing this topic is because it affects the diagnostics, the prognostics, as well as the therapeutics and the outcomes. So who classifies them into basically 13 different histological variants from squamous varying up to the undifferentiated? If we just look at the tumors of the urothelial tracts and their variants, we have the nested, microcystic, micropapillary, lymphoepithelioma, plasmacytoid, sarcomatoid, giant cell, poorly differentiated, and such. And then we have the non-urothelial variants. So non-urothelials will be of two kinds, epithelial, which will form approximately 90% of them, and non-epithelial, which are rare or less than 10%. So predominantly we'll talk through the commoner ones today, like squamous cell, adeno, and small cell. And we'll also touch upon somewhat of sarcomas, carcinosarcomas, melanomas, and lymphomas, etc. So why about the non-urothelial bladder cancers? Because they are aggressive, they are advanced, albeit presenting just like hematuria, like a normal bladder cancer. Rarely adenocarcinomas may present like a mucosuria. So let's come to the commoner of them, which we have encountered in our careers once or other, like a squamous cell carcinoma. Forms 3 to 5% of all bladder cancers. But in Middle East, it could be up to 75% because of schistosoma hematobium. With risk factors like chronic irritations, UTIs, bladder calculi, pelvic radiations, even intravesical treatments with BCG, and exposure to cyclophosphamides. Smoking is an independent risk factor. The primary treatment for a localized one, I have gone through a lot of literature and tried to just summarize the recommendations for you. If it's localized, the treatment is surgical only. And about intravesical therapies in squamous cells, they have a progression rate up to almost 50% over 2 years and death in almost all cases. So the SEER database, when it was analyzed, shows that it's more aggressive than urothelial. Patients who did not undergo radical cystectomy, SCC subtype was a strong and independent predictor of a poor 2-year survival for all stages. It in stages 3 and 4 is worse than urothelial carcinoma, regardless of whether a cystectomy is performed or not. However, when this tumor is confined to the bladder wall and the bladder is removed as a part of the initial treatment, it is not associated with increased mortality. So, SCC who will undergo radical cystectomies for T1s and T2s, the 2-year mortality rate is comparable to your urothelial carcinomas. This underlines the importance of timely diagnosis and aggressive surgical management. Now coming to the role of neoadjuvant chemotherapies in squamous cell carcinomas, because they are a lot talked about these days. These carcinomas have a high local and systemic recurrence rates up to 50%. So the regimes actually should be considered, but the data is sparse. And in a very small study of 25 patients, 40% could be downstage to non-muscle invasive bladder cancers, and none of them had a recurrence of SCC on subsequent follow-up. So, the problem is, why I'm talking about NAC in this subset is, a median survival post a pelvic recurrence is only 9 months, and overall 5-year survival is only 50%. So, neoadjuvants may be attempted to downsize the tumor to non-muscle invasive, because this is actually leading to significantly longer median survivals. Now, role of radiotherapy in locally advanced and metastatic SCC. With or without chemotherapy, it may be used as a treatment attempt. The chemotherapy combinations used in such a scenario have been paclitaxel, carboplatin, gemcitabine. However, any use of RT with or without chemotherapy is still associated with a poor result, 5-year survival being 5 to 15% or less. Now, the next big subset amidst variants is adenocarcinomas. They can be further substratified into the urachal ones and non-urachal ones, and urachals would represent 10% of all of these adenocarcinomas. So the urachals present more in younger groups, more in females. They are less likely to be high grade, but surprisingly they are more likely to be metastatic at presentation. Still, overall as a subset, they will have a better prognosis. So partial cystectomy can be offered as a treatment of choice over here, but the caveat is the resections should be en bloc, including the dome, the ligament, and the umbilicus, because these would involve umbilicus in 7% of the cases. So the relapse rate is higher in case you do not indulge in an en bloc resection, and there is no survival benefit for the lymph node dissection or adjuvant therapies in a urachal origin adenocarcinomas. The metastatic ones do not have an effective treatment yet. Now let's talk about the non-urachal ones. They would be papillaries or flats infiltrating the bladder. Their 5-year survivals are pretty low, almost to the tune of 11 to 50%. In early localized stages with well-differentiated tumors, such patients may be offered TURBT or partial cystectomy. For invasive non-urachal adenocarcinoma, radical cystectomy, albeit with a pelvic lymphadenectomy, is the recommended treatment, unlike the non-urachal where lymphadenectomy has not shown much advantage. Coming to the next subset of small cell carcinomas, they have similar characteristics to the presentation in lungs. They can even have paraneoplastic syndromes. Their incidence is 0.5%, and any amount of a histology presentation amidst any group would be classified as a small cell bladder carcinoma. Very poor prognosis. Even with multimodal treatment regimens, survival for metastatic groups are 0% at 2 years. Due to the aggressive behavior, the early upfront radical cystectomy should be considered in truly non-invasive diseases, with multimodal therapy regimens should be used in invasive, the ones that are T1 or higher. Systemic chemotherapy becomes an integral part over here. Surgical treatment and no chemotherapy would only lead to median survivals of 3 to 5 months. However, patients who receive chemotherapy as an addendum would be surviving somewhere between 15 to 33 months. So, systemic chemotherapy in the post-op setting, 5-year survival is 43% after radical cystectomy plus adjuvant chemotherapy, vis-a-vis only 20% for surgicals alone. So, treatment should be multimodal in this subset. Now, about the sarcomatoids. Pure sarcoma is only 0.3%. However, sarcomatoid is the commoner one, up to 6%. So, mere presence of sarcomatoid is itself an adverse pathological feature. In comparison to urothelial, they present in higher advanced stages as well as metastatic, harboring a worse prognosis. The SEER again recommends a radical cystectomy. Due to higher recurrences, multimodal approaches have been advocated despite scarce data. Now let's talk about plasmacytoid. It's got a worse outcome. Median overall survival 27 months. There's an alternate way of systemic spread in this case with ureters to the retroperitoneum and into the peritoneal cavity. Comparing them, they are usually more advanced and early radical cystectomy is recommended. There are only case reports for radiotherapies or chemotherapies in this group, so there are actually no recommendations. Now this is an interesting subset. Micropapillary carcinoma, and one should remember it. It's a variant form of infiltrating urothelial carcinoma commonly encountered, 0.6 to 1% incidence, advanced stage at the time of diagnosis with a poorer prognosis. In a T1 or a carcinoma in situ, an early cystectomy is beneficial, while deferred cystectomies in these cases show advanced disease after intravesical therapy with BCG on histopath. Intravesical therapy is less effective in variants. Progression rates are up to 70%. So, an early radical cystectomy in all non-muscle invasive micropapillary bladder carcinomas is recommended. Role of adjuvant chemotherapies. They have a lesser susceptibility to platinums. However, the higher rates of recurrence do question the efficacy and role of any adjuvants in these group of patients. Now, without a molecular, no presentation is complete these days, so I'm coming to the last subsection and let's talk about the moleculars of micropapillary. It is a cluster with luminal subtype of bladder cancer with a high level of ERB2, also known as a HER2 mutation. This explains a need and a biological basis for more aggressive treatment for MPUC. It's biased towards luminal, further subsplitting it into two groups, luminal and P53-like. P53 have an even serious outcomes than the previous ones. And the proportion of them is about 50%. The objective biomarker panels can help identify these P53-like MPs, and 40% of them have HER2 gene mutations. So HER2-directed therapies may be the future. Moleculars in other variants, plasmacytoids would have something like E-cadherin mutations, small cells TP53 and RB1 with activation of MYC oncogenes. So we need genomics or computer recognition to find these variants better and have more targeted therapies. However, the variants still are not reliably identified and we need to improve the assessment and molecular characterization. So the take-home message is, a radical surgery for non-metastatic disease, advanced stages, you need combined multimodal therapies, and multi-institutional trials are the need of the day. Thank you.
Thank you, sir. Is there any role of immunotherapy in these subset of patients?
As of now, there is no literature to this effect.
And if a histopathology comes of a RC, a radical cystectomy of T3 tumor, and is there any role of adjuvant RT in these patients?
So adjuvant RT in some varied case reports have only been reported when the tumor is non-resectable, because you're left with no other option, so you are adding that. What exactly is coming out of it is yet to be decided with time and more cases.
Any more questions from the house?
Sir, what about the Sir, sometimes we have seen like squamous differentiation. So does they behave differently from pure urothelial?
No, stage for stage they would behave the same.
For the same stage they behave the same.
Yes.
So is the percentage of squamous differentials, it makes a difference in prognosis?
So they may present or be detected at a more aggressive stage. That may make a difference. But if you go by stage for stage, the differentiation, if the treatment is offered at the right time with the radical surgery, is same.
So we should manage them like pure urothelial, or we should consider them as squamous?
You should manage them in with a recommendation for an earlier cystectomy.
Okay, sir.
Dr. Manav, after cystectomy, do you offer them the new bladder or a conduit?
So, Shailendra, for that the answer is if I go by the literature. So even a metastatic case can be offered a neobladder in case a patient is very desirable, with explaining the pros and cons, because only the urethral margin will make a difference eventually. But we know that these patients usually have a poorer prognosis, so you would counsel them not to go into the neobladder kind of a thing, because neobladder itself is an exercise in maintenance, dexterity, and an effort by the patient and his motivations.
No more questions, then we can
Thank you.
ask Dr. Sudhir Devana for his deliberation on restaged URBT necessary or avoidable.
Thank you, Chairperson. Very good morning to all of you. At the outset, I want to thank Dr. Gautam for inviting me to be a part of this academic event. And he has given me one interesting topic as to in particularly in the management of non-muscle invasive bladder cancer, where you routinely do restage QRBT for patients with T1 or high-grade lesions. And so, can we avoid restage QRBT in these cases? That's an interesting talk which was given to me. So, we all know that non-muscle invasive bladder cancer is the most common tumor which we encounter, of which the initial management would be the TURBT, where you have to resect initially the exophytic part, and then the resection of the base also should be done to get detrusor muscle in the specimen, because that's the most important part which we have to do. This everybody knows. And even the guidelines regarding restaged TURBT say that you have to go for this procedure within 2 to 6 weeks of first TURBT, only basically with the idea that if you had done some incomplete initial TUR resection, or if you have found no detrusor muscle in the specimen, which I already mentioned, and then the associated with the T1 tumor, because these are a separate category of tumor where there is a risk of recurrence and progression is higher. So it's better to go in again and have a look. And it has been shown in the various studies that doing a second TURBT is going to increase the recurrence-free survival, and also it will improve the patient outcome. So that's the most important part of the restage. So undoubtedly, based on the guidelines, obviously we have to do in T1 high-grade lesions, but can we avoid them? That's what the question which we are going to answer. Like in this published series, I have collected all the published data on patients with restaged TURBT where a residual tumor was found in the how much percentage is there. If you go about it, you can see a wide range of variation ranging from 16 to almost as high as 75%. So that means there is something wrong with the quality, maybe, or quality of TURBT which was being done, which there is no standardization, because everybody does in a different way based on their own experience. And then, yes, probably they might be missing a tumor at other place. That can be a possibility. And another most important thing is upstaging. This is the most worrisome part. So if you see the range, it actually ranges from 4% to somewhere around 10%. So that means we are going to identify patients who can even be considered to radical cystectomy if you do a restage. So that is a positive part of doing restage TURBT. And another advantage is the prolonged recurrence-free survival and also the progression-free survival. There is already enough data to confidently say that a patient undergoes a second loop TURBT, they have higher recurrence-free survival and also progression-free survival. You can see these in the Kaplan-Meier curves also. If you do a second loop TURBT, you see the recurrence-free survival is far better and the progression-free survival is also better. That's why it came up into the guidelines to go for that. So, what are the other side of the story? Why can we avoid this restage TURBT? You see, the patients need anesthesia for this. You have to, the OT time will be wasted, and of course you have the use of resources also. And of course this procedure is not without complications. We have seen patients undergoing restage TURBT at the scar site, patients having perforation because of operative jerk or whatsoever. So, and also the next thing is the financial burden. So let us look into how to avoid it without affecting the recurrence-free survival and the progression-free survival. So I have divided this into 3 points. The first point is improving the quality of the initial TURBT. The second is the proper case selection. And of course now the new one which is coming up is the use of MRI in selecting cases. Like how to improve the quality of TURBT. Always resect the tumor into two parts. First you resect the gross tumor, which is a pedunculated one, and then spend dedicated time in resecting the tumor bed till you see the healthy muscle, and also the margins of the tumor also should be resected. This is the most important thing which we have to do. That is in our hands. So this we can improve. Then of course, obviously when you do a good TURBT, you will find a detrusor muscle in the specimen. And I would always consider surgeon as the experience goes on, obviously you do a better job. And the other 2 points which I have written on the right side, the use of blue light cystoscopy and en-bloc resection, yes, they have a definite edge of detecting more tumors. Obviously that will translate into having a less chance of recurrence. So that I will be discussing in the later slides. Like this is the another study published where they have definitely shown that on multivariate analysis that the presence of detrusor muscle is an independent predictor of having no tumor at restage. That means if you don't have a tumor at restage, that means you can avoid the TURBT in that setting. So that's why in the initial TURBT you should have a detrusor muscle. And of course they have even mentioned en-bloc resection as showing significance on multivariate analysis, showing that it can also improve the no tumor chance at the restage. Surgeon's experience, which I already said, this is a study published in European Urology where they have categorized surgeons into 5 categories based on the experience, and they have clearly shown that the experience matters with significance. And even particularly when they compared low and intermediate risk tumors with high risk tumors, they found that if you have a high risk tumor, particularly like a T1, an experienced surgeon would offer a better job and compared to the inexperienced surgeons. This is another study published similarly to show that on multivariate analysis, definitely the odds of having no tumor at restage is better with a senior surgeon when compared to a junior. Let us talk on something about the blue light cystoscopy. Obviously, everybody knows that in the published meta-analysis, they have clearly shown that if you do that blue light cystoscopy has a definite edge in terms of having a prolonged recurrence-free survival. However, the evidence is not consistent with all the studies. So there are some studies which say it is better. There are some studies which say that it may or may not help you in decreasing the recurrence. And just I brought up this randomized trial because the rest of the published literature is predominantly on retrospective and prospective trials, and this is a recent study published in 2022 of randomized trial comparing blue light cystoscopy with white light guided TURBT. So if you do this technique, can we avoid a restage in that staging? They found that the 3-year recurrence-free survival is almost comparable. So it's not offering any much advantage. So that means white light cystoscopy is enough actually if you do a good job. Now let us go to the en bloc technique. Obviously the technique wise you will obviously feel that if you do an en bloc you can take a better chance of muzzle. But it's not possible in all cases because your case selection is very important. So if it is like at a ureteric orifice, obviously you can't use that technique. But yes, in selected cases it can be considered. And if you come to the evidence, the problem is majority of prospective and retrospective studies have shown advantage that en bloc resection is better in getting good muzzle and everything, and also which is transferring into the decreased recurrence-free survival. But if you see the randomized control trials, the evidence is not robust. So that means as of now there is no level 1 evidence to say that the en bloc resection is better in terms of reducing recurrence-free survival. Now proper case selection, this I want to highlight because if you have a large tumor, multiple tumors and a tumor at the dome of the bladder, obviously you can't do an ideal TURBT which you do. Because if a large tumor, you spend more time managing the bleeding and everything. At the end of the time, obviously you will do a suboptimal job for resecting the base of the tumor. And of course, you have other inhibitions in between. Having operated the surgeon would be fearing to do a proper cutting at the bed because they will fear of perforation anyway, and also bleeding. So these are situations, if you have a patient with multiple tumors scattered all over, obviously doing a restage would be better. So that means select your case properly if you want to avoid a restage. This is a paper published from us only from our department where we want to show the utility of the restage TURBT, and you can see presence of solid tumor is an independent predictor of having tumor at restage. So that's why whenever you have a solid tumor, better to go for restage. But if you see other tumors like more than 3 centimeters also, here if you see, there is no significant difference. Even with single and multiple, no difference. Even the low grade, high grade also, there is no difference. That means, even if you have a multiple tumor or a large tumor, if you have done a better job at the initial, there is a chance that you might not have needing any restage also. So, you can offer fairly comparable outcome. Of course, contrary to our study, of course, there are papers who say that in large tumors, better to go for TURBT, restage TURBT, and if you have multifocal, it's better to go for restage, showing significant risk of having a residual tumor. But yes, by changing your surgical technique, we can consider actually avoiding a restage. And this point which I want to highlight with this slide is that histopathology. This is also very important. Sometimes you don't have a good quality specimen. So if somebody gets a TURBT done outside and he comes with a improper biopsy report, obviously you have to consider to go for a restage. So because in many studies they have shown that the quality is also poor in some percentage of the biopsies. And then coming to the evidence, these are 2 papers which have studied on the avoiding restage TURBT in non-muscle invasive bladder tumors, and they have found that definitely the progression-free and recurrence-free survival are comparable even if you avoid a restage. And coming to the final point which I am mentioning, can we predict which case can be avoided of doing a restage TURBT based on the imaging? This is particularly using a multiparametric MRI. If you do a multiparametric MRI, you can actually select your patients in which you can avoid restage TURBT. This study has shown that the use of VIRAT scoring, if the score is less than 3, then in such cases, if you do a good TURBT initially, there is very less chance that you will have a tumor at the bed. So they have shown that the ROC curve is showing very significant outcome in terms of like sensitivity is 85% and the specificity is also very high with an area under curve of 0.9. And this is just an example before I finish my slide, my presentation. You can see this is a patient who underwent tumor. Let us say a patient comes to you, got an MRI done. This is a tumor. You can see in the ADC map there is definitely restriction in the tumor, but in the dynamic contrast enhancement films, this is a perfusion image where they have shown the predominant uptake is there in the pedunculated part, but at the base there is no much of uptake. So they have labeled it as Byrad score 2. That means there is very less chance that this patient might be having muscle invasion. So if you do a dedicated TURBT, the chance of you having a residual tumor in the specimen is less likely. So MRI actually can help you. Let's come to the final take-home messages. Yes, definitely restage TURBT is indicated according to the guidelines, particularly in T1 tumors. And however, it can be avoided by using careful case selection based on the preoperative imaging as well. But most important thing is performing a good quality first TURBT. That is the most important. If somebody has done it and a patient is coming to you, and if you have a high-grade disease, I would suggest you to go for a restage. Otherwise, if you are doing and you are confident that you have done a good job, then you can avoid in selected cases. And of course, the evidence shows now that Byrad score less than 3 helps in actually differentiating cases, whether to go for TURBT or not, restage. And of course, there is no level 1 evidence yet to suggest that en bloc resection decreases the chance of having a residual tumor at restage. At the outset, I want to invite you all for the first upcoming conference of urolithiasis section at PGIMER Chandigarh, and it would be on May 13 to 14 at our center. So we invite you all to please do come and attend the program as well. Thank you.
Thank you, Dr. Devana. Very nice and elaborate deliberation on how to restage. Would you recommend this multi-parametric MRI in follow-up, or it is just an initial investigation?
Sir, based on the current evidence right now, it is actually prior to doing your resection. So the published data, because the 2 publications which I have shown, these are very recent publications which have come up, and it is actually recommended as of now based on the initial setting only. I don't know whether in future maybe it might come up to say, supposing a patient undergoes TURBT, now you want to assess whether there is any residual tumor, because you have to do restage within 2 to 6 weeks. But the problem is, obviously you have the artifact related to the TURBT itself. So there would be some problem in that, but I personally believe that doing MRI before the initial TURBT is better.
Now, usually we are going for the CT urography most of the time. Now
Yes.
we recommend this, it should be replaced by the MRI.
Maybe T2 and T3 lesions, yes, the role of MRI is emerging now to better characterize whether the depth of invasion far better when compared to an CT scan. But yes, in non-muscle invasive, I would consider it to be in a pre-procedure setting only.
Sir, thank you for the wonderful presentation. I have a question, sir. If in a patient of TA high grade, less than 3 cm tumor, in the biopsy specimen, lamina propria is there and it is not invaded, but no deep muscle. So, sir, in these cases, will you skip restage TURBT or?
Yeah, because TA lesion is preferably confined to the only the epithelium. So obviously, yes, if the size of the tumor is less, he is an ideal candidate to go for avoiding the restage. But provided your cytology in the follow-up also you have to look, because there is a possibility that he might have CIS in the rest of the bladder as well. So the point is, he might have CIS, but he will not. There is a less likely that he might have a tumor at the base if you have done a good job. Like if you should see the previous one of my slide, I can show the initial slide. There is a study actually done from CMC Vellore only, in particularly patients with TA. Let me show that, and you see this study. You see this? Dangi et al. In 36 patients. In this, actually, they have shown that even in TA high grade also, there is a chance that you might have a residual tumor. But the evidence, but the upstaging to T2 is 0% there. So definitely, yes, if you have done a good job, because always the surgical technique is the one which is most important. Otherwise, considering this study, there is a chance that you might have some tumor there, restage as well.
So sir, in this case, we can directly.
So high grade lesion, it is guideline wise, it is better to go for restage.
Restage, but sir, if the surgeon is confident, then we can directly go for the intravesical therapy.
Yes, yes.
As it's
One more thing, this point I didn't highlight in my presentation. Whatever we discuss that the technique and avoiding the restage, the point is that the patient should be ready to complain, to follow the adjuvant therapy in terms of intravesical therapy. If that is not happening at the right time, then whatever you have done is a waste of time actually. So that effort goes away. So he should be ready to be competent. Anyway, with intravesical therapy, you will be doing scoping anyway. So obviously, if you have missed it, you will detect it anyway. So that is all. That should always be there. That he has to be ready for the adjuvant therapy as well.
Sir, I have another question, sir. In a patient of URBT, and during intraoperative period, there was an extraperitoneal perforation. I managed conservatively. Biopsy report came as a T1 high grade and no deep muscle found. Or it's a T1 high grade, but there is deep muscle is free of tumor. In these two scenarios, restage will be done.
He had a perforation also, you are saying?
It was a small perforation managed conservatively by catheter.
Ideally, the very fact that he had a small perforation, then he had taken a good deep biopsy there actually, to be frank. So you will definitely have a biopsy in that setting. And the most important point is, at that point after many times when once perforation happens, you tend to finish the case very fast. You try to coagulate it and then stop because the tumor cells might go into the extravesical space and everything. So, I mean, practically if you are asking me if the perforation occurs and if your if deep muscle is there and a complete resection has been done, you can avoid, otherwise you have to go for a biopsy anyway again.
Okay sir, thank you. Thank you very much. Next speaker, Dr. Hemang Bakshi sir. I would like to invite you on stage. The topic is pelvic lymph node dissection in carcinoma urinary bladders, the updates.
Thank you, respected chairpersons. Good morning, everybody. I thank, can we have presentation? I thank the organizers for having me here. Open this. well, ठीक है. That's right. So I am to speak on pelvic lymph node dissection in bladder cancer and its current status in 2023, what we are doing and what we should be doing. So we all know that pelvic lymph node dissection is an integral part of a cystectomy in bladder cancer, high-risk NMIBC and muscle invasive. The role is diagnostic, where it gives a good staging, prognostication, and selection of adjuvant therapies, as well as therapeutic, because there is a potential cure in patients having micrometastasis and 1 or 2 lymph nodes positive. There is an improved disease-free survival, cancer-specific survival, and overall survival. This has been proved in literature since many years. Now, controversies are, number one is the extent of node dissection, the templates, what we should be doing, and the number of nodes to be removed, the lymph node yield, whether image guidance helps, what kind currently, open versus minimally invasive, laparoscopy or robotic, whether the lymph node yield is same, the oncological outcomes are the same, and what effect neoadjuvant chemotherapy or adjuvant chemotherapy is going to have on the lymph node dissection. So these are some of the points which need to be discussed. Now, regarding the extent, this is the standard European definition, European Urology work group definition of the different templates. Limited is obturator plus internal iliac. It would remove 50% of nodes. Standard is external iliac. Standard would be external iliac. Addition of external iliac to the limited group. So 3 templates. Extended would include obturator, internal iliac, external iliac, common iliac, and presacral, and this would remove 90% of the nodes. Super extended would be extension of the lymph node template up to the inferior mesenteric artery origin. Now, the definitions would also vary. In some studies, extended is equal to standard template, but majority of the times, these definitions of the European Urology Work Group is commonly. Now, bilateral node dissection needs to be done, and as you can see, the nodes are evenly distributed both sides of the pelvis most of the times, and lower periaortic nodes also contribute significantly to the total number of nodes that are involved. Now, why do an extended PLND? Because standard includes, we already discussed the templates, but it identifies more than 90% of N1. Deep metastases are very rare, so you don't encounter just the presacral nodes and no nodes in the distal pelvis. But an extended lymph node dissection would increase the nodal area by more than 30%, especially in P3, T3 and beyond, and those who have clinically positive nodes. So would eradicate theoretically more of the disease in more advanced cases. Now, this is a meta-analysis published by a Chinese group. More than 10 studies, close to 4,000 patients, comparing EPLND versus non-extended PLND, and the results showed that EPLND was significantly associated with better recurrence-free survival and disease-free survival, but no correlation was found with overall survival in either group, in comparative group. Complications were similar between the two, and as was mortality. So no overall survival benefit, but oncological control was better in this meta-analysis. You can see across the forest plots, all studies up to 2018, and the recurrence data favors EPLND. Survival data, meta-analysis of PFS and OS. OS is, the trend is towards the left-hand side, which is EPLND, and on the DFS, majority of the studies favored EPLND as compared to non-extended lymphadenectomy. The only randomized trial published in literature comparing extended versus limited pelvic node dissection is the LIA trial, published by the German group in 2018. They randomized 400 patients, almost even in number, EPLND versus non-EPLND, extended versus limited. And as you can see, the cancer-specific survival, 65% versus 59%, not statistically significant, the p-value is 0.36. Again, cancer-specific survival, 76 versus 65% in limited LND, the p-value is 0.1. And overall survival, again, 59 versus 50%. So all three parameters of cancer-specific survival, OS and RFS, were not clinically significant between the two groups. And if you see the number of lymph nodes, this is a typo in the visual abstract. The number of lymph nodes removed in limited were 19 and extended was 31. It's not 13 actually. So these lymph nodes are much more than what normally would be encountered. We don't usually encounter 19 lymph nodes in a limited dissection. This is one point. But in regards complications, there were more Clavian grade, higher than Clavian grade 3 complications, lymphocytes for extended PLND, and this was a negative trial for primary endpoint, which was a recurrence-free survival. There are a few criticisms that included 14% of T1 patients, which the outcomes are expected to be good either way, whether you do EPLND or non-EPLND, because the metastasis rate of lymph nodes being positive is less than 7%. So, and no NSCT patients were included, which is not the real-time scenario, because most of the times these days NSCT would be given to these patients. So, and there are other reasons. There was a selection and a surgeon bias in the study, 56% or less. So more than half had less than or equal to PT2. So early cases were more in this study, which would confound the outcomes. And of course, no NSC is allowed. A better trial study is the SWOG S1011, which had more numbers, which allowed neoadjuvant chemotherapy, and which was supposed to be out the results by the end of last year, but so far as I know, they haven't been published yet. So we await the results of this, and for comparison, NSCT was allowed, and these had more higher stage patients as compared to the LIA trial. So nodal yield, what is an adequate or optimum number of lymph nodes should we remove? and how important is lymph node density to reduce or eliminate surgeon factor as far as number of lymph nodes are positive lymph nodes go. The lymph node density is taken into account, which is number of lymph nodes positive versus divided by the number of lymph nodes which are removed. And the cutoff in most studies is 20%, so the survival would drop when more than 1 in 5 lymph nodes are positive from 45% to 6%. So the density is taken into account in many studies to avoid the confounding factor of number of nodes. Regarding the number of nodes removed, the reanalysis of SWOG 8710 study, and more than 10 lymph nodes minimum should be removed according to the SWOG. This is an earlier study, of course. Surgical margin status and the number of nodes removed are independently associated with local pelvic recurrence, which is logical and which is proved by this study. Now, what is the exact number of nodes beyond which if you remove more numbers, there is going to be no advantage as far as survival or cancer-specific outcomes go. So this graph shows that beyond 25 lymph nodes, the curve flattens out. So if you remove more than 25, it's not going to be beneficial much to the patient. It's going to add more time, create more complications. But there are other studies which have shown that 16 node threshold, cancer-specific survival and DFS is better when more than 16 nodes are removed. And the correlation between the number of lymph nodes removed and percentage of positive node is strongest when the number of lymph nodes removed is 16. So 16 is a key number according to many studies, but still there is no consensus on the exact threshold at present at which survival benefit can be predicted. So again, it is still. So I was very happy to see our own Dr. Gautam Chaudhary and this institute group have a very nice review on the literature. And they have summarized very nicely. I cannot, of course, lack of time, go through all this. So, minimal invasive versus open, laser trial, 3-year update, the non-inferiority trial, oncology outcomes were similar between robotic versus open, and the number of lymph nodes was similar in the lymph node yield, overall surgical margins were similar, open versus robotic, and in the Peter Wiklund's population-based study in Sweden, again, the number of removed lymph nodes were higher after a robotic as compared to open, as were all other parameters the study. And the two randomized trials comparing robotic versus open, Parek's razor trial and the Bochner study in 2018, if you see the number of lymph nodes, standard template 20 versus 18, extended template 31 versus 29 in the Bochner study, and in the Pain study 23 and 25, the number of resected lymph nodes. So they are practically the same. There is no difference, and the guidelines, of course, suggest that, just the last slide after this, guidelines suggest that all patients undergoing cystectomy should get a lymphadenectomy done, AUA, EU, and the NCCN. AUA mentions the minimum lymph node count should be 12. All other guidelines do not have a consensus on the minimum number of lymph nodes which should be removed. The last take-home message is, all patients undergoing cystectomy should have a PLND, as we all know. Extended node dissection, EPLND, is currently the standard of care up to the ureter and below the, just above the common ileal margin, including the presacral and the common ileal nodes. Super extended dissection up to the IMA does not confer any significant advantage over the extended template. WOG data is eagerly awaited. Robotic versus laparoscopy versus open. The number of the lymph node dissection oncologic outcomes are the same. Image-guided PLND, people have injected ICG and technetium nanocolloid as they do for penile cancer and have studied the outcomes. But there are small studies, retrospective studies, long-term follow-up is not there, so we can't really comment on that, but that could be future. Thank you so much.
Sir, how we decide, because all these are the pathological reports, how many lymph nodes are there. But during surgery, I think we are not been able to count the lymph nodes, how much we have. Only we think how much chunk we have taken.
Yeah, so we clear the templates, right? So you can send the lymph nodes in separate packets. I tend to include just in one common lymph node packet, but people do external iliac, obturator, common iliac, internal iliac in separate labels. So it all depends on the pathologist. There is no consensus whether this is going to be a better guide for the pathologist and more number of lymph nodes would be retrieved. But you don't need to count the lymph nodes, you just clear the templates and that should be our goal, I guess. Very good.
Dr. Devana.
Sir, I have a question. Like you already mentioned in your presentation that as of now, majority of the patients undergo neoadjuvant chemotherapy.
Correct.
So, is there any paper which has addressed on because it is a normal observation that whenever a patient receives neoadjuvant chemotherapy and when you are doing lymph node dissection, it's slightly difficult when compared to a situation where you are doing it upfront, because the planes are very good, because once that reaction occurs after chemotherapy, so the suboptimal chance of doing lymph node dissection can happen whenever the chemotherapy was given. So
yes.
Is there any published data which was looked onto this point, whether giving neoadjuvant chemotherapy has some different outcome in terms of lymph node yield?
Not really. I couldn't find any. I will search for the literature. But what you are speaking about is the difficulty in surgery would happen if there were clinically positive nodes to begin with. If on the CT, MRI, there were positive nodes, we have given NSE, the nodes have responded very well. There is a clinical negative node on the PET scan subsequently. In these patients, you might expect some fibrosis, some adhesions. But the clearance would be, I guess, the same. But I couldn't find any literature pertaining specifically to the difficulty surgery.
Again, one point, robotic versus open radical cystectomy and lymph node dissection.
Right.
All salvage cystectomy people are doing by open method, where lymph node dissection is not a part. When we are collecting data, we include all those cases in open radical cystectomy. So just you are twisting data in the favor of radical cystectomy and lymph node dissection. Even in our place, we have done a study in which shown that data is favoring lymph node number in favor of robotic surgery. But what they have done, they have counted salvage cystectomy where lymph node dissection is also not a part. Because of you have given radiotherapy and chemotherapy, you are not able to do lymph node dissection in those cases, and only you are doing salvage cystectomy. So you are twisting data wrongly in the favor of robotic radical cystectomy and lymph node dissection.
That would be a separate study, I guess, because salvage cystectomies are rare, and I agree that radiation, if it is given, you don't need to remove the lymph nodes in those cases. But for those who have not received cystectomy, this is good enough data, I would say.
Thank you. We should close the session because I think a lot of people has a flight to catch. So, thank you, Dr. Bakshi.
Thank you for a great kickstart to today's event. We have a poster evaluation which will be conducted on the left side of the auditorium in the corridor, and we have received about 20 posters. I would also request all the chairpersons and speakers to proceed to the right of the auditorium for a group photograph and for their mementos. The judges for the poster evaluation are Dr. Puneet Agarwal, Senior Advisor in Urology at Army R&R Hospital, Delhi; Dr. Sunil Gokru, Professor and Head of Urology at R&T Medical College, Udaipur; Dr. Vishwas Baheti, Consultant Urologist from Udaipur; Dr. Govind Sharma, Consultant Urologist from Jaipur; Dr. Shashank Saini, Assistant Professor in Urology from TMH Varanasi. The second session for today is on muscle invasive urothelial carcinoma and UTUC. I would now like to call the chairpersons to the stage. Dr. Govind Sharma, Consultant Urologist from Jaipur; Dr. Rohit Ranjan, Consultant Urologist from Gorakhpur; Dr. Samit Chaturvedi, Senior Consultant Urologist at Max Hospital, Saket; Dr. Prakash Chaudhary, Consultant Urologist from Jodhpur; and Dr. Gopesh Vishnoi, Consultant Urologist from Pali. I request the chairpersons to kindly come on stage and introduce the speaker. Thank you.
Do you have papers?
Good morning, all. First, I would like to invite Dr. Shrenik Shah on laparoscopic radical nephrectomy. How would I do it?
Good morning, everyone. First of all, I would like to thank the organizers, Gautam and whole the team of Aiims Jodhpur. This is what I liked the most was in urology, as there is a subspecialty coming up, but in this is a subspecialty of subspecialty, like with one typical topic like of TCC, we are going ahead and into the full depth. So I congratulate, this has been really a wonderful meet so far. Okay, my topic for today is the role of if there is a large mass upper tract, and then what to do. Yesterday we had one case also. So if we really understand, the upper tract TCCs are really not that uncommon. So if we really look at 5 to 10% are of upper tract TCCs. After the bladder, if you will see that the upper tract TCC total is 2 to 4%, but if somebody has, if you compare with the bladder, it is still 15 to 75%. The clinical presentations may not be very typical, but still the hematuria may be the common. If there is obstruction, flank pain will be there. Now in this, again the diagnosis, especially in the era where we must make sure if it is a high risk, that leads to the kind of, we need a definitive treatment. And the diagnostic already algorithm in an era of flexible ureteroscopy, we can obviously go and figure out for the filling defects and we can take the biopsies. Now, what is the EAU guidelines? Like the strong guidelines is if there is a high risk upper tract TCC, we must do the definitive treatment in which we must, if it is a small mass, we may remove it endoscopically, but for the large mass, we must remove the complete mass with the kidney and the bladder itself. Now there is a difference. The left and right side, both the nephrectomy, nephrectomy will be different. We understand that on the left side, the important is, as yesterday I think in the live surgery also we had gonadal, and there would be adrenal and the lumbar, especially before we reach to the level of the artery. The port position normally is been preferred is a transperitoneal. People can do retroperitoneal also, but this is what we preferred. The left and the right, normally you put 4 or if required 5 ports. This is a port, yes, we always do by the varies. You create a good pneumoperitoneum of around 4 to 4.5 liter of the CO2 will go, and then after the first port, all ports are put under vision, and this is in a lateral position. As rightly yesterday also was shown, we do the port, the colon mobilization, and then the ureterogonadal complex is uplifted and you try to go. This is right now done in the lateral position, and the psoas is one of the very important landmark as you start mobilizing the ureter with the gonadal vein and try to reach up to the renal vein. And the gonadal is clipped. Similarly, if it is coming on the way, you should also take care of the lumbar. So on the right side, similarly, if you will see there, the gonadal won't be the question, but you would be really concerned about the straight, there will be IVC, that the renal vein will be opening up on that, and the artery would be behind it, so you should be really looking at once you do the vein dissection, the artery should be first taken care, and you should completely dissect it out, should be under vision. And so the first goal is to reach to the hilum, and you try to take care first artery, and again this is the behind, take completely encircling, go behind the artery to make sure that, and even when you are applying clip, the real sound should come, you should be able to see behind the artery also. Keep some few millimeter, 2 to 3 millimeter area even after before you cut the artery, because that stump is required so that your clip would remain and there should not be any other disasters. So this has been completely done under vision. And once artery is done, you take care of a vein. And then you go for the kidney mobilization, like the upper pole, and then you go the posterolateral, from the lateral also. Now, once you finish up this upper, the kidney is mobilized, we change the position, and then we put it into the supine position. And then there are various techniques for the bladder cuff because it has to come in continuity. And there are people are doing like by the plug technique, endoscopic technique. We prefer to do by the laparoscopic one, in which we try to, people are doing by intussusception technique, transvesical treatment. But what we try to do is we pull the ureter, dissect it right up to the VUJ, and you can see then you put an encircling incision around, keeping at least 1 to 1.5 centimeter margin and taking care of the complete bladder cuff. And once it is removed, then this becomes pretty good that you can take care of the bladder closure under vision, whatever the rent, you do it normally in 2 layers, and this has been completed. So by all means, I believe could be one of the real advantage of doing by the minimal invasive, I would say. These are the few cases I am just sharing. This is this 55-year-old gentleman had a large mass, maybe almost 4 centimeter in the lower distal ureter. And this was another gentleman had a 65, whole pelvis was filled up with a mass, and similarly. So even if we go by the review of literature, the minimal invasive has definitely advantage, whether you do lap or the robotic. And same, the guidelines also says for high risk tumors, the follow-up is also important. You must perform the same like the CT and the for every 2 years. And this is our small experience that we have done the right and the left. And the most important is the histopathology. Now we are really concerned, the high grade, and in that probably nothing like the surgery that. So again, I would like to conclude that have a better knowledge of anatomy, do a proper dissection, and probably taking care by the minimal invasive, especially in 2023, is a way to go. Probably laparoscopy can very well done. There are certain cases where robotic has definitely advantage, like if you have to do like partial prostate, but probably here laparoscopy is still good, but whichever way done, rather than in open, you put 2 incision, one for the kidney and then second for the bladder. So minimal invasive is still a way to go. Thank you very much.
Thank you very much for nice presentation, sir. Any questions from audience?
Right, no, normally we do not do that because this is going to be, if it is a lower track, like at the level of the lower ureter what we had shown, but normally we don't do that.
Thank you so much.
Thank you.
Sir.
Thank you very much for the opportunity here.
Now I would like to invite Dr. Santosh Kumar sir for his talk.
Thanks Gautam and team for doing commendable job and taking this institute to a new height. Radical cystectomy. I am doing open. I do have robot. I am doing robotic radical prostatectomy, radical partial nephrectomy, all sort of reconstruction. So, okay. start from beginning? Okay. So I am doing open radical cystectomy because I have seen you can do with subumbilical incision. Even you can offer Aishwarya Rai and Harna Sindhu. She will have pantage and she can do belly dance also as well. But I believe those patients will not come to me, go to Dr. Rawal or the robotic surgeon. Because the brightness of robot is so much, open surgery is losing its charm. But I will make it shine it again. So going with robotic radical cystectomy. So this was a patient with high grade ECC. So just within 15 minutes we have kicked it out from the body of the patient, although I am neither Arjun nor a club. What is the problem? Okay. So we are following same protocol, Iraj protocol, no digestive, no boil bath, early ambulation, good nutrition, and post-op early feeding or some feeding with Hajmola toffee. Proper pre-op preparation, chest physiotherapy or limb physiotherapy is a part of therapy. Again, we give subumbilical incision 4 cm below the umbilicus. We use a stapler. You use tranexamic acid, not IV, although there is a study to give it IV, and not epinephrine soaked sponge to avoid even minimal bleeding. So just we have gave the incision, just we are dissecting entirely and separating it from peritoneum. We have divided the urachus and we are dissecting it posteriorly with blunt dissection. Although this is very bulky tumor, you can see this is very bulky tumor, barely any space hand should go. Even in robotic surgery you will feel some problem in doing this. Then we are using a stapler. This stapler you are using on pedicle. So within 1 minute pedicle will or this kidney bladder is separated from the lateral pelvic wall. So you are putting, after dissection, you are putting finger entirely and posteriorly you are gauging it. There is pedicle is there is enough space to hide the stapler. So you are just hiding the stapler and bladder is separated from lateral pelvic wall. After posterior dissection, anterior dissection, you are keeping pedicles between these two fingers and firing the stapler. And always you are judging this stapler firing should not go on rectum or any major vessels. Any residual vein tumor is or blood is coming quite up, you can see posteriorly easily. And again you are dividing puboprostatic ligament and again we are firing on a stapler here. So when you are dividing prostate from urethra, just put your fourth finger behind the rectum and use scissor. You just cut it and after that you just take few hemostasis suture and put a Foley's catheter from below and hemostasis will be secured. So usually blood loss is not more than 30 to 40 ml. You need not to go for ureter before removing bladder. At the time of lymph node dissection, you will come to see where is ureter is there. And when you have use the stapler, ureter will be good distended and it will help you making ureteroileal anastomosis also, whether you are making breakers or you are making vellus. Here we are doing bilateral pelvic lymph node dissection. Our study shows the lymph node, number of lymph node was less than robotic surgery, but they have included also salvage cystectomy cases. Here again we have used a stapler anastomosis for bowel. And in open, there will be no hassle doing bowel anastomosis. Yesterday you have seen the color of bowel, it was quite changed due to excessive manipulation of bowel during robotic surgery. So whether it was minimal invasive surgery or not, again is a question. Here you have divided both the ureter. Ureter is good dilated because you have already clamped, fired the stapler during the division. We have divided the ureter. You can see the ureter is quite healthy. Then we have made villus anastomosis. You are usually fastening the anastomosis over the infant feeding tube. Then we are retroperitoneizing the conduit to avoid any herniation. When you are doing laparoscopic surgery, usually people are not doing this step. Yesterday we have not seen this step. So this was the final picture. Thank you.
Excuse me, sir. Sir,
yes.
So in every case you do open or any specific condition in which you do open surgery?
Pardon?
In every case you do open radical cystectomy?
Yeah.
Or any
because I have not seen any advantage, and we have only 1 day robotic for each consultant. So we have got too many cases of radical prostatectomy or partial nephrectomy, where there is real advantage is there. When there is question of whether it is advantageous or not advantageous, we are using robot judiciously in the favor of where there is real advantage is there.
Any questions from audience? Thank you, sir. Now I would like to invite Dr. Kumar Prabhas for his talk. He will speak on immunotherapy in neoadjuvant settings.
Good morning, everyone, and at the outset, I'd like to thank Dr. Gautam for this opportunity. and my topic for presentation is new adjuvant immunotherapy in bladder cancer. And this immunotherapy word, new adjuvant, let's see what happens and what kind of data we have, what we get in the future, that you will be keep hearing for next few decades, because that's the way it has come up in many other tumors. And the way it has changed as far as the kidney cancer is concerned, the outcome, the lung cancer, this is one of those first time when we are seeing that you do have a group of patients living beyond 5 years, melanoma beyond 10 years, which we have not seen in the past. So you will keep hearing this again and again in many settings. But my topic is new adjuvant and bladder cancer, where we at this moment struggle for chemotherapy, because majority of the patient not necessarily is able to take chemotherapy, and that also gives an opportunity that if you're not, do we have an option there? And that's why I start with the need. Why we need for immunotherapy in bladder cancer. So non-invasive, we are absolutely wonderful. Remove it, patient does well. You may have to keep removing it, but patient does well. And then you do have some immunotherapy there also in case the local immunotherapy or chemotherapy fails. But the survival, if you have, the moment you have a muscle invasive tumor, then the survival is poor. T2, we are worried. T3, we are really worried. Lymph node, when I was getting trained, our surgeons used to not operate because it was considered metastatic disease, highlighting that yes, you do have a poor outcome in the moment you have a muscle invasive disease and the moment it goes beyond T3. So with all the treatment available, you require to improve outcome, including chemotherapy and surgery. Second issue, that as I said, almost more than half the patient, and that's primarily because these are elderly patients, and you have a disease in the area where you can have compromised renal function, you are not able to deliver chemotherapy. Highlighting that there's a need where if you have a chemo safe or a renal safe drug, it may be useful. So because of these at least two reasons, immunotherapy is interesting in this setting. Now, what kind of data we have in for neoadjuvant immunotherapy as far as the bladder cancer is concerned? And these are the reasons why one should consider exploring it. Now, data starting with, I'll give one example and then summarize the trials and then the issues. Starting with one of the trials, where immunotherapy was given for cisplatin eligible and ineligible both group of patients, and wherever people were able to take cisplatin, they received it, and they received a drug called pembrolizumab. You have now almost more than around dozen of checkpoint inhibitor. You will keep hearing this name: pembrolizumab, nivolumab, atezolizumab. There are 5 of them in India. There are 5-6 more coming. But ultimately, these are checkpoint inhibitors with a similar kind of approach. What it suggested, and this is on the left-hand side below, that yes, almost half of the patient you can have where you can have pathological complete responses. Suggesting that yes, looks like it does something in this setting. It also shows that if you do have a complete pathological response, the key one is the top curve, what you're saying. What it means that if you're given treatment early, before surgery, and after surgery, if you don't see tumor, majority time, and in fact, by and large, disease doesn't come back. Meaning that out of 100 patients, 95% will survive. They will not die because of disease. They may die because of something else, because they're elderly people, but they will not die because of disease. That is where it is exciting, but also suggesting that you have a good group of patients where you don't receive complete pathological responses. Data in cisplatin ineligible patient. This is one of the study which was done, a phase 2 single arm. So it gives you some hint, and hint remains similar. These were the numbers for the patients and the stages where they were taken, the kind of stages of the patient who were taken, and we'll talk about it, what is the limitation. And this suggests again the kind of patients taken, and again suggesting that almost less than a half of the patient you do have what we call complete pathological responses, and that varies from drug to drug and stage to stage, and we'll talk about it. Again highlighting that if you have pathological complete response, then 85% of the patient, that is the third line here, that they don't die because of disease, they die because of something else. Highlighting having a complete pathological response is important, and this drug does lead to, in a group of patients, complete pathological response, and that's why it becomes interesting. These trials, there are many of them, I'll show in the table, that also shows the issues of these trials. What kind of drug you have taken, and these are showing the 4 kind of drug alone or in combination. Different kind of pathological responses because the combinations they have used is different, the stages they have used are different, and the way they have selected based on a biomarker has been different. And that's the reason it also has a challenge to interpret it completely, but highlighting that yes, in cisplatin ineligible patient also you give this drug, and you do have a group of patients who has complete pathological response. This is a summary slide for whatever has happened in neoadjuvant setting for immunotherapy. What I'll do is, I won't dwell, but I'll summarize. What it suggests, all these trials, what I started with, that if you give immunotherapy alone, you do get complete pathological response, that makes it attractive. You add with chemotherapy, then you do have complete pathological responses. And in that setting, it looks, if you alone compare with chemotherapy, it is not very higher. So first one, attractive because you are not able to give anything. Second one may be useful because you want to see that if you give immunotherapy, because immunotherapy is supposed to have control of disease for a longer period, what we have seen in lung cancer, what we have seen in melanoma and other cancers, hopefully it does it here. That is the overall summary for what we have this data here for. These are ongoing trials. Idea is that can we spare surgery? And this is one of the study done which suggests yes, in short term, looks like if you give immunotherapy, CR, follow them up only, some of the patient fails, rest can go continue without disease coming back. So looks like there is some hint that you can spare or preserve organ, which my colleague will be talking subsequently. There can be another way, potential of preserving organ. Pathological response rate, which I suggested, it is around less than a half, depending upon you giving chemotherapy or not, alone immunotherapy or double immunotherapy. That tells you what kind of pathological responses you have. So that is a bit of a less than half. Survival outcome in short term, 2-year overall survival data of 75% and 80% looks attractive, but again in the short term, again it is phase 2 trial. Biomarker, you have various of them. You have genetic sequencing, you have a PD-L1, CD8, many of those markers. Apart from PD-L1, as on date, we don't have any other biomarker which can predict what we are going to do to these patients based on biomarker. At this moment, only PD-L1, that's the only biomarker which has been useful. Compliance, if you give neoadjuvant immunotherapy, what happens to compliance? Looks like it is good, majority of them they receive it. What happens to surgical complications? Because these are the issue the moment you use any treatment neoadjuvant setting. Looks like surgical complications are similar what we have seen previously with neoadjuvant chemotherapy or with only surgery. What are the grade 3 adverse event when you are given immunotherapy in bladder cancer? Is it different? Looks like it is similar what you have seen in any other disease where the immunotherapy has been given as far as immune related adverse event is concerned. For chemoimmunotherapy, toxicity is a bit higher than only immunotherapy, but that's again expected. Again, data looks similar to what we had earlier. Last, I'll take 10 seconds. Monotherapy and chemotherapy plus immunotherapy looks like responses higher with chemoimmunotherapy, but chemoimmunotherapy as compared to chemotherapy, not necessarily responses are higher. Could be responses can be sustained. So in conclusion, neoadjuvant immunotherapy is a promising approach for bladder cancer management, and you will hear a lot as we go by in next few years. Thank you so much.
Thank you very much for nice overview on your adjuvant therapy. Sir?
Any question? Yes, sir. Question can be asked?
Yeah. Go ahead, Ibrahim.
Hi, Kumar.
Hi.
Wonderful presentation. So my question is that do you advise immunotherapy for only PD-1 positive patients or all comers?
So in today's time, for metastatic setting, it's all comer where we advise. In adjuvant setting, it is preferably for PDL1 positive patient. That data looks very strong. Update came recently. I'm sure many of you would have gone to European meeting, and it is, if you take, is 10 months versus 57 months. So there one, if you have to select it, then choose it based on PDL1. But data is also positive for anyone coming over. Neoadjuvant setting, this is the way to select, but people are exploring both ways.
Fine. So now, how many cycles you give before surgery?
So if you have to give, it looks like they have given 2 to 3 cycles, so it will look like same kind of the way we have given chemotherapy. Usually they won't overstep it. There is a data in lung cancer that giving beyond neoadjuvant for few more months it is useful, but that is also iffy at this moment. So at this moment they will people will develop it based on neoadjuvant chemotherapy rather than extend.
Yeah, in last European meeting, as you told, there were a lot of hue and cry about post chemo not eligible, patients being ineligible for surgery for at least 3 to 4 months. They're taking more time. So that is the reason. So they told to explore the immunotherapy pre-operatively rather than giving chemotherapy. So especially for patients with PT2 tumors, it may not be for the T3 and T4. So that is the reason I think immunotherapy is becoming a very promising approach. I think in future, but at this point, can we advise our patients to take this immunotherapy outside the clinical trials?
So at this moment, message will be no. In selected patient, for example, if you have a T3N2 disease and you are not fit for chemotherapy, most likely you won't be taking up for surgery.
Right.
Then you do have a chance that if they have a good response, subsequently you can take it for surgery. Just now we did for esophageal cancer.
Yeah.
It was a lot of lymph node. My surgeon was not keen, and they have taken immunotherapy. When they have done surgery, there is no tumor. Not sure there's a right approach, but these are things we extrapolate. So run of the mill, T3N0, today immunotherapy, definitely no.
Thank you.
Thank you very much, sir.
Yeah.
Go ahead, sir.
Is there a protocol in which we use neoadjuvant immunotherapy followed by cystectomy and then follow it with only immunotherapy and not chemotherapy in PDL1 positive?
So at this moment, routine care, no. As a part of protocol where we can developing it, yes. Because one of the challenges only for neoadjuvant is that if you give only 3 and leave it, looks like you require some more push for the immune cells to be active.
Yes.
So in lung cancer, yes, that data is there that you give this called Nadim 2 trial. Anyone can Google it, where it was given for 3 cycles, then 6 months immunotherapy was given later on. That will be explored, but I'm not saying that is the way to do it.
But what was done in these?
These were all only neoadjuvant. These was all window of opportunity trial. So what people were looking, do we get pathological responses or not? That was the kind of trial with whatever I showed.
So many of these patients might have been followed with post-operative chemotherapy.
Not necessarily. Oh, these are all neoadjuvant immunotherapy or neoadjuvant chemotherapy plus immunotherapy. Followed by surgery, they have not been given anything unless they didn't receive it earlier than in adjuvant setting.
Thank you.
Thank you, sir, for wonderful presentation.
Thank you, chairpersons and speakers, for a great session. I would request you to please move towards the right side of the auditorium for a group photograph and mementos. For the next session, I would like to call upon stage Dr. Abhinandan, Consultant Urologist, Gurgaon, Dr. Sandeep Noonia, Consultant Urologist, Jaipur, Dr. Shanky Singh, Assistant Professor in Urology, PGI, Chandigarh, and Dr. Devendra Pal, Consultant Urologist in Jaipur.
Hello. The next speaker is Dr. Gargi. She will explain and teach us regarding the role of radiation oncologist in management of CAU.
Good morning, everyone. Thank you for having me here. So today I'll be discussing the role of radiation in bladder cancers. So broadly, we can divide where we use radiation into these three parts. First is in the setting of definitive radiation, where we do organ preservation. Next, two are emerging roles, where we are exploring the use of adjuvant radiation post-radical cystectomy, and the small role in high-risk and very high-risk non-muscle invasive tumor. So how do we select patients for radiation? Broadly, we divided them into tumor-related, patient-related, and treatment-related factors. So coming to the tumor, stage 2 and 3A tumors, which are unifocal and with a relatively small size, respond well to radiation. However, patients who have baseline hydronephrosis, extensive CIS, and for some reason may not be able to have an complete URVT, they don't do as well. Coming to the patient, patient needs to have a functional bladder, and they need to be motivated and reliable for regular follow-up, which is in the form of regular cystoscopies, urine cytologies, and a urine routine to look for microscopic hematuria. And lastly, we come to what is the technique of radiation that we have. So available of modern techniques in the form of intensity modulation and image guidance, which allows for adaptive radiotherapy. So these reduce the toxicities of radiation, and we can deliver it accurately and safely. These are the factors we consider, but as we are evolving, we are seeing that there is no absolute contraindication to bladder preservation, and it no longer need be restricted to unfit patients. So, trimodality therapy, it forms the cornerstone of bladder preservation, and it consists of a TURBT followed by chemoradiation to the bladder. Now we see that there are tendency to improve outcomes with the addition of NACT, and it should be considered in most patients who can undergo it. NACT is usually in the form of 2 to 3 cycles gemcitabine cisplatin, and with concurrent chemotherapy usually weekly gemcitabine or cisplatin. We've seen that continuous radiation is better than split course radiation. So split course radiation is where we do an interim cystoscopy mid-treatment, and we divide patients with poor response to go ahead and receive cystectomy. But it has been seen that with continuous RT, rates of bladder preservation are better, and with similar disease-free and overall survival. So what all do we treat? Our RT volumes consist of the bladder and the pelvic lymph nodes up to the common iliacs, and the prostate is treated in case of the prostatic involvement or tumors in the bladder base. The radiation dose is 55 gray in 20 fractions, which is delivered over 4 weeks. And as I said before, adaptive image-guided IMRT would be the best possible option. So, how has bladder preservation compared with surgery? We really don't have any randomized data. This is the only randomized trial, SPARE, which was a multicentric trial in the UK, which attempted to randomize patients to bladder preservation and cystectomy. Unfortunately, the trial had to be closed early because of very slow accrual, and also patients, around 24% of patients who were randomized to cystectomy ultimately ended up receiving radiotherapy. However, we do have a large amount of good systematic review and meta-analysis data from meta-analysis, one of which I've put here. So this analysis consisted of 8 studies with nearly 9,500 patients, and as we can see from this forest plots, the OS, DSS and PFS, they were non-inferior with radiotherapy. So what is the radiotherapy workflow in short? It consists of simulation, contouring and planning, where simulation is a CT scan we take for planning. The patient is placed in the treatment position. As you can see here, we have delineated the bladder, and upper 2 volumes that we see, those are the adaptive volumes which we take, because the bladder is a distensible organ and there are differential volumes fillings day to day. After that, we do something called as planning, where we simulate the dose distribution and take the best possible dose where the toxicities would be minimum and the tumor gets the best possible dose. Coming to adjuvant radiotherapy, rather than emerging, it is a re-emerging role because earlier series of patients, though they showed improvement in terms of outcomes, there were unacceptably high rates of bowel toxicity. So this indication has gained a revival due to modern radiotherapy techniques, and its role in squamous carcinomas is more or less established. However, its role in urothelial cancers is still evolving. So this is a large randomized trial with T3 and above bladder cancers, of which 80% patients were squamous. And as you can see from this Kaplan-Meier curves, there was significant improvement in local control and in DFS with the addition of radiotherapy. So why do we need radiation in urothelial cancers? There have been various CRISP models. Of the two here, we can see that once the patient has locally advanced disease T3 and T4 with lymph node positivity, the outcomes are very dismal. Similarly, from this SWOG 8710 trial, they saw that patients with T3 positive margins or an incomplete or a suboptimal lymph node yield had poorer outcomes. This is another study from our institute where we analyzed our patients to see the patterns of local regional recurrence in patients who have undergone cystectomy. So basically the takeaways from this study were that there were a significant number of patients who had a recurrence in the common iliac nodes, which may or may not have been included in the surgical template. Another thing is a significant number of patients had a recurrence in the cystectomy bed itself, even though they did not have a positive margin. So this is currently a randomized trial that we are running where we take locally advanced urothelial bladder cancers and we are randomizing them to adjuvant RT and observation post-surgery plus or minus chemotherapy. So toxicity has always been a concern with adjuvant radiotherapy. So on the right, we can see the radiation volumes which are actually treating. The red above is what we treat in the cystectomy bed, and below is in the red is what we see is our lymph node portals. So what we usually do is we put diluted contrast in the ileal conduit so that it can be well delineated, and we preferentially underdose those areas. Coming to NMIBC, there is a small indication where patients with high risk and very high risk NMIBCs who may not want to undergo cystectomy are given radiation. So as we can see here, there's a respectable cystectomy free survival of 88%. However, the acute toxicities are quite high. So thank you. I'll take questions.
Thank you, Dr. Gargi. Do you have any questions?
So ma'am, my basic question like a novice to you is, when do you consider a patient cured post chemo RT bladder sparing protocols, and when do you advise them salvage cystectomy?
So we keep them on regular follow-up with a 3-monthly cystoscopy, at least for the first 2 years, and similarly along with that we do a urine cytology and 6-monthly cross-sectional imaging. So if we see that there are any suspicious areas on cystoscopy, the patient undergoes a TURBT, and in case of a recurrence, we send them for salvage cystectomy.
So would the recurrence be a high grade that would prompt a salvage cystectomy recommendation, or even a low grade recurrence would?
Usually a high grade recurrence. If it is still low grade, we would again consider some intravesical therapy and try to save the bladder.
And would it be something like within first 3 months, 6 months, you believe that it's a residual tumor and you do not recommend a salvage cystectomy? Or is it that any recurrence entails a recommendation for salvage cystectomy?
So usually the patients who are selected, they most likely have a complete TURBT. So we don't really see cases with residual tumors. And it's like
so I mean, like I'll give you a situation. The complete TURBT is done, you're given a radiotherapy. On first 3 months cystoscopy, a biopsy from base shows tumor over there. So how would you handle such a scenario?
So the tumor being present histologically 3 months post RT, that is not a good indicator. So this patient, I would like to go ahead with the cystectomy.
But still, if it's a low grade, would you still think of something different, or it's a salvage cystectomy even with a low grade?
Yeah, so like I said, with low grade, we can still try to preserve the bladder. But if it is a high grade tumor, definitely the patient should go for cystectomy.
Thank you.
I have one question. Please.
Thank you. Ma'am, excellent presentation. I'm Dr. Sivaramakrishna.
Hello, sir.
I have maybe it's a silly question, but what's your opinion about brachytherapy in carcinoma bladder, especially with respect to NMIBC and whatever residual tumor is there?
So I don't think that is a good idea, especially where we now have EBRT techniques where we achieve excellent control and very minimal toxicities.
This was only, my peers are telling me it was a silly question to ask.
No, no.
But this was basically a medical student question.
Yes, sir.
In the thought process, are we going to avoid any intestinal toxicity?
Okay.
Will that be a good research idea to look at?
Sorry, sir, I didn't get you.
Good morning.
Good
In your
morning.
presentation, you just said that in a study there was poor accrual of patients.
Yes.
So, what were the reasons? Probably ethical reasons or inefficiency of treatment?
No, there were many reasons actually. There were, main is the doctor and patient preferences for certain treatments. Like doctors were hesitant to go ahead and give patients the option of radiation. On the other hand, patients, even once they were randomized, were given the option of refusing cystectomy and going for bladder preservation, which around 24% patients did. So that is what
randomization was given to the patients. But we know that trimodal therapy is on one way and the surgery is on other way.
Yes.
So I think there are some ethical concerns in that study. That's why that study was probably carried out in UK, I think, if I remember.
No, there were no ethical concerns as such.
Okay.
It was a IRB approved study, and we have prospective data which is non-randomized, which does show us that bladder preservation is safe and it does give decent outcomes.
Thank you.
Thank you, Dr. Gargi.
Thank you.
Now we move on to, if there is no other question, now we move on to the next speaker, Dr. Uday Pratap Singh. The topic is tips and tricks of neobladder creation. Do different configurations of neobladder affect the outcomes?
Good morning everybody. Till Dr. Uday starts his session, may I request all the speakers to kindly stick to the time, because most of the delegates have a flight scheduled at around about 2ish. So the chairpersons, you are kindly requested to stick to the time schedule. We will have to make up the whatever time we are going behind. So limit the number of questions, please. Thank you.
Good morning everybody. My presentation is on the tips and tricks of new bladder creation and do different configuration of new bladder affect the outcomes. So these are the different kinds of new bladder of imaging. Can you guess which kind of new bladder are these? Maybe Hartmann, Gonim, AIP and Studer. So I will give the answer at the end of my presentation. So after getting this thing, radial cystectomy, so we have options of doing the urine diversion, which can be like incontinent diversions and maybe continent diversions. So I'm talking about the orthotopic new bladder. So what are the surgical principles? So we have to create a low pressure reservoir. So to create a low pressure reservoir, we need to make a pouch in the spherical configuration. So we need to detubulize the bowel so that we can create a low pressure reservoir so that it can protect the upper tracts and optimize continence. So there are different types of new bladders, which may be purely allele new bladders, some may be purely colonic, some may have both the allele and colonic segments. The most common, if you see worldwide, the Gonims, Hartmanns, Studers, and BIP are made. So what are the difference between these more commonly made new bladders like Studers, Hotmans and Gonim? You can see the segment of bowel is more with the Hotman and less with the Gonim, only 40 centimeter segment. And you can see the configuration. The Studer has actually U-shaped configuration, the rest of both Hotman and Gonim has W-shaped configuration. So the only Gonim has the non-reflexing kind of ureteroanastomosis as compared to the both the Studer and Hotman have a reflexing kind of anastomosis. So the advantage of making the Studer is that it can be done with the short segment of the ureter actually, but that requires long chimney, so it's difficult to do the upper tract surveillance later on. And on the other hand, if you see Gonim, so upper tract ureteroscopy or upper tract surveillance is very easy, but it requires long ureter. And in Hotman, actually, you take long segment of bowel. So early continence is good, but in late they present with the urinary retention and metabolic acidosis. So this is a debatable thing whether you make a non-reflexing or reflexing. So if you say non-reflexing, so it prevents the ascending bacteria actually, and it protects the upper tract. So generally I prefer non-reflexing kind of anastomosis, which is done in the Gonim. So these are the surgical techniques. So it starts from the radical cystectomy when you are doing radical cystectomy and how to do a orthotopic new bladder. So this is a video. So you have to be very careful when you are doing the apical dissection. So you try to preserve the length of the urethra actually, and even 4 or 5 mm more urethra you can preserve in the groove of the prostate. So it creates the better continence. And try not to injure the nerves around that area or sphincter to preserve the continence. And then you have to take the sutures actually. So on the left side you can take outside in, on or right side you can take inside out. So it's become very easy to take 6 to 8 sutures. And then you can cover with this with the clothes, and then you can transpose this left ureter to the right side below the sigmoid. And in female, it's very essential to prevent the hypercontinence actually. What happens in females, most of the patients they went into retention because of the hypercontinence, because of sagging of the bladder. So generally we fix this vault with the round ligaments, and then you have to put a lot of momentum behind the new bladder so that it doesn't cause sagging of the new bladder. So you can take a lot of momentum and then just put it inside the pelvic cavity to fill that pelvic cavity. So how to create a new bladder? I'm here describing the technique of making the Gonim. So you have to make a W shape, then you just join the both lateral limbs and detuberize and close it. And this is the video of how to make it. You have to take a 40 centimeter segment, 25 centimeter proximal to the ileocecal junction. You isolate that 40 centimeter bowel segment, and I generally use the ligature actually. So you can need to tie each and every mesenteric vessel. You configure it into W shape, restore the bowel continuity, and then you have to create the troughs. So you just join this lateral limbs of the bowel and with the silk 30, and then just detuberize you will get the two troughs actually to implant both the ureter. And then you can join the medial plates after detonarization. So you have the two troughs after joining the medial plates. And both ureter you can see inside that trough, and you can anastomosis over the 6 times DJ stent. Here are the DJ stents. And then you can fold the ileal plates, and most dependent part you can anastomize with the urethra. And what do you just do in the urethroplasty? Just you have to orient all the sutures according to that, and you can take a urethrovesical anastomosis. I generally tie this stent with the SPC. So later on, when you are removing the SPC, it will come out these things. You need not to do any cystoscopy. And it can be done with a robot also. So I generally make a very simple St. Augustine white type new bladder. And this was done in the female patients. Radiocystectomy being done, and with the Da Vinci robot. And the specimen can be viewed through the vaginal stem, and then you can suture this vaginal stem, and then you have to isolate the 40 centimeter segment. And I did not use any stapler in this particular patient, so I just did what I do in the open also. So I just isolated and sutured with the simple suture, and I did not use any kind of a stapler in this patient. So this is the bowel anastomosis. So most of the video you will find only the stapler actually. So I have never find any kind of any surgeons doing this kind of anastomosis. So at 20 centimeter you can fix the urethra, you can do the urethropneumocystic anastomosis. So it's fixed the actually your mid part of the 40 centimeter segment of bowel. Then you have to detonatorize, and then you have to suture the medial plates. And then you can fold itself, and then you can suture the lateral aspect also. It's a very simple kind of new bladder.
Dr. Uday, can you wind up, please?
Okay. Just 1 minute. So this is right anastomosis, then we put the SPC and the left anastomosis. So you can finish it up. And the most important thing is the post-operative care actually. So these patients, they require frequent bladder wash actually. And after 3 weeks, you can remove the SPC with the DG stent. And you have to teach them the time voiding actually. So every 2 to 3 hours in the day, they have to void, and in night 3 to 4 hours actually. So until the bladder gets normal capacity, so they have to teach this time voiding. So I have this, because of the videos, presentation very actually long. So if you want, I can wind it up here. So the advantage with the Gonim is that you can do the upper tract ureteroscopy later on. So because both of the ureter in the posterior, and just like in normal orientation. These are the voiding patterns. So daytime continence is around 85 to 98%. Nighttime at 1 year can reach up to 95% patients. Hypercontinence more common in the females. So never try to make a long bowel segment actually to create a long urethra. Otherwise it can cause kinking and can cause the hypercontinence. Urethral recurrence is around 2 to 5%. and you have to take care of vitamin B12 deficiency. So you have to get it done frequently after 1 or 2 years. And metabolic exercise also you have to take care. You have to give vitamin and D3.
Please come to the conclusion, sir.
Okay, this is last slide. So till date, I have done around 81 open radical cystectomy and ONB, and around 4 roboticectomy. So thank you. So, is there any question?
Any question, please?
Question. In all these procedures, whatever you demonstrated is okay, but what we do is we use the distal segment of the ureter 1 centimeter to anastomose to the urethra, and rest of the procedure is just like other procedures. The non-reflexing anastomosis to the proximal end of the ureter.
You make Studer. You are talking about the Studer?
No, it is modified Studer that we use the distal end of the ileum to anastomose to the urethra, just 1 centimeter. Okay, so it is like this. Have you any experience in that? We have 10 patients and they are fully continent.
Okay. Any questions?
Any other questions? And thank you, Dr. Uday, for your nice presentation.
Thank you.
We'd like to move on to the next speaker, Dr. Ishwar. Dr. Ishwar, the topic is IRAS protocol in Indian setting.
Good morning. My topic of presentation is IRAS Enhanced Recovery After Surgery Protocol in Indian Setting. So I will give more emphasis to post-radical cystectomy. Professor Henrik Kehelet in 1990 put that concept of IRAS, and now it has become part and parcel of colorectal surgeries, vascular surgeries, thoracic surgeries, and in urology, especially radical cystectomy. The purpose of IRAS protocol is to modify the physiological and psychological responses to major surgery. This leads to reduction in complications and hospital stay, improvements in cardiopulmonary function. Patients have earlier return to bowel function, and there is earlier resumption of normal activities. What are the key principles? First of all, we have to counsel the patient about the surgery and the post-operative outcomes. We give more emphasis for pre-operative nutrition because most of these radical surgery patients are poorly nourished, they have low albumin, they are thin, they are cachectic, so we have to build up the patients. Then the concept of bowel preparation and liquid diet 1 day before, I think that is a part of past now. So we have to avoid perioperative fasting. Nowadays, in many centers where IRAS protocol is followed, they give liquids up to 2 hours before surgery. Free of carbohydrate loading is also to make the patients withstand this major surgery. Standardized anesthetic and analgesic regimens that includes epidural and non-opioid analgesics and earlier mobilization of patients. So there are components of IRAS protocol: pre-operative, intraoperative, and post-operative. Pre-operative, we have to counsel the patients. We tell them about the surgery and its implications, post-operative outcomes. Fluid and carbohydrate loading is recommended. There is no prolonged fasting as it has been done in the past. Non-selective bowel preparations, antibiotic prophylaxis to prevent deep vein thrombosis, prophylaxis, and no pre-medications. Then intraoperative, there are short-acting anesthetic agents are promoted in such patients. Mid-thoracic epidural anesthesia to give post-operative pain relief. no drains, especially if you are quite confident about your surgery, avoidance of salt and water overload, and maintenance of normothermia, body warmers, warm intravenous fluids. Post-operatively, analgesia, avoidance of rice tubes, prevention of post-operative nausea and vomiting, avoidance of salt and water overload, early removal of catheters, early nutrition, non-opioid analgesics and NSAIDs, early mobilization of the patient, especially on the first or second post-op day. We promote stimulation of gut motility. If the patient has some kind of bowel sounds, then we promote early liquid feeding and audit of compliance and outcomes. So, day before radical cystectomy, patient should have a normal breakfast. Patient is admitted. Unrestricted clear fluids are recommended. Dietitian consultation is taken about the nutrition of the patient. Stoma therapist sees the patient and assess social circumstances and refer if needed. On the day of first surgery, clear carbohydrate drinks up to 2 hours before surgery are recommended, then nil by mouth. As surgery is done, we start clear liquids as early as possible. Start food chart, epidural analgesics because post-operative pain relief is very important. On day 1, fluids are recommended as the patient is tolerating. Female patients, vaginal pack is removed. We encourage patients for early mobilization. Antacids are recommended. Drains are early removal of drains if their output is minimal. And in cases of neobladders, flushing of neobladders is started twice hourly for 12 hours, then 4 times hourly. On day 2, light diet as tolerated. If patient has gut motility, bowel sounds, then light diet is recommended. We mobilize the patients and we also encourage patients to take care of themselves about especially catheters and neobladder flushing and all these things. On day 3, if patient is totally mobilized, then we remove epidurals and continue and mobilize the patient. Light diet is recommended. And if the patient is tolerating all those things, then patient may be discharged. On day 5, 6, 7, dietitian assess nutritional requirements of the patient. If some patients, they are not having early gut motility. In such patients, we have to assess their bowel activity, and if there is no bowel activity, then we have to put rice tubes in such patients or maintain the rice tube, and accordingly clear liquids are recommended. If the patients are not tolerating, then we have to put such patients on total parenteral nutrition. We have to remove sutures on day 10 and stents on day 8, and on 11th day most of the patients go home if they do fine according to the protocol. So about preoperative nutrition, if proper nutrition is there, complication rates can be reduced. And if patients are poorly nutrition, there are 3 markers to assess the pre-op nutrition. If patient has more than 10 to 15% weight loss in last 6 months, if the patient's body mass index is less than 18.5 kilogram per meter square, and most importantly, if the patient's serum albumin is less than 3, then in such cases, patients we can predict that they might have poor post-operative outcomes. So there are ESPN practical guidelines for clinical nutrition in such patients. Preoperatively, fasting is not recommended. Earlier we used to put patients on fasting day before and clear liquids. Now they recommend that you give pre-operative carbohydrate loading up to 2 hours before the surgeries, and post-operatively, as per patient behavior, if they have good bowel motility, then we increase liquids in recovery period, removal of drains and catheters, proper analgesia, so that patients may have a faster recovery. As per if there are population of patients we are high risk, such as more than 10% of body weight loss in last 2 months, or BMI less than 18.5 kilogram per meter square, or albumin less than 3, in such patients, we have to postpone. Ideally, we should postpone surgery in such class of patients, and we should build up this patient or a kind of surgical rehabilitation so that they can withstand this major surgery. So ESPN recommends that in such patients, you have to build up the patients. If the albumin is low, then we have to build up albumin and make them more. So benefits of carbohydrate loading, it decreases, attenuates post-operative insulin resistance, reduces nitrogen protein losses, reduces muscle mass, reduces pre-operative thirst, hunger and anxiety, facilitates accelerated recovery through early return of bowel function, and patient goes home earlier. Bowel preparation, the aim of bowel preparation is to get rid of large bowl of solid fecal contents to lower the bacterial load, thereby reducing the incidence of post-op complications. Aziz in 1972 originally questioned mechanical bowel preparation, concluded vigorous mechanical bowel preparation is unnecessary. So Safi and colleagues conducted a retrospective study assessing no bowel preparation versus bowel preparation, and they found that there was higher incidence of post-operative ileus, slower commencement of diet, greater risk of wound dehiscence, and longer hospital stay in patients who received a vigorous bowel preparation. Post-operative nutrition. Post-operative nutrition is we should encourage early post-operative liquids, and especially the albumin. We should see the patient's albumin. We should build up the albumin. Or if the patients are not tolerating diets, then we have to put them on TPN. Then continuing the caloric requirement at discharge, the dietitian, the role of dietitian and the stomach therapist is very important. The surgeon goes on the backside, and those are the people who manage such patients about their dietary requirements and post-operative recovery. So, tube feeding is recommended if patients are not having early bowel of recovery. So you may have a question that most of the patients we put a Rice tube and they don't tolerate such feed. So we have to individualize the patients. Some patients have early bowel activity. In such patients, we can start early nutrition, especially starting from clear liquids, and if patient tolerates, then we can expedite patient's post-operative course. So in radical cystectomy, I think we are running short of time. So
please come to the conclusion, sir.
The conclusion is basically that we preoperatively we shoot the patient and see his or her build up any weight loss, BMI or albumin. There are three criteria. If this patient fulfills these criteria, then we should have such patient for ERAS protocol, and such patients have an early recovery if follow the preoperative, intraoperative and postoperative guidelines as we have mentioned in this. So there is an Indian study. The study is carried out in Aiims and Max hospitals. They randomized study, and they showed that if you follow ERAS protocol, the onset of bowel movements and early passing of flatus and stool is statistically significant if we follow the ERAS protocol in such patients. And the complications rates are also low if you follow that. According to this study, the Cleveland grade of class complications are low in such patients. So the conclusion in the study shows that ERAS protocol leads to faster bowel recovery compared to our conventional care in patients younger than 75 years and with good performance status, but fails to demonstrate a shorter length of stay and lower complication. Thank you.
Thank you. Do you have any questions? Thank you, sir. Thank you.
Thank you.
Thank you for an enlightening session. I request all the chairpersons and the speakers to proceed to the right side for a group photograph and to collect their mementos. The next session is an ISU session for Beyond the Landscape in Urothelial Cancer. And I invite Dr. Ashwin Tamankar, consultant urologist at Apollo Hospital, Navi Mumbai, to give his opening remarks.
Good morning all and welcome on behalf of ISU. We are running ahead of time, so without wasting further time, what we decided that it's a 1 hour session. The entire thing is going to be covered in the conference. Fantastic organization to the organizing team. So we decided we'll have some different topics on different notes, and we have the plethora of stalwart speakers. So we will, without further ado, we'll start with inviting the chairpersons.
I call upon stage Dr. K.K. Sharma, Chairman KKS Urology Hospital, Jaipur. Dr. Kamaljeet Singh Sir, Senior Consultant Urologist from Amritsar. Dr. Manish Chaudhary, Senior Consultant Urologist from Faridabad. Dr. Aaron Jain, Senior Consultant Urologist from Alwar. Dr. Deepak Ranjan, Consultant Urologist from Yashoda Hospital, Sikandrabad.
So it gives me privilege to invite our first speaker, Dr. Sudhir Rawal sir. He's the director Rajiv Gandhi Cancer Institute and stalwart of uro-oncology and father figure for all of us. So over to you, sir.
Thank you, Ashwin, and thanks Gautam and other organizers for inviting me to city of Jodhpur, this is second visit in Aims. First was I came here long back when Himanshu called me to do one surgery. And it is always an incentive for me to be in this place because my sister lives nearby, not very far from here. And Ashwin gave me the different topic like brainstorming for research titles in bladder cancer. And when I thought of, I can think of one thing which probably is not possible in my lifetime or maybe in future also, that we can have a one drug, oral drug, which works in non-muscle invasive, muscle invasive and metastatic locally advanced urothelial cancer, and also in variant histopathology, which is not going to happen. What is there in these segment of the bladder cancer, I'm going to tell you in brief because time is less. And what we are involved in a few of them we have involved in. In this country, we hardly have any research, basic drugs coming for trial and other things. You know that 75% of the patients are of bladder cancer and NMIBC, TA, CIS, T1. And for low grade, there is hardly anything is required. It's indolent disease, it recurs, you can burn it, and then the patient can have mitomycin C, and most of the time they do fairly well. But even then, in that segment, there is a mitomycin C gel is available, especially for low grade upper tract tumor, which is marketed by Olympus. It's not there, but we did trial long back for this in bladder cancer, recurrent low grade bladder cancer. As far as high risk, this is a big problem, especially T1. 30% of these diseases are BCG unresponsive, and then they are BCG intolerant, and there is BCG shortage, not in this country, but in other countries. There is so much BCG shortage that they are now doing the trial, alternating BCG and mitomycin C so that they can reduce the use of BCG. I saw recently a trial in EAU Milan. The high risk progression and metastasis will occur in the patient who are unresponsive unless you operate them early. The current issue is that the radical cystectomy remains gold standard treatment for BCG unresponsive patient, but then it is probably associated with morbidity and other changes in the quality of life. And that is why there is a lot of trials in this segment where you can avoid cystectomy and you can preserve the bladder. You can see there are so many things available: valrubicin, gemcitabine, mitomycin C, gemdosi, cabazitaxel, gemcis, and there are other things. In this segment, they all have been tried and they have variegated response. It's not that they are one drug is very good or one combination is absolutely outsmart other combinations. And then these are other salvage therapy, BCG interferon. This has been tried, and there are the thing which has come is now is pembrolizumab. And this is given IV in the patients who actually fail BCG, and this is FDA approved treatment as far as today is concerned. There are adaptive immune resistant in the intravesical BCG in non-muscle invasive bladder cancer, and this has actually has been exploited to treat these patients, and that is why because of this molecular mechanism, this leads to CD8 exhaustion and failed recruitment of the CD4 T cell, and that is why there is a recurrence and the progression. For that, there are 3 trials which have been used, which are there, which is one of them is FDA approved drug, epemzurulumab. The other trial which is going is S1605, where atezolizumab is being used in these patients, is given every 3 weeks to see the complete response or disease-free survival. Then there is an adopt bladder trial where these patients are divided in 3 cohorts. One patient will receive durvalumab with BCG, other has received durvalumab with EBRT, and another cohort is BCG. And if there is a residual NMI-BC after BCG, patient goes on durvalumab. I'll just go in detail of these trials. Keynote 057, it's already established. I'll not go in detail of this. Pemzolizumab is FDA approved, and these are the data because of which pemzolizumab was FDA approved in January 20, especially in patients who are responsive to BCG. But the problem with pemzolizumab is that it is not especially in the patient who has got CIS, the response does not last for a long time. They fail. While in papillary, they actually last for a long time, 43.5% response, at which lasts for a long time. So it doesn't work that well if the patient has got CIS. Durvalumab, I will talk about durvalumab in combination with BCG and external beam radiotherapy, and they have shown when you combine durvalumab with BCG, the response is very good, 85%, and 12-month response is 73%, followed by, if it is combined with radiotherapy, that is 6 grays of radiotherapy in 3 cycles given to the patients. There is another drugs which are there in this segment is N805, and they have a molecular mechanism because through interleukin 15 N72D, interleukin 5-15R alpha, and IgG1-Fc. This drugs, this is a cytokinin agonist, and this works actually on the molecular level so that you can enhance the immunity in the bladder mucosa, because BCG, what happens with BCG, once you give the NK cell or T cell, they comes down after some time. While if you add with N803, there is a lot of infiltration of these cells and they survive for a long time. And this is the study which has been done, which is going on. This is a study schema, cohort A against with CIS, cohort with papillary tumor, and then you can see the primary endpoint are to see the biopsy confirm complete response, and if you can avoid the cystectomy or duration of complete response, serious adverse event, immune adverse event has to be seen. The final conclusion of N803 with BCG is that there is a 99% bladder cancer specific overall survival for 2 years with this combination. Cystectomy was avoided in over 90% of the patient with 2 years, and the efficacy and safety profile of N803 and BCG exceeds that of other available intravesical systemic option for the BCG unresponsive NMI-BC. Probably this may be the game changer in future, but right now we do not have. Then one can add virus with immunotherapy, interferon alpha, and you can treat this recurrent disease. It is called as immunogene therapy, where virus actually acts as a carrier for drug, and this increases the dose delivery into the mucosa so that the patient can have the very better effect. Then these are other drugs which I have already talked about, pemzolizumab, atezolizumab. They have the effect, but not a great effect, but still they do have 40 to 41% or maybe 53%. This is there, but then it's very costly. Probably I don't think I'll be using this drug in my practice at all. Then there are unresponsive this is BCG unresponsive. There is alternative trial going on. This is an oral tablet, but the patient has to have the FGFR mutation. Since the time is less, I'll just go in skip few slides. MIBC, you heard in the morning that there is not only chemotherapy but also the immunotherapy is coming. But problem with MIBC, NACT is that the NACT works best when it is T2 disease. If it is T3, T4 disease, this will be actually suboptimal response. And in T2A disease, which you can diagnose on patients after TURBT, when you do PET scan and there is no residual uptake in the bladder, these patients probably will do equally better with the surgery alone rather than adding an NACT in these patients. And moreover, there are biomarkers are there which are not very good and as of today. So that treatment remains not very acceptable to the urologist, but we in our practice have increased the use of NACT in Rajiv Gandhi Cancer Hospital. Immunotherapy, I think I will not go in detail. In morning there was a talk by Kumar Prabhash who has already told you. But if you see the pathological complete response in muscle invasive bladder cancer remains below 50% no matter what combination you use. You use GEM-CES, you use immunotherapy, you use anything, it is less than 50%. And then you have to weigh how the patient has to be treated. Then there is cis-ineligible and cis-eligible patient, where these trials are going about IO plus new drug, surgery, chemo, IO, and there are so many trials are going in this field. Again, there is not a single biomarker which actually, this is the study which says that there is a study failed to show any value of other previously useful biomarkers, and only the biomarkers, they said ERCC2 was found to be predictive. There is a debate again, there is a PDL1 in the morning has been talked, but then what we can say, there is not a very good biomarker for these patients which as on today can be used in practice as we use as PSA. These are different other biomarkers which are being used. Then there is a EV, this is another kid in the block, new kid in the block, you will say this is ADC. This is an antibody drug conjugate where antibody has a nectin-4 drug which is delivered into the cell, a high dose in the cell, and this actually has been tried in now the trial going on a new adjuvant setting. But in LABC, locally advanced bladder cancer and metastatic bladder cancer, this is second line drug, which you can see in my slide. This LABC and metastatic is not curable. Surgery hardly has a role. There are many options, but only thing which probably has actually proved as of now is Avlumab maintenance therapy, which gives very good results in these patients. But EV is second line drug, and there is another ADC which I will be showing in my next slide. This EV is enfortumab vedotin. It actually has a nectin-4 which goes inside the cell when it goes to the endosome and lysosome and kills the cell. Then this has been tried post chemo, and it has been FDA approved and is marketed by Estella. Estella is now already, this drug is in the market. This was you can see the trial data where it was better than best supportive care or chemotherapy of choice. Last few slides. This is another ADC. This is Goviactin, where you actually deliver the irinotecan inside the cell in place of nectin-4, and this will also work in the same way. So with that, I'll just show these are the guidelines for second line therapy. This is still the miserable state of patient where you cannot offer anything. My take-home message will be that therapeutic landscape of bladder cancer is rapidly evolving. Radical cystectomy still is the gold standard for the BCG unresponsive disease. The search of reliable marker continues, and with better understanding, precision and personalized care, maybe in the future we will be having few drugs which will work in all these types of the subtypes of the bladder cancer. Thank you.
Thank you, sir.
Thank you, sir. Thank you for the excellent overview. The second speaker for today is Dr. Amitabh Singh. So we are going to ask him to request about cost metrics and toxicity metrics of an MIBC. So prime time to revisit our doses and schedules.
Good morning, everyone. Greetings from Rajiv Gandhi Cancer Institute, and thanks for giving me this opportunity. So I'm supposed to talk about the cost and toxicity associated with the treatment of NMIBC, and it is the right time to revisit our doses and schedule to decrease the toxicity of treatment of NMIBC. So we all know that bladder cancer is associated with the highest lifetime treatment cost. And in fact, in recently published article in JAMA in 2021, it has been estimated that at the end of follow-up of 1 year, the approximate cost is roughly around $30,000, whereas at the end of 2 years of follow-up, the cost goes up to $55,000, and finally, at the end of 5 years of follow-up, it may go up to $1,17,000. And this cost varies across all the countries depending on their currency evaluation compared to the dollar. And this cost includes direct cost, that means cost associated with the evaluation, investigations, treatment and follow-up procedures, and indirect cost also, that means the loss of working hours and the loss of life. And because NMIBC constitutes mostly almost 70 to 75% of all bladder cancer patients, so logically the most of this cost, the major burden of this cost is being shared by the only treatment of or management of non-muscle invasive bladder cancers. So frankly speaking, as a urologist, we can't do much about reducing the cost of this treatment unless until we do have any very cheap investigation, non-invasive investigation which can replace invasive follow-up methods with a very great high sensitivity and specificity, or if there is any paradigm shift in the policy management from the government or any guideline changes for the management of NMIBC. But definitely we can do much greater job or much significant job in reducing the toxicity of treatment of NMIBC. So across the country in all institute, mostly this intravesical mitomycin and BCG is being used for the management of NMIBC because MMC is not associated with lot of toxicity. So I'll be just discussing on the toxicity profile of the BCG, and it's a really toxic drug because almost 50 to 60% of all these patients, they experience side effect. And only 30% of these patients, they are able to continue their 3 years of the maintenance of the intravesical BCG. A lot of strategies has been tried in the past, like use of isoniazid, use of ofloxacin. Isoniazid didn't prove to provide any significant benefit in reducing the toxicity or increasing the BCG tolerance, whereas ofloxacin proved its worth in reducing the toxicity and increasing the tolerance of the BCG. But much of the focus has been shifted towards the modifying dose and the schedule of BCG just to reduce the toxicity of NMIBC. So to defeat our enemy, first we need to understand our enemy. So it's very important to understand the BCG because every strain of BCG is not same. So all these BCG strains, they are different in terms of their genetic constituents because they are being subcultures, and with every culture they lose their genetic material in especially a region of difference. So all these, because they differ in their genetic constituents, so they differ in their antigen profile over the surface. So finally, they differ in their immune response also and virulence also. In fact, in this study, which is a retrospective study, Yuvraja sir et al. Has tried to investigate the Danish 1331 and Moscow 1. And they found that the toxicity profile of Moscow 1 strain is definitely much worse than Danish profile. So Moscow 1 strain has a higher incidence of moderate to severe with significant p-value. It has got a highest incidence of BCG discontinuation, and it has highest requirement of anti-tubercular treatment to manage the BCG toxicity also without compromising the oncological safety. Because the recurrence-free survival, progression-free survival and the overall survival was same whether you are using Moscow strain or whether you are using the Danish strain. So all these strains, they differ in terms of their concentration also. This is a very important point you need to understand. So once the BCG was first used by Morales, he used the concentration of BCG in terms of 8.8 into 10.8 colony forming unit. Because this is attenuated bacteria, so concentration is basically measured in terms of colony forming unit. So when Morale used this unit, 8.8 into 10 to power 8 colony forming unit, so he achieved this concentration with 120 milligram of BCG. So with this positive study, again the Lemme et al. Conducted first randomized trial and with the this pasture strain of the BCG, and he used that same concentration, same colony forming unit with the same milligram, 120 milligram of the BCG, and that trial was positive in reducing the recurrence and the progression of disease after giving intravesical BCG. So, but unfortunately down the line, we all urologists just forget to measure the colony forming unit. We just stick to the milligram of the BCG. So we blanketly use 120 milligram of the BCG in every patient, irrespective of the strain we were using. Just for an example, in India previously the Danish was available, now we are using the Moscow strain. So same colony forming unit of 10.8 to 10.9 colony forming unit can be achieved with only 30 milligram of the Danish strain and 40 milligram of the Moscow strain. So just consider if you are giving 120 milligram of this Moscow and Danish strain, so that means you are giving almost 3 times of colony forming unit of this bacteria. So that could be one reason why we are just exposing all these patients to higher toxicity of the intravesical BCG, irrespective of increasing the oncological outcome of all these patients. So that's why in India there were 2 randomized trials in the past where investigator tried to reduce the dose of the BCG, that is 40 milligram and 80 milligram instead of giving 120 milligram. So all these were randomized trial and they evaluated and they found positive outcome with the low dose also, irrespective of reducing the oncological safety of the patient, and they got a significant difference in decreasing the toxicity profile. Again, this one study was in the collaboration of Serum Institute of India and RML Delhi, where Dr. Sudhsar et al. Published this study, where they compared 80 milligram dose of Moscow strain with the 120 milligram of Moscow strain dose. And they found that there is a significant less incidence of fever, dysuria, hematuria, increased frequency and burning micturition with the 80 milligram of Moscow strain, without compromising the oncological safety, because recurrence-free survival and progression-free survival was all same, whether you are using 80 milligram of this strain or 120 milligram of all this strain. Again, just to confirm or reiterate this finding, this study was in the past published by the SGPGI by Anand sir et al., where they tried to evaluate or the measure the interleukin 8, urinary interleukin 8 concentration before giving BCG, 2 hours before BCG and 4 hours after the BCG. And they tried to correlate with the response, BCG response in the disease, and they tried to measure the concentration with the low dose of BCG and high dose of the BCG. And interestingly, they found that there is a very good correlation with the urinary interleukin 8 concentration with the response rate of the BCG. And those patients who had responded or those who had a very high concentration of interleukin 8, it was same whether you are using the low dose of BCG like 40 milligram of the BCG or whether you are using 120 milligram of the BCG. So indirectly you can say or you can extrapolate this result as whether you are using low or high, if it install or if it activate your immune response, then both dose will activate the immune response with same efficacy. And you can prevent your patients from the toxicity of BCG by giving high dose of the BCG. Whereas there are 2 large randomized trials in the West also, like Kyoto and EORTC trial. So Kyoto trial just evaluated 81 milligram with 1/3 dose, that is 27 milligram. And what they found actually, in case of multifocal tumor, is standard dose, that means 81 milligram is better than reduced dose in terms of recurrence and progression. If patient is having grade 3 or high risk disease, then there is a positive trend towards the standard dose. Whereas the 5-year cause specific survival is almost same whether you are using standard dose or reduced dose. Toxicity significantly in the favor of reduced dose, but severe systemic toxicity which required hospitalization of the patient is same irrespective of whether you are using reduced dose or standard dose. Whereas EORTC was a failed trial because they used TICE strain and they randomized their patient into 4 cohort where they tried to analyze low dose along with the maintenance duration also. So 1/3 dose with 1 year maintenance, 1/3 dose with 3 year, then full dose 1 year and full dose 3 year. And there was no significant difference in terms of toxicity whether you're using low dose or high dose. So there are possible reasons behind these failed trials or difference between the Indian trials and the Western trials, because this ERTC trial used just TICE strain, which is, we all know that is the least virulent trial. So because it is the least virulent, so it didn't led or contributed to the toxicity of the BCG. Indian trials were criticized for the less number of the patients because all arms usually have only 30 patient or 40 patient. They incorporated low risk patients also, which ultimately finally liquidated the final outcome of all these trials. And that's why and another thing, because all of this Indian population is exposed to the BCG by a vaccination or just exposure in the population. So probably that's why we mount a better immune response to the BCG compared to the Western population. So this phenomena was evaluated in this retrospective study from the Kochi by Ginil et al.
Dr. Amitabh, please continue.
Yes, sir. Last two slides. Last two slides. So they found that there is no difference in the survival whether you are using maintenance or not. So again, I would say, conclusion, we definitely need more Indian randomized trial with larger cohort of the patients. Inclusion of only intermediate and high risk patient with subgroup analysis would help us to come to conclusion. And the role of maintenance BCG also to be defined, especially in our patients, whether it is helping us or not, or whether just contributing to the toxicity. And alternate studies, as Dr. Rawal sir has mentioned, combining with the mitomycin with the BCG. But definitely what our evidences we have, they are just supporting the low dose of BCG, but they reduce the toxicity and they are as good as the standard dose of the BCG. Thank you.
Thank you, Dr. Amita. May I call the next speaker, Dr. Anup, Professor Anup?
While we are setting up, what's the dose which we are currently using, 80 or 40 for a little old gentleman, Dr. Amita? What's the dose which we are contemplating, 40 or 80 at this point of time? For old gentleman, 40 or 80 milligrams? At 80. So,
registered in EAU, they are using it.
Right, sir. So the next speaker, it's a privilege to invite Dr. Anukumar sir. He's going to talk about, it's a different topic, not routinely discussed, so it's a difficult task, but none other than sir can do this particular job the best. So high risk screening and primary prevention strategies for bladder cancer, a plea for policymakers. Over to you, sir.
Requesting Dr. Anup to kindly keep an eye on the watch. The first bell should be the... Thank you, sir.
Good morning, respected chairpersons, seniors, my dear colleagues. I want to thank organizers Anjay Usai and Dr. Ashwin for inviting me to this wonderful meeting. I have been given a very unique and out-of-the-box topic which I have never presented before, but I will try to do the justice. High-risk screening and primary prevention for bladder cancer, a plea to the policy makers. Why this is important, we should understand the epidemiology of CV bladder first. CV bladder is the 7th most common cancers in males. Incidence is quite high, 10 per lakh in males and 2.5 per lakh in females. Mortality is also 3.3 per lakh in males and around 1 per lakh in females. In India, if we compare the data with Western countries, the male to female disproportion tends to 1. And important thing is the high incidence of smoking. 75% of patients in India versus 22% in West. The smokers are more predisposed to CV bladder. When we look at the economic burden of this disease, almost 6 lakhs cases in 2020 registered in the worldwide, and treatment cost, you can see 1 lakh to 2 lakh dollars per person. Annual loss of productivity and annual treatment cost in billions, and almost 12 years of income producing years were lost because of premature death. And therefore, CV bladder has the highest per person cost and the 5th overall highest cost. And therefore, it is important to talk about prevention and early detection treatment of CV bladder because it has got enormous social, economical impact on Indian society. Now, what is primary prevention? I think most of us might not be knowing. That's why I put this slide, and I want to thank Dr. Siddharth for helping me in making these slides. Primary prevention is basically person does not have the disease yet, and therefore we try to reduce the risk factors. And the goal is that person does not develop the disease. This is our goal of primary prevention. But secondary prevention is the patient, the disease has already started, patient is asymptomatic, and we want to do the screening for the particular disease, that is intervention. And the goal is early detection and treatment. And of course, the tertiary prevention is person is symptomatic, develop the disease, and we want to have the prompt and appropriate treatment, and the goal is to reduce complications. So we're talking about the first, which is primary prevention. Now, for that, we should know the risk factors of CV bladder. Smoking, working in various chemical industries, chimney sweepers, rubber workers, dye workers, and tobaccos, of course. These are the commonest risk factors for CV bladder. And if we look at this paper, which is a meta-analysis of various modifiable risk factors, these are the factors which decrease the risk of CV bladder, which is very important. If you take selenium as an antioxidant, vitamin A supplements, again an antioxidant, and fruits and vegetables, as compared to non-veg, you have a reduced risk of CV bladder. Now, the question is if CV bladder is amenable to prevention or not, then only we can talk about primary prevention. Yes, it is amenable. You can see in this bar chart, 50% cause is smoking, 10% is occupational hazards, 40 are other causes, and smoking, occupational exposure, environmental exposure, dietary factors, if you take all these things, these are all modifiable. So we can modify these risk factors and decrease the risk of CV bladder. Genetic factors, unlike CV prostate, they play a minor role in CV bladder. and therefore it is amenable to prevention. Now, this paper, as I said, meta-analysis shows that 50% of sea bladder is caused by smoking, and it is more common in smokers as compared to the formal smokers. And again, cigar and pipe smokers, they are increased risk as compared to general population. Oral tobacco does not increase the risk of sea bladder, which is again a very interesting finding. The problem is this advertisement. You can see in America or India, a lot of advertisement given by celebrities and our film stars, which promote our youngsters to go for smoking, and this is the problem which is increasing the smoking epidemic in India and abroad. Now, the smoking control policies have been adopted to increase awareness used by media, absolute ban on the advertisement of tobacco products, health warnings of the packing. Now you can see World No Tobacco Day was celebrated 31st May 2021, and we say no to tobacco, say yes to good health. This is just the beginning of that one of this policy, and all the packets they have the warning, smoking kills, tobacco causes cancer, but still, golden question is, if still our public know about it. Now this is the public survey carried out. Only 92% of participants, they said that smoking caused lung cancer, but only 30% knew smoking causes sea bladder. They don't know it can cause sea bladder. 7% said smoking is the primary cause of sea bladder. And 28% they identified industrial chemical as the sea bladder. And 50% incorrectly identified alcohol as the cause of sea bladder. So this is the level of awareness in our population. And therefore this slide is very important to say how we can control this smoking epidemic. One is increased awareness programs targeting on school and college goers. You attack on the basic education, inculcate the activity of no smoking. Registered tobacco shops should be there, a ban on sales to minors, and all these small number of shops which are coming here and there, they should be banned. Increased tax on cigarettes. Now there is a recommendation by WHO to have 80% tax on tobacco products, but what you will see in India, 50% tax compared to 80% tax in America. So this is the cause. Tax on BD is even 20%. So if you impose more taxes, it will decrease the urge to go for the smoking. And of course, enforce the ban on smoking in public and workplaces because you want to prevent the passive smoking. And therefore, next is the occupational exposure. We know it is sea bladder is caused by occupational toxins, dye, rubber, textiles, and there is lack of awareness, and personal protective equipments are lacking in all these industries. And you can see this is all the dyeing industry chemicals in the river and exposing all of us to this risk of sea bladder. Now, finally, I will talk about some screening in high-risk population, which is some work has been done. And this paper shows if you do screening in asymptomatic patient, 1,000 patients were included. They used dipstick test for hematuria and urine markers were used. Only 7 patients out of 1,000 they had tumors. Another paper, what they found is if you do the microhematuria as a screening method, only 30% in 2 to 30% patient it is intermittent. Therefore, you cannot pick up tumor just based on microhematuria, and most of these patients might have benign causes. And the incidence of sea bladder in general population is very, very low. That's why these are problems of screening protocol. So the answer lies in high risk population. We should go for bladder screening using the dipstick and MP22 cytology in Eurovision. 3.3%. These are the patients who could be detected by using the screening methods. Once you detect these patients, you have to go for CT and cystoscopy. Another paper, if you do screening in primary aluminium production workers, again you found around 77% higher risk of developing the cancer. So these are the high risk population can target for screening. Similarly, if you target the patients who are working in aromatic amines, you can look at their 1% patient develop tumors. So it's a very low incidence, but still you can use screening in these patients. What are the harms of screening? It includes cost. Its incidence is very low even in high risk population, and patient develops anxiety because false positives are very high. That is the problem with screening in CA bladder. What are the guidelines say? None of the guidelines recommend screening in CA bladder. USPSTF, National Cancer Institute, AU, American Cancer Society, none of the guidelines suggest it can be done. Therefore, my last slide is what can we do? What's the reality? The reality is our plea to policymakers, we should have a stricter curbs on the smoking, especially in the public places and young adults. That's one we can do. Stricter enforcement on work protection laws to protect from the occupational exposure. Increase awareness of CA bladder by smoking, occupational hazard related using the media and our society related activity like we're doing here. And you assess the feasibility of CA bladder screening programs in Indian population. How we can do screening? One is introduce a bladder cancer screening in high risk population. as a shared decision making as you do for CA prostate. But if you have a highest risk, like you have smoker and you are occupational hazard also, then you can do a risk-based screening in these patients. So this is the reality of screening in CA bladder. I think this is one of the unique topics Ashwin gave me, and I think it's better to should start thinking about it, how to prevent CA bladder rather than to cure it. I think thank you for me for your paying attention, and I think I finished well before time.
Thank you, Dr. So one quick question: does urine routine microscopy and a microscopic hematuria can be assimilated?
So yes, I because the time was short, I did not elaborate that. Yes, if you use only dipstick method, the problem is 22 to 30% patient is intermittent. So you cannot pick up tumor just based on dipstick. So what they say, the combined test, you use dipstick, you use Eurovision, you use NMP22. Once it is positive, you have to confirm it with CT and cystoscopy because false positives are very high. So that is a problem, but yes, you combine both, I think we can increase the yield of detection.
Thank you, Dr. Anu, for the precise presentation.
Thank you, Chairpersons. Thank you so much for the session. So with this, we'll move forward to the tumor board discussion.
Dr. Ashwin, this is 1 hour session which is to the ISU. We have running, thanks to Dr. Anu, we have covered the 5 minutes.
Yes.
So you have to cover the remaining 5 minutes. Thank you.
Thank you. So I'd like to invite my panelists, Dr. Sudhir Rawal sir, Dr. Anup Kumar, Dr. Kumar Prabhas sir, Dr. Srirag, and Dr. Rakesh Vyas, Radiation Oncology. Dr. Srirag is head of the department of JIPMER. Dr. Anup Kumar, Dr. Rawal sir doesn't need introduction. Dr. Kumar Prabhas doesn't need an introduction separately. So the disclaimer is it's not something like a standard tumor board, but we will try and have some real world case scenarios which will have some discussion which is going to be very relevant for our day-to-day practice. Not exactly like a theoretical. We have included some cases which are a little beyond the book as well, just for academic discussion. So case 1, can we have some mics there? So case 1, 64, ECOG1, hypertension, no diabetes, trust biopsy showed at least T2 disease, positive cytology, a large lesion in the bladder dome, and there is a big nodal, external iliac 2.5 centimeter, no subsequent meds. So Dr. Neeraj is not here. Dr. Srirag sir, NSAT versus RC. NSAT, everyone agrees, I think NSAT. So completion T-orbit done. Kumar Prabhas, I wanted to ask this question because this patient underwent only one biopsy. He didn't undergo a formal resection, which is a doable resection. Does that matter for NSAT, as in the debulking of a tumor? For example, what we do in bladder preservations, is it very important? That is a relevant question asked by the patient.
So in my JC, it will be decided Vedang's manage it or Gagan. So if finally decided Vedang manages, then it becomes very important. If it is decided Gagan's manages, then it doesn't.
So on the surgical side, we just debulk, we just need a tissue diagnosis. Yesterday it was brought out as a point. So assessment protocols are how many cycles and re-imaging after 2 cycles? So what's the standard protocol like? Just from your end again, sir.
So one of the important aspects is the fitness, which we talked about. This is the issue because elderly population. Yeah. For evaluation, it is for efficacy and the toxicity that we do for every cycle. No intervention required. It's only to evaluate the patient clinically. But once it is done, then yes, one needs to evaluate radiologically, and before surgery may or may not be cystoscopy to go ahead.
Any intermediate evaluation after 2 cycles, or you straight away go till 4 cycles if everything goes well?
No intermediate evaluation. 3 to 4 depending upon your center. There are people who are concerned about beyond 3. That's perfectly fine. 3 is good, maybe good enough because that data is there. But many center gives 4. That is also good enough.
So this patient on a clinical imaging had a fantastic response.
Can I add to it?
The image on the left.
Can I add to it why I said this? Usually having a progressive disease on chemotherapy is very uncommon. So that's the reason there is an assurance that you are not messing it up. Because what we are concerned about, are we messing up the disease which you could have or sir could have easily removed? And here the reassurance with chemotherapy is rarely you will have a progressive disease, so you don't mess it up. So in between doing test is not very useful.
Absolutely. So he had a good response. The right side image, the one on the PET scan, the tomo image, shows in the lighted up node on the pelvis, and it is almost vanished on the post chemotherapy. So underwent complete resection. So Dr. Srirag, lymph node dissection, standard, extended, limited dissection. Just a quick answer. Dr. Srirag, yes.
Yeah, it's extended. Extended is best.
Yeah. So he had a node in the iliac region. Does that change your plan for going one step ahead of it? Just a
see, once it becomes
like, see, once it is in the, better to do an extended dissection, but if you see there's a paralytic node, then I feel that, then I think we are only doing a palliative treatment. But if possible, you should try to do the maximum. But as we go higher up, the morbidity is too high for the patients and the post-op complication rates are really high. So we should wait upon seeing the patient and then take the decision.
Absolutely. So choice of diversion, he is a young fellow. Sudhir Raval sir, node positive, what's the norm like in today's practice?
There are many studies on this situation when actually this question has been explored way back in early 2000, and there is no difference in patient if you offer either neobladder or conduit, but it's the patient choice. If the patient wants, he has responded very good, so the neobladder can be done.
So it doesn't deter from a surgical side as a decision from the surgeon side.
Say that again?
From the surgeon side, both options are eligible.
Yes.
Absolutely, sir. So final path was under downstaging of T stage, so PT1 high grade TCC, 1 out of 49 nodes positive without extranodal extension, negative margin. So there was a good downstaging, but one node turned out to be positive. Obviously the same node probably which was lighted up earlier, but good part of chemotherapy was extranodal extension wasn't seen in the post-operative phase. So Anukumar sir, 4 cycles of gemcitabine cisplatin given. Do you want to just do a surveillance for this patient or give some options?
This patient has got a very high volume disease. I want to go for the adjuvant now.
Yes,
we can't put this patient on active surveillance because
Absolutely.
this is the only window we have. We miss this. It's going to come back with a lot of recurrence.
So that patient will be handed over to the medical side. So Kumar Prabha sir, what's the plan in today's time? Say patient is affording, first scenario.
So if patient is affording, immunotherapy needs to be discussed.
So 1 year?
1 year. But adding it, during discussion, it should be conveyed to the patient that OS data is not there. That is key because that's something which a patient wants to know and we all want to know.
Yes, sir.
Second data is that PD-L1 positive or negative. This is all comer data, what you have shown. PD-L1 positive, it is very different. 10 versus 59 months, which looks like different than what you see in PD-L1 not being positive. That needs to be conveyed. After that, it will be patient decision, but discussion should happen. That doesn't mean I'm saying every patient should receive immunotherapy.
Absolutely, but nivolumab option is definitely one worth considering, and that's the only drug at least at this point of time for this basket of patients. Or you are exploring beyond nivolumab as well, because other trials did not show positive results.
Very important. What you said is absolutely important. Drug and the disease should match. You have 5 kind of immunotherapy. That doesn't mean other 4 are useful.
So only nivolumab.
Only nivolumab. Other trials are negative, so shouldn't be used.
Absolutely. And if the patient is not affording, what's the plan? Do you consolidate by giving more cycles of chemo or just wait and watch and surveillance?
3 to 4 enough.
Yeah, so surveillance if patient is not affording. Sir?
Yes.
Ashwin, Kumar, can you just tell me about DDMVAC? Where will you use DDMVAC? Because I think data or maybe a lot of people in the West, they go for DDMVAC rather than GemCis.
Sir, this is totally our fault. Preferably we should be DDMVAC. As much you keep hearing from people, gemcitabine platinum, we also do it. This is more for convenience sake, but data is far more for DDMVAC, and if preferred, we do push for it because of logistic. We end up giving gemcitabine platinum, but we'll prefer DDMVAC.
Absolutely. Rakesh Bhatt sir, adjuvant RT is a node positive patient. Suppose we are not contemplating immunotherapy. Two scenarios. We are contemplating immunotherapy, and second is we are not contemplating immunotherapy and just surveillance. What will be the plan of action from here?
I think as you have given the pathology report, as a complete dissection has been done and only one node is positive PT1. So there is faint indications. So probably adjuvant radiation is not needed in this patient.
Absolutely, sir. I think sir mentioned about BART trial. I think the radiation.
Yeah, this trial is going in TMH. Vedang is doing, but I have some reservation about this trial because way back in 90s in UK they use any RT rather, neoadjuvant RT, pre-op RT a lot, and that time they say later realized that it doesn't affect. So I don't know in adjuvant setting what are going to be the results, but then let us see the trial result.
I think current recommendation is 2A because of no concrete evidence, but let's wait for the results from BART trial, I guess. Yes, sir. So minor twist, it's the same patient, I think it was brought out by Raja sir in the same setting. So same patient, node positive, but he is ineligible for cisplatin in the beginning because of maybe say hydronephrosis. So Kumar Prabha sir, are you keen on requesting surgeons to put in PCNs when subjecting for chemotherapy, or you generally ask them to upfront operate if they are operable?
We prefer, at our center we prefer operating, but we do hear from our colleagues, and we had a foreign faculty, they prefer putting
so try and assess the response and then you reevaluate cisplatin eligibility.
Yes, that is a valid option, but our infection rate is higher. That's what we had an argument with him, and we kept saying, our infection is not what you're saying. He said, we don't have this problem. We said, we do land up in problem, it messes up the surgery also. So we do prefer surgery upfront.
So same situation, sir. Node positive clinical, 2.5 centimeter. His cisplatin ineligible but carboplatin eligible. Say performance status 2 GFR is adequate. Do you give gem carbo or you ask surgeons to operate upfront if the disease is operable?
Upfront surgery.
Upfront surgery.
Even node goes back from our OPD for surgeons.
Absolutely, sir. And if same situation, T3 disease, N0, obviously the answer will be same, that upfront surgery if feasible, if patient is ineligible for cisplatin. Am I right?
Yes. Unless if there are lymph nodes and then surgeons are uncomfortable operating.
Yes. That is point taken well. So case scenario second, 74 fit patient, diabetic, hypertensive, OSA, non-smoker, hematuria, USG shows multiple bladder lesion, FDG PET was done, right lateral wall lesion, cytology was positive. So Dr. Srirag, one question, FDG PET, even before the utilization of a standard CT or even a cytology, and FDG PET was asked for. Correct or wrong, or any comment about this?
Like you mean to say why we use the FDG PET?
Yeah, as in this point of time.
See, we don't do because I think it's an overdo
at this point of time. Yeah. Another point is for trainees, if there are trainees around, conventional CTs with full bladder, FDG they will never allow full bladder to happen because they want to mask the urinary activity of FDG dye. So you will not get an adequate picture of distended bladder on FDG. So no FDG CTs at this point of time. He undergoes a scopy. I'll run the scopy quickly. I just wanted to show the big lesion on the right lateral wall, two lesions, and then a lot of red patches, which I just wanted to show. Yeah, so these are red patches, probably the evidence of CIS on the clinical imaging. Undergoes TOBT, near complete resection, at least on the microscopic vision. High grade T1 extensive CIS with LVI. Focal muscle positive and a cautery artifact. Dr. Shira, cautery artifact is a thing which generally sometimes pathologists do.
Yes, sometimes pathologists say, but I think always we need to have the pathologist to us, like we should discuss with them, and then whatever doubts they have, we need to clear. And I feel it's a high grade T1 with extensive CIS LVI. I think he should. He's a candidate for radical cystectomy.
So in that particular situation, for convincing patients, do you want to have a review of report because muscle
definitely,
is
definitely. We always discuss with the pathologist.
So good pathological reporting is very important.
Very important.
Yeah.
And plus, we need to make sure that the patient also understands, because if given a choice, all the patients want to preserve their bladder.
Yes,
but they should be informed that okay, what are the problems if you give the bladder? But if such a patient is going to progress.
Absolutely. Non-smoker and CIS, does that fit in, or do we get these scenarios that often? This is a real world scenario. I don't know, no environmental exposure or no smoking.
Yeah, it's possible. It we get.
Yeah, and enhanced cystoscopy given a choice, is it desirable?
Definitely we need to do.
And which is the preference? Obviously, blue light is not available.
We have only NBI.
Given a choice, if it is available under the umbrella, blue light or NBI in.
I think then maybe blue light will have more options, much better than NBI. But we have only options of NBI now.
Absolutely agree. So review in TMH taken, high grade extensive T1, extensive CIS, necrosis, superficial micropapillary pattern, but muscle was reported negative. So same questions, Anukumar sir, he's already answered, but just want to re-emphasize from your end, risk stratification and what's the plan?
Yeah, so this patient has got already high risk disease and he is going for early cystectomy.
Early cystectomy. Yeah. Yes, because of three combinations, T1 high grade and CIS with some micropapillary patterns as well. No role of RT here, sir. Yes, sir.
So, if there are some medical contraindication or patient is not willing, patient can be taken. Yeah.
Yes, sir. So, case scenario 3, we're just going to have some certain scenarios, not going to complete one particular case to the end. So, 70 fit patient, large growth in near the bladder neck, cytology was negative. So, TRBT was and a limited TRBT had to be done because it was extending till the bladder neck. Report was T2 at least, prostatic urethral, superficial involvement, high grade. Decided that he was a T2 candidate, so decided for RCIC with frozen section. Raval sir, what's the standard norm in your end for sending frozens? All patients or only those who have these kind of scenarios?
No, we only very selective in this. Problem with frozen in this situation is that 50% they may be negative, but they will be positive later on.
Later.
And that is why Studer and all, they do not suggest frozen at all in this situation.
Yes, sir. So
good thing is that if you do neobladder, then definitely you actually urethral surveillance will be there.
Yes.
But if you are doing ileal conduit and if you are planning for urethrectomy, you plan it for immediately at the time of cystectomy rather than waiting for recurrence to go.
Upfront. So that would be based on the frozen, right? As in urethrectomy decision will be taken based on the frozen, because earlier it was only superficial
That's
involvement and not the stromal one. Yes, so frozen was sent, apical negative. So final pad turned out to be T4, as you rightly said. The stroma of prostate, they reported it as positive. Margins were clear, nodes negative. So now we are again back to the discussion about urethrectomy, sir. So obviously we are having an interval dissection here, not on the same go, but as you said, preference would be at the same time. Is there any age cutoff in your end for deciding about interval urethrectomy for minimizing morbidity, or it doesn't add much to the morbidity?
No, I don't think it adds much.
Right. So completion urethrectomy was done. Urethrectomy was done at about 4 weeks from the surgery. Negative for any skip lesions. That's the picture of urethrectomy. So unfortunately, this is important thing here is because the final stage is T4. So we need to get back to the medical on team about this. This is a point which is very relevant. Sometimes we tend to forget about these points. So T4, prostatic stromal involvement, sir. Agree for chemotherapy here, adjuvant chemo. Earlier we never thought that it was T2 on the clinical sides. Adjuvant chemo?
Yes.
Okay, and would NSCT had helped? There was a suspicion of prostatic stromal involvement. Do you recommend NSCTs these days, as we are utilizing NSCTs more often? Are you thinking that even prostatic stromal, not stromal, but the superficial involvement is a candidate for NSCT?
So clinical judgment becomes a tricky one.
Yes.
It would have been T4 or it would have been T2 or less. Now that's a tricky one. But having said that, if we have a fair doubt about it's going to be T4 or T3, a new adjuvant is always better than adjuvant. In any visceral tumor you will see. You take esophageal cancer, you take bladder cancer, because it is easy to deliver. Benefit wise, I have no doubt about it if you give initially or give later. But ability to deliver becomes a challenge once you have done visceral surgery. The amount of time the patient takes to recover, that becomes a challenge. So if that is the issue, preferably NSCT. But it's okay. I know that this situation will come up. This is a clinical situation. This is nothing to do with at the time of judgment, because you do have a situation where you are doubtful about NSCT. Yeah. So you end up going in.
Absolutely. So adjuvant RT, sir, Rakesh Vasar is ultimately T4. We have done urethrectomy negative.
Yeah, here is the indication, and it will definitely give a disease-free survival advantage, not the overall survival.
So dose and fractions, and when do you want to start?
As my colleague, radiation oncologist, now we are giving hypofractionated. So 55 gray in 20 fractions, or 50 gray in 20 fractions.
So post urethrectomy, say about 4 weeks? Is
Yeah, 4 weeks, 4 to 6 weeks.
So 62, again fit patient, non-smoker hematuria. There was a big lesion on the lateral wall, T2 at least, urethral carcinoma. Very important slide, it's a real world scenario. We just wanted to re-emphasize to the patient about cystectomy. We got a review from dedicated uropathologist, and the report surprisingly changed the whole thing. It's large cell neuroendocrine carcinoma reported as per, high grade T1 reported as per TMH reporting. Obviously the rediscussion had to happen. So Anup Kumar sir, staging changes here. We have done only CT, chest and thorax until now. Now the surprise report is large cell neuroendocrine.
So I think we'll go for, in this particular case with neuroendocrine, we'll go for a PET scan.
FDG PET scan and a brain imaging, which will include the brain imaging. So very important. So one good indication of PET scan in bladder cancer domain. To be considered for micrometastatic disease, sir, Kumar Prabha sir, in your opinion?
It is, except that one more information we always ask when you have this large cell, what is your MIB index? So tells you how much is the proliferation. Usually the way Santosh has reported, I saw that looks like high grade treat like small cell. Many times you do have, they say neuroendocrine tumor, if you probe them, they realize MIB index is 10. Then you know, oh, these are neuroendocrine bad ones, but it's not small cell. Then it becomes a bit tricky one, how much you are intensive for chemotherapy. Here, it is, if you're treating as a small cell, because it is a high grade, then yes.
So any difference between large cell variant and a small cell variant? I'm not very...
So that is, this is one gray area, and you will see all kind of report happening. So what we ask for, when we have a large cell reporting, say, put it at neuroendocrine, and then put it as what is the MIB index. If your MIB index is 10, it is, you can say, it can be a bit of atypical carcinoid also, which you do surgery and I'm good enough. I don't want to go in. But large cell neuroendocrine high grade, most likely Santosh means is treating like a small cell.
Yeah. So T2 appearing image. So everyone agrees for the plan of NSCT, sir?
No doubt systemic therapy patient needs to be exposed in this.
So no cystectomy upfront. And what's the drug choice? Because there will be some deviation.
Okay, so it is here. It will be platinum based. Usually etoposide. Some people will use irinotecan. That's perfectly fine.
So etoposide cisplatin combination.
Etoposide.
And how toxic it is in general?
It is a bit more toxic than gemcitabine platinum. Maybe similar to DDM-VAC.
Absolutely. So just a quick thing. And how is the prognosis in general? It's terrible or acceptable?
It is if it is small cell. Someone spoke rightly. In localized tumor also, if you get patient alive beyond 2-3 years, he or she should be lucky one. The data, it is all extrapolated from lung cancer. The 5-year survival is 5% to 7% in localized tumor also. So very few people survive unless they are early T1s and or T2, and that too in lung cancer. Here, the moment is invasive one. Not many survives long.
So chemo first for neuroendocrine variants. Sadly, this particular patient, just on a funny note, had a severe hyponatremic convulsion after immediate first cycle. Got admitted and later on decided not to go for anything. For at least 5 months, we haven't imaged him. He's not ready for any imaging. He's just gone on an alternative therapy. That's a sad part, but it's a part of our practice. So that's the recommendation from NCCN. RCC, so another thing is, these are 2 post-op scenarios which I wanted to bring forth. I'll quickly go through because of want of time. RCIC day 4 has a distension. Until now he was quite better. Drain is 140 serous, not suspicious. Creatinine is 1.3. Shrirak sir, CECT done. So what if you're doing a CECT? What do you want to as in how? What's the request order coming from your end to the radiologist?
2 things which I want to know: whether there is a high drain, there is a fluid output, whether it is intestinal obstruction is there, because air fluid levels we can see. So
dilated bowel loops.
Yes, we can do is that we can do a gastrography study also. So actually it is both therapeutic as well as diagnostic as well as therapeutic. So we can we have gone up to 3 doses of gastrography study, gastrography therapeutic, and 3rd time also we have been lucky sometimes.
Absolutely. So oral contrast sometimes works. So if the abdomen is not tender guarded, you're good enough to have oral contrast CT.
Yes.
With IV contrast. Conduit gram in the same setting, do you feel it's a worth idea?
Actually, we can do, or usually what we do is that CT urogram we do, so that time we can get if there is any leak from the uroileal junction, we can make out. But sometimes if it is in a female patient, we may not be able to get, because sometimes the urine will leak from if urine is leaking, or I'm telling from my personal experience. 2 weeks back we had done a operative cystectomy and ileal conduit. There was a ureteric leak, but the CT didn't pick up. 2 times we didn't pick up, but then we put bilateral PCN and then a methylene blue, it clearly leaked out. And we did a urine creatinine also. It was 3 or 4 it was. So confirmed it is urine leak. With both side PCNs we managed.
So this patient had ileus, no leakage anywhere, conduit gram, everything is normal. Raval sir, it's day 4, too early to decide about anything. Plan will be conservative.
Yeah, we will manage conservatively, but what we are doing in our practice
So what's the goal in general for educating everyone? What's the goal of managing these patients? Or what's the objective of managing these patients?
Objective is to treat, we don't want to open him up as far as possible, because you open him up, mortality rather will be high. So try to treat him conservatively with TPN, as you said, correct the electrolyte hydration. What we have seen in our practice is, where is Amitabh is here? Acetylcholine they give? We give acetylcholine also, injection.
Alright.
So that helps, is because these are old guys. And another thing that we do, nicotine patch for smokers. Many of them are smokers. So 2-3 things we do extra, what you have written here, except otherwise we do use this Sprite, metoclopramide, but then acetylcholine, this injection, and then also this patch. Right. For these patients, we do not hurry on, doing surgery. But in case, suppose he goes in obstruction, so this ileus, if he goes in obstruction, so we go with the robot. With the robotic surgery, we go with the robot. And most of the time we are successful in treating this patient.
Right. So this patient managed conservatively, RT taken out on day 8 after patient started passing flitters, bowel sounds were normal. Again, immediately after feeding went into ileus. Day 9, other parameters are still well preserved. No hypertension, mild tachy, no fever. WBC is about 16K on higher antibiotics. Drain is 200. Minor muck, it's been there since 8 days, but no convincing bowel leak or the urinary leak. The drain fluid creatinine is acceptable. So day 9, still no pressing indication for surgery. Do you want to still conserve, sir, or reintroduce the RT and conserve? Or what's the threshold of opening these patients? Sometimes we tend to open these patients very rarely, and it's
day 9 is now is a bit late. And did you do gastrographin?
Yeah, it was given in the initial.
Was there any obstruction there?
No, no obstruction. The dye was going until transverse colon at least, so beyond the anastomosis.
Then I still have hope that he will respond.
Right.
Sometimes they have partial obstruction, that also can cause, but day 9 is a bit late. We'll probably take 2 more days and then
Decide about opening
decide.
him up. Right. So luckily after that he
I
managed
think
well.
I think you
Yes,
put
sir.
the rise tube on day 9. This is what you are.
Reinserted. It was reinserted. It was inserted on day 4, taken out day 8, and again on second day.
So there are no warning signs still. So we can wait for 48 hours.
Yeah.
We can measure the abdominal girth and the vitals. If the girth is increasing, and of course the vitals and they are not stable, then I think we should go for the.
Yes. How many times we have explored these kind of scenarios, sir? As in and probably negative exploration. Just a vast
Negative, no. We have done positive re-exploration, and
something is found inside.
yeah, there was obstruction of the distal loop going into the when it goes towards the cecum. And
Right.
we have a video also in my channel also, and I have shown this. We have published that paper also when we have done immediate robotic re-exploration after radical cystectomy. The patient had obstruction and had radical cystectomy robotically.
Yeah. Because of want of time, I'm just going to run quickly in the next scenario without giving the clinical history. That's the day 0 of cystectomy had less of output. Immediately after cystectomy had less of output, only say 100 ml of output, lot of fluids given, Lasix given, lot of fluid challenge given, preload volume is increased, but still no good output. Undergoes a CT, and there is a contrast delineation next to the conduit. So a little bit of free fluid or free contrast near the conduit on a delayed film. What's the plan? Dr. Srirak already mentioned about it, but does it happen routinely on day 0, day 1? It generally happens.
Actually, sometimes if the stoma we are not done properly, like many people have practice of placing an Foley's into the conduit.
Yeah.
Many do not.
Yeah.
So I used to place earlier, then I had stopped. But sometimes, one of the robotic cystectomy which he did, the post-op there was a increased output. And when I placed the Foley's, it decreased.
Yes.
So many times you can manage it conservatively.
Yes, sir. Anukumar sir, stent preference in say robotic. Let's talk about open conduit. Stent preference.
So we are putting DJ stent and we fix it with the catgut. So that way it's easier to remove from the conduit part. Even for the robotic we do the same. And in this case, I think that there must be some leak from the anastomotic side.
So there was a narrow ureter, which I've asked in the second question. So initial ureter was quite narrow, the left side ureter. So Rahul sir, so he obviously undergoes nephrostomy and managed conservatively on nephrostomy settles. So nephrostomies are pulled out eventually. Stents were already in place. So Rahul sir, in narrow ureters, whichever approach we are doing, interrupted versus continuous sutures, very tight, narrow 5 French infant feeding is barely accommodated. Very rarely we get these circumstances.
That actually one thing which I will say that I'll differ in putting nephrostomy if there is day 1 leak.
Okay.
Because nephrostomy itself is a very morbidity. The patient will be there for 6 weeks and then you come back there. So what in my practice I have learned is immediately explore the patient.
Because inflammation is not set in, that's the right time.
So even with the 3rd, 4th day, we put the robot or do the open and then refashion the anastomosis and go back. And the patient most of the time is alright. But in this case, which you have said that now because the narrow ureter, if you can get good length of the ureter, you have to mobilize the conduit also so that it can reaches to the part of the ureter where it is better lumen. Otherwise, put interrupted sutures.
Interrupted is also worth idea. How many times you managed with, you answered that question already. If exploration, what's the plan? So if exploration, so that's the last question we are wrapping up. What's the plan in mind when you are taking the patient in for understanding of junior colleagues of us or for that matter mine? What's the plan in mind? What all things can happen inside?
Inside, some you may not have sufficient length of the ureter. There may be problem with that.
Some necrosis. Or
necrosis is so long that it may not be there. If it is open surgery, we can bring the conduit down there. Robotically, I'm not talking. If you want me to do open surgery, there is no problem in putting the conduit up there, maybe harvesting another segment of the intestine and putting that to the ureter so that you can get the good part and then bring it. Robotically, it is difficult. Many times, sometimes you have to open the convert to the open surgery. If you are in any doubt when you are doing robotic, that you are compromising with the anastomosis or the vascularity, better go for open surgery.
The open surgery, we go in, vascularity is very compromised. Ureterostomies, do you ever explain this to this kind of patients?
Ureterostomy, no, unless there is a very difficult or hard situation.
Otherwise, you can actually increase the length of the conduit by mobilization, or you may take another part of the intestine. But I have not done ureterostomy for this. I have done ureterostomy for other reason, but not for this.
Absolutely. Thank you so much. Thank you everyone, and thank you for the opportunity on behalf of ISU to Northern Urological Society. Thank you so much, sir.
Thank you for quite a thought-provoking session. I would request all the chairpersons and speakers for the ISU session to move to
Good morning, esteemed urologist. Just one small announcement. The presentation time has been decreased to 7 minutes. The first bell will be rung at 7 minutes, and after 1 minute we will be asking you to stop it, please. It is because we have a flight, the last flight, there are approximately 25 delegates to catch. We have a valedictory function, we have a lunch. So it's a humble request from the Secretary North Zone. Please respect the bell. Thank you.
We would like to call upon Dr. Vinay Vyas, consultant medical oncologist at Jodhpur, who will be talking on chemotherapeutic options for management of urothelial carcinoma.
Thank you, Dr. Gautam and his team, for inviting me to deliver this lecture. I have kept it very short because it is just a reason for since morning we are listening about it. We have three scenarios. One is neoadjuvant, second is adjuvant, and third is metastatic. I have dedicated 2 slides each, and I will finish in 6 slides. So for neoadjuvant chemotherapy, data support the role of neoadjuvant chemotherapy before cystectomy for all stage 2 and 3A lesions. The randomized phase 3 VESPER trial compared the efficacy of DDMVAC or GC in the perioperative setting for 500 patients with muscle invasive bladder cancer. And progression-free survival at 3 years was significantly higher among those who received neoadjuvant DDMVAC compared to neoadjuvant GC. Although practically speaking, as Dr. Kumar said, we are using GC more in India rather than DDMVAC. A higher complete pathological response was also seen in neoadjuvant dose-dense MVAC as compared to the GC. GC is gemcitabine cisplatin. So, according to this trial, the NCCN panel recommends neoadjuvant chemotherapy followed by radical cystectomy for patients with stage 2 or 3A bladder cancer. Neoadjuvant chemotherapy followed by radical cystectomy is a category 1 recommendation. So patients with hearing loss, neuropathy, poor performance status or renal insufficiency may not be eligible for cisplatin-based chemotherapy. So if cisplatin-based chemotherapy cannot be given, neoadjuvant chemotherapy is not recommended and such patients should go for direct surgery. In the second scenario, adjuvant chemotherapy, data are less clear with less number of patients accrued in the trials regarding the role of adjuvant systemic therapy in invasive bladder cancer. Studies have shown that adjuvant chemotherapy may delay recurrences and improve overall survival. As per the VESPER trial, which included a subgroup of 55 patients who were treated with either dose-dense MVAC or GemCis as adjuvant therapy, 3-year progression-free survival was improved in DDMVAC group than in GC group for all patients who received perioperative chemotherapy. And also in time to progression, DDMVAC fared well above GemCis for adjuvant chemotherapy. So again, National Comprehensive Cancer Network recommendation on adjuvant chemotherapy. If cisplatin-based neoadjuvant therapy was not given and the tumor is found to be T3, T4 or node positive following resection, adjuvant cisplatin-based chemotherapy is the preferred approach, although adjuvant nivolumab may be considered, but because of the cost issues, less common in this part of India. If cisplatin-based neoadjuvant therapy was given and the tumor is T2, T4A, means the pathological response complete has not been achieved, either we have T2 to T4A or node positive, then nivolumab may be considered. as we know that only pathological response, what we achieve with the neoadjuvant chemotherapy has not been more than 50%. So many times we will see such situations. Patients with tumor that are T2 or less and have no nodal involvement or lymphovascular invasion after cystectomy are considered to have lower risk and are not recommended to receive adjuvant therapy. Now in the third scenario, the chemotherapy for metastatic disease. Again, GEM-CIS and DDMBAC with growth factor support are category 1 recommendation for the metastatic disease. The performance status of the patient is a major determinant in the selection of a regimen. In patients who are not cisplatin eligible and whose tumor express PD-L1, or in patients who are not eligible for any platinum containing chemotherapy, we have recommendation FDA approved for atezolizumab and pembrolizumab are appropriate first line options. Carboplatin may be substituted for cisplatin in this situation. For cisplatin ineligible patients, such as those with GFR less than 60 ml per minute. Taxanes have been shown to be active as treatment options for urothelial bladder cancers, and the trials were there with gemcitabine cisplatin plus taxanes, but they didn't find cost-benefit ratio, and toxicity was more with the taxanes, and the advantage was not more than 3 months of survival. So the alternative regimens including cisplatin paclitaxel, gem paclitaxel, cisgem paclitaxel, carbo gem paclitaxel and cisplatin gem docetaxels have shown modest activity in patients with bladder cancer in phase 1 and 2 trials. And I finish my talk with this. Thank you very much.
Thank you, sir. It was a very vivid presentation. Sir, what are the chemotherapeutic options in patients with mixed urothelial carcinomas like micropapillary or nested variants, sir?
Again, we use mainly GEM-CIS only. We don't differ much. And of course, in squamous cell carcinoma also we use the GEM-CIS only.
Sir, what are the, sir, what is the role of, sir, this genetic evaluation, sir? After patient fails on the first line chemotherapy before on the second line chemotherapy, sir, is there any role, sir, of genetic evaluation, sir?
Yeah, actually the patients of urothelial cancer or urinary bladder cancer have maximum number of mutations, and when we send them for NGS panel, I think it is, we definitely will see some or other kind of type of mutations in this, of which the FGFR mutation is the maximum which we see. We see HER2 mutations also. So we are looking for actionable mutations where we have the drugs available. Although we will have different mutations, many will be having no drugs available in the market for them. So they will not be of much use. But definitely those, like those who are associated with some Lynch syndromes or associated with HER2 or associated with FGFR for which we have drug, we will be interested in those mutations.
Thanks.
Thank you, sir. Any question? We move on to our next speaker, Dr. Puneet Agarwal, who is a senior advisor in urology at RNR Hospital, Delhi. Sir will be speaking on stoma care, practical guide.
This is the new normal for the patient who undergoes radical surgery for the bladder. And this is the surgical skill of a surgeon that patient can appreciate and has to live for rest of their life. If, as a surgeon, we make up stoma something like this or something like this, let me tell you, both surgeon and patient are going to have a tough time in a post-operative period. During our pre-operative counseling, we generally show pictures like this to the patient for motivation with a healthy stoma and a spick and span external appendages on the stoma. With this, the patient is so highly motivated that they think something like this will happen, but most frequently we land up having patient like this in our OPD,
or something like this managing their stoma, because there is a disconnect between what we teach them, what they perceive, and finally what happens on ground. Good morning, ladies and gentlemen. Greeting from Army Hospital, R&R. If you see the clinical pathway of the patient undergoing radical cystectomy, they have a pre-operative counseling period, peri-operative period, and the post-operative period. The pre-operative period, we generally counsel them regarding the need of the surgery, and the patient might have reservation for the surgery because of their social, economical, or religious background. But once the patient has agreed for the surgery, in a peri-operative period, this is the most important step that we should emphasize and need to learn. And this we have learned during our general surgery training as well as in our super specialty training. And this was discussed yesterday also during the various surgical steps. So stoma should be positioned correctly. A type of stoma we should choose correctly, and it should be made on the rectus sheath, and it should be away from the line of incision. The ideal, the gap recommended is around 5 centimeter. However, it may not be always possible. And we should mark this stoma while the patient is sitting as well as standing, so that patient can see the stoma, and we should avoid any area of scar or radiation and any skin folds. During intraoperative period, the stomal length should be of at least 6 centimeter, where we can have a nipple of 2 to 3 centimeter in size, and adequate buttonhole should be made. The subcutaneous fat should not be excised, and there should be adequate cruciate incision should be given in the rectus sheath, so as to allow 2 fingers to pass in this patient. In immediately post-operative period, the stoma should look red, round, raised, and lumen should be at center with a smooth surface. Post-operative assessment should be done in a ward with a transparent flange, and we should look for any changes in the stoma. And first bag change should be done in the ward, and we should again need to motivate the patient, because patient might have leak in a post-operative period. The discharge is the most important time again that we need to counsel our patients. First about the skin care, where we need to apply different paste or sprays to protect the skin. And the use of stoma appliances, the patient might use a one piece pouch or 2-piece pouch, and the need to empty the stoma bag once it is half full. Then we should emphasize the need of use of bags in the night, so as to prevent leak in the night, and the ideal stomal bag should be changed every 3 to 5 days depending upon the weather condition. The patient should monitor his urine output in the post-operative period, and adequate hydration should be done in the post-operative period. The counseling regarding diet and nutrition should be given to the patient. If the patient is active, we should motivate them for exercise, and there is a requirement of placement of belt when the patients are doing their regular physical activity. At home, again the patient need to manage their stoma at home, and during the follow-up visit, if there are any changes in the stoma, that we need to again counsel and teach the patient regarding the stoma care. However, things may not go the way we want every time, and we might have a deviations from normal, and we might have a early or late operative complication. If we see the early operative complication, this is what we normally see in a post-operative period as a stomal edema, which usually subside in an early post-operative period, but we need to differentiate it from ischemia via either a needle prick or a light hue test, where a reddish hue can be seen through the stoma. The management includes the use of cold compresses or sprinkling of the table salt for 20 to 30 minutes in this patient. This is also commonly seen in post-operative period, where we have a bleeding from the stoma. It may be through the stoma or through the cutaneous skin, and the causes of bleeding may be extensive causes, which may include the portal hypertension or a flange itself. It might be damaging the stoma. The treatment depends upon the etiology of the peristomal hematoma, and most of the time the things can be managed conservatively. However, if things does not improve, we might have to take a hemostatic sutures, or we might have to use the sclerotherapy in this patient. This is the most dreaded complication that none of us want in a post-operative period, but we need to assess it early in form of ischemia or necrosis. The causes can be extensive denudation of the stoma of mesentery, or it may be seen in an obese patient, or it may be due to the pressure on the stoma itself because of less cutting in the rectus sheath. We should place a transparent pouch in the post-operative period, and we should with that, this mini endoscopy test of test tube, we should be able to see the extent of necrosis. If it is at the level of facial plane, we have to refashion the stoma. But if the necrosis is beyond the facial plate, the patient might have a peritonitis and urine leak. Then this becomes an absolute emergency where we need to operate. Mucocutaneous separation is caused when we make a buttonhole which is more than the size of the stoma, and this may further cause the retraction and necrosis in a late period, and when there is a urine spillage in these patients, they might have a burning and irritation. So management includes all such forms of protective devices in these patients, but if things does not improve, we might have to refashion the stoma or resuture the stoma to the cutaneous skin. The patient might come with a late complication. This we commonly see as a peristomal dermatitis, which is caused by any of the irritant factors, and the treatment includes any form of protection or use of a moldable flange or a convex flange with a belt in this patient. Stomal granulation again caused by the tight flange which we use in a post-operative period, or continuous irritation. Again, the management is conservative most of the time, and we have to advise patient to use a flange which is little larger than the size of stoma. A parastomal hernia we generally don't see in urological practice. However, if the loop ileostomy is seen, this might be there, and the management is conservative with the reduction of the prolapse. If things does not improve, we might have to refashion the stoma. A parastomal hernia again is it's a iatrogenic cause. It's more commonly seen when we place the stoma more laterally in the anterior abdominal wall. Treatment can be conservative with the use of binders and belts. If the things does not improve, we have to refashion the stoma. Stomal retraction is seen because of either mucocutaneous separation or a partial necrosis in this patient, and this patient might have a cutaneous irritation because of the leak of urine around the stoma. The treatment includes the use of a convex flange and use of flange along with the belt in this patient. If thing does not improve, we might have to refashion the stoma. The last is stomal stenosis, in which the patient might present with the uremic symptoms. The treatment includes the dilatation either with a metal dilator, or we can use a balloon dilator, but if things does not improve, we might have to refashion the stoma. But at the end, I want to say, if the patient still have lot of issues, but they accept stoma and stomal appliances as the integral part of their body, and they say, I am still alive, I owe that to the ostomy, and for that, I'll always be grateful. Thank you.
It was a very nice presentation, sir. Any questions from the audience? Sir, one quick question, sir. Regarding the parastomal hernia, sir. Is there any role of, sir, prophylactic mesh hernioplasty?
Sir, it is being recommended if the obese patient, very old patient, it is recommended to put a mesh along with the initial surgery itself. It is recommended. It is there in the literature, sir. But personally, we are not practicing.
So, moving on to our next speaker, Dr. T.V. Raja, sir.
Good morning. I thank Nazon USA and Gautam for calling me for this. So my topic is just tips and tricks of intracorporeal urinary diversion. Yesterday we saw a wonderful. What is it? No, me too. Not copied. Pen drive. So we know how to do the intracorporeal diversion, and this is a technique where it takes a lot of time, and especially neobladder. So I'm just giving a video presentation. Yeah, good reservoir, large capacity, so low intraluminal pressure for neobladder. The steps are self-explained in the video which I am going to show you that. So basically, in first I am showing neobladder where we do a student neobladder. The tip one is to get the ureter right side of the sigmoid colon. So as you saw yesterday, so you have to create a plane between the sigmoid mesentery and the bone, pectoral bone, and take it to the right side. Some people do it on the both the sides, little difficult and little worrying also, because it can get strangulated. And tip 2 is to get the measurement of the intestine properly, but we always measure it. Yesterday you saw Dr. Alavat not measuring completely, but we take stay sutures because sometimes you miss, especially in obese patients with lot of mesenteric fat. The tip 2 is to get actual measurement, whether you use umbilical tape or any measurement tool is okay, and mark it with different sutures at different levels. We usually put 4 sutures, different color and different length of sutures. So we know that which is proximal, which is middle and distal. So that that makes your life comfortable and you won't take any other wrong segment while doing a neobladder. So this is how we do it. The complete almost 45 centimeter to 50 centimeter of intestine marked, measured, and the stay sutures taken. You can see this is the white stay suture, and this is the last 15 centimeter of the unopened segment of neobladder. So this is the second tip. Third tip is to have tension-free adequacy of ileal length. So you have to check where you are going to anastomose, bring it. So the most important is to get the patient, reverse the tendril bulk, that is most important. And this is a female patient, you can see the uterus there, and see whether it goes and reaches the urethra. Tip 4 is to have the Rocco stitch, is similar to Rocco stitch herein, so we always do it so that because you know that the intestine is going to fall off and you have a little bit tension, and if you do a good Rocco stitch type of suturing at the intestine, then it becomes very easy. Then we have uretro-ileal anastomosis, standard one, you can see, open that, and this is little larger in size. Actually the urethra is also was larger, so the patient was married without any children, and muscle invasive bladder cancer post chemo. You can see nicely how urethral anastomosis. Again, the tip is to have watertight anastomosis, and whether you would want to do with the 2 sutures, 1 sutures is up to you. So I do posterior and anterior separately with 2 separate sutures. You can see watertight anastomosis very nicely, and especially in female patient is easy because pelvis is wide enough. And then we have a bowel cut and anastomosis, and this is the standard procedure where we use white stapler. Nowadays we use power gun, very easy to do that. And the side-to-side anastomosis is also standard with the blue cartridges, and we take side-to-side 2 cartridges so that you have adequate length and you can comfortably remove the T part of the segment. Next is detuberalization. As yesterday you saw that this is very important cut away from the anastomotic site, otherwise you will be having gangrene or ischemia of the segment between the cut and the suture. And then you just you can put your open the segment by using cautery, and you know which is the length. So the sutures will help you. Most important in neobladder is sutures, the marking sutures. And then what we do is that hold them and then close the posterior one. Again I am going to take 2 or 3 sutures because sometimes it goes inside, it's difficult to identify. And take sutures and the suture material. So I use barbed suture, and that is Statafix. It is a very fine barb. It's not going to harm any tissue. And this is a very good suture material, 3-0. And then we have to double fold it like what we just stood at neobladder. So you can see that the double folding has been done, and any corner you can just take it and fold it, just to make the neobladder conical rather than a tubular one. You can see that. And again, the right hand is helping to fix make the fold, and then go on suturing it the same suture. And we have a right limb and a left limb. It's a continuous suturing. You can take a whole thickness, but generally we take, in between we take seromuscular, in between we take complete one, so up to you. and the suturing continues on the left side. Yeah, I can fast forward. This is just a suturing. And then we have the ureteroileal anastomosis. Yesterday I used a Wallace technique. So I always do Brickus technique, which we learned from open surgery. So I didn't change. Only one patient I did Wallace. I was not happy with that. So the most important tip here is to have good spatulation of the ureter and with adequate vascularization. You can see that earlier I used to put the infant feeding tube and externals. Nowadays I put degestenting, and I do the anastomosis from outside, not from the inside. You can see. So once we do that, this is the classical Brickus anastomosis, and both the ureters are done now. And as the stoma creation becomes the next one, so you can see that. So this is the ureter, and then leak test and water test anastomosis has to be done. So I always put a SPC there and put some water in the neobladder and see whether any leak of saline you can make out. So this is the end of the suturing. After that, exteriorization of all the tubes, and for the ileal conduit is the same steps. Again, the taking good length of ileal conduits, usually 15 to 18 centimeter, depending upon the patient's body habitus. So you have to see that, and I always mark where I'm going to cut. Most important is you should not go parallel to the intestine, then you will be strangulating or causing ischemia to the ileum, and other steps are the same. So I'm going to fast forward that, and you can see nicely here we are going to put a ureteroileal anastomosis Brickus type with a stent inside. Earlier we used to put infant feeding tube even for ileal conduit. So now we put stents there. Very easy to do from outside in rather than doing inside out. You can see stay sutures at 6 o'clock and 12 o'clock and pull both the sutures, and then you will get a very nice intestine and this thing. So we used to do it in the same thing in open technique. And same thing we do, and again for the anastomosis I do 4-0 stata-fix rather than using 3-0 here. So very easy to do it. So that's about the ileal conduit. So now this is the data. Generally it takes around say 4 to 5 hours, and the neobladder takes to 5 to 6 hours. And this is a rough data. Complications are very similar to open surgery. And this is how the major tips and tricks of this creating intracarpal neobladder. Thank you so much.
Thank you, sir. Very nice explanation of each and every step, sir. Sir, regarding ureteroenteric anastomotic structure, sir, in ICUD, sir, actually there is more accurate and precise dissection of ureter, while in ECUD more length we have to dissect, sir. So the incidence of this ureteroenteric anastomotic structure in open and ECUD and ICUD, sir?
All are same. Is entirely depend on the technique. So according to me, the most common reason is to not to have adequate tissue around the ureter, holding the ureteric end roughly. These are the two things, and we have ICG available. And if I have any doubt, I put ICG, check it, and do the anastomosis. Very rare. And wrong anastomosis. These are all technically oriented. If you are good in technique, I think picture should not be, rate should not be different from an open versus robotic.
Probably the ureteric end that is cut directly holding with the robotic arm or the instrument, because those are really strong. Would it be better just tying a suture and then like a stay and then?
No, you can hold it, you can hold the periureteric tissue, not the entire, exactly the mucosa. Even in open surgery we use, do use it, hold it. It's not like, that is not the main cause. Main cause is the ischemia. Ischemia, you should avoid it, because you try when you are dissecting ureter, when you go near to the bladder, it becomes thin and thin. Although proximally you might have a tissue, periureter tissue, when the tip where you are going to anastomose it will be having less tissue. That is the most important factor I feel.
Thank you, sir.
Thank you so much.
Thank you. I request all the chairpersons and the speaker to proceed to the right of the auditorium for a group photograph and to collect their mementos. For the next session, I would like to call on stage Dr. K.K. Sharma, Chairman, KKS Hospital, Jaipur, Dr. Bodapati Shivaramakrishna, Professor in Urology from Kolar, Dr. Devendra Sharma, Senior Consultant Urologist at CK Birla Hospital, Jaipur, Dr. Shivanshu Singh, Consultant Urologist from Varanasi, Dr. Mahakshit Bhatt, Consultant Urologist from Jaipur.
Morning, folks. First of all, thanks to the organizers for inviting us for this privilege. My request to the speakers is, as per the request from the organizers, please stick to your time. So now, may I call upon Dr. Srikanth Srinivasan, Additional Professor, Community Medicine, Aiims, Jodhpur, to talk to us on
10th most common cancer in the world, and 3% of all new cancer cases are from urinary bladder cancers. ICMR data shows that we expect around 29,000 bladder cancer cases in the year 2025. It's an estimate. So there is an increase. If you see this Delhi data, there seems to be an increase of urinary bladder carcinoma cases. Yes, so a lot of people with bladder cancer are in need of palliative care. This is another data we have, that most of the patients to cancer hospitals come at the late stage. 80% come usually in the late stage, that usually in the stage 3 or stage 4 they will come to the OPD. So almost all will need the palliative care. So 2025, if you expect 29,000 urinary bladder patients, 80% of them coming late stage, so it will be 23,000, and around 4% only are getting exact palliative care in India. So it comes to around only 1,000 patients will be receiving the actual palliative care. That means more than 20,000 patients are going to be in entire India, somewhere from Kashmir to Kanyakumari, urothelial cancer patients who will be needing palliative care. So what is palliative care? It is a main aim to improve the quality of life of the patient till he lives. Palliative care, we are not going to cure the disease, just we are going to improve the quality of life of the patient. It can be provided through institution, home or hospice. Hospice centers are very limited in India. Institution based in Aiims, Jodhpur, we have pain and palliative care unit. We also have an wound and ostomy care unit. So whoever is interested, whichever nurse is interested in palliative care, we train the nurse in that particular wound and ostomy care, especially this colostomy care and urostomy care things. In the OPD, we manage the physical symptoms. Then we get the consent for home care. If the patient's relatives and the patient agrees for home care, then we provide home care. Because there needs to be a continuum of care for these patients. So patients also feel comfortable in receiving care at home. Sometimes they may be very difficult for them to come to Aiims or any tertiary care hospitals because of economic or other issues like lack of caregivers. So patients feel comfortable, they feel individual attention, they feel less socially isolated, and the home care team can do a full assessment of the patient and the family members. What is that full assessment means? We go by the total pain concept. That is, we not only address the physical symptoms but also the emotional, social and spiritual issues of the patient. Also, we are trying to address the caregiver's needs. Caregiver face a lot of fatigue and burnout now, so we address the psychosocial problems of the caregiver also. This is our home care team. We have a nurse, social worker, and a trained doctor. The doctors are trained through Indian Association of Palliative Care. They have a brief training. But whenever it comes to individualized patients, always a treating physician will be part of the particular team. So for our home care, if there is a urothelial carcinoma patient, we definitely will include the urologist in our team, and as per his advice only we proceed further. So we get permission from the patient and then we proceed for home care, and the home care activities are supervised by trained anesthetist and oncologist. So we do the assessment of and management of the patients at the home. At the end of the thing, we come back and discuss our findings and management with the treating physician. So at home, we have to have a good communication with the patient. We have to do active listening of the patient, and we also, as rapport builds up, we plan for advanced care planning of the patient. That is towards the end of life care patients and symptom management. We plan according to the evidence-based management. So we have to believe whatever the patient says as far as symptoms are concerned. Assessment of physical symptoms, remember this O, P, Q, R, S, T, U, V. O is onset of the symptom, P is palliative propagative factors, Q is quality of the symptom, then R is relieving factors or radiating factors, S is severity, T is time of the particular problem, understanding values of the patient, that is social component. So these are the symptoms which a urothelial carcinoma patient can come out with. The main problems will be pain and hematuria, and sometimes the excoriation of the stoma. Apart from that, because of chemotherapy or radiotherapy, there may be burning sensation, loss of appetite, insomnia, gastric irritation, bad odor from the stoma area, confusion if there is brain met, sore mouth, etc. So this is not the end. This is not that only 16 symptoms are there. So many problems may come up during these physical problems. WHO pain ladder is used for pain management. Morphine is one of the best drugs that can be given. This is a nurse home care visit, doctor and nurse visit, doctor and social worker visit, doctor and nurse social worker visits. Interventions, remember MBBS during your care, that is mouth, bowel, bladder and skin sleep should be taken care during your home care. Then pressure sore management. Special services, under the advice of the urologist, we go for ureal conduit care. Then if the patient has metastasis and tracheostomy has been done, we go for these cares if necessary. Ascetic tapping is done in certain parts of Kerala under the supervision of a doctor. Specialist palliative care, we refer the patient back to institution for these particular problems. So palliative care continues even after the death of the patient. We visit a home, bereavement visit is made. What are the problems we have? We have more experience in colostomy care but very less experience in urostomy care. That is one of the problems we are facing. These are some of the experiences shared by the home care team from a palliative care team in Kerala. So to conclude, palliative care starts from the time of diagnosis and it's an holistic approach. Multidisciplinary team is involved. It can be given in the institution as well as the home. And during the care, remember mouth, bowel, bladder, skin care, and then OPQRS, TUV in symptom management, and listen actively to the patient. Show empathy and do not have sympathy. So these are some of the references with respect to urothelial cancer and home-based care. A lot of PubMed articles are available. You can go through it. So towards the end, I would like to conclude that if you come across any patient who are in need of palliative care, try to find out the source available near to that particular patient and try to get that access to him. Thank you very much.
Thank you, Dr. Srikanth. Now, I would like to request Dr. Prashant Nayak to deliver his talk on laparoscopic radical cystectomy. How I do it.
At the outset, I'd like to thank Dr. Gautam and the team Jodhpur for inviting me here. This is my first Northern meeting of any kind. I bring you greetings from Eastern India. So, batteries. I think after seeing yesterday's amazing operative sessions, to see the video that I've got, I think it's redundant, so I'll be just skipping or fast forwarding through the video. I have some evidence that I wanted to place before the August gathering, so that is what I like to do rather than concentrate too much on the video part. So without much ado, so let me start. So this is the video that I think just will rush through. We have had a good number. I think in last 5 years, about 90 and odd cases we have done of laparoscopic radical cystectomy. We do get these large, bulky ones, and where even if they're papillary low-grade tumors, you still need to go ahead and do a RC because nothing else works. So these are some of the quaint little points that are important while you're doing a pelvic lymph node dissection. The common iliac ureter, external iliac, the growth you're seeing, and then generally start dissection from on top of a ureter, and then dissect, go down. So make sure that you're taking only the adventitia, not doing injury to the ureter. So how much down do you go? You can dissect up to the region of the vesicuretic junction, but I feel a part of the distal ureter remains to stay. So you need not go and clip the ureter right at the vesicuretic junction. So whether you do early, I think this point has been decided. Earlier we used to do early clamping of ureter, now we don't do that. So we leave the ureter intact, we dissect and keep it and clip it later. We should leave a part of the ureter. As I was saying, the distal ureter is part of a radical cystectomy. So you should leave a part of the distal ureter there. And then you come up and dissect it all the way up to the pelvic brim, so that that gets out of the way when you're doing the dissection. Dissection artery provides an excellent plane which allows you to dissect on top of the artery, and you dissect along the artery. Then you need to get into the plane behind the artery and the vein on top of the obturatus internus. So I think that is how I start my dissection. So getting into this plane is quite easy. that gives a very good plane. You get totally behind the vessels. You can go down and so dissect behind or lateral to the vessels. So many of my colleagues and others I have seen, they do the mobilization medial to the vessels. That's a struggle. So I would urge anyone who wants to start or somebody who's doing do try this method where you go behind. I think yesterday also we saw in the robotics, so generally you go behind and you can go right up distally. So go into, we can faster. And this also allows you to get in between the artery and the vein. So that is another area where you leave some amount of tissue. So when you go behind, you can dissect between the artery and the vein, and then you can go down in this approach itself and reach the operator nerve. So yeah, so that was, I was dissecting. So you can see dissecting, separate the artery and the vein and try to get that issue that is between the artery and the vein, so that you completely make them nude of all their investments. And then you go down and yeah, so here itself you can go down and you can look at the operator nerve. So you have to seek and you will find. And so definitely you look for the operator nerve, you'll find the operator nerve that allows you to dissect all the tissues. So once you have done this much from posterior, then you can come back to the medial part and then you can remove it. And that basically takes care of your lymph node dissection. The proximal extent would be, the effort should be to reach an extended lymph node dissection, reach up to the aortic bifurcation. And it doesn't add much to the patient morbidity. I think there is enough evidence about that. So that is the right and the left side done. This was a video of the radical cystectomy part. Posterior dissection is like in RP, then you do the lateral dissection, then drop the bladder anteriorly. I'm just going to fast forward this. I think all of you have had enough of this since yesterday, so drop it down. Yeah, so what I wanted to see, we look at the deep vascular complex, and if we see that the vascular complex is thin, most of the times you could manage it with an energy source. There is no need to put a suture. But if we see it is too broad and angry looking, then of course we use suture also. So that was, I think I'll fast forward a bit. Yeah, so only other thing I wanted to show was, yeah, so this is suturing of the TVC. That could also be done if we think it is too large and too bulky, and sometimes it leads to a bothersome bleeding. So we do that. And yeah, anti-spill clipping. So moment you take it out, and I generally inflate the bladder cuff and then you put a clip so that nothing spills out from the bladder. So that was about the video. So we had about 92 patients over 5 years. 32 mortality was 2 cases. One was DVT, one was sepsis. NACT, 10% cases, the patients that we cater to, we try our best to give NACT, but this is what the real world figure that I have, that only 10% of my patients receive NACT. And ileal conduit I do in 95% of patients. There are various reasons why NACT uptake is poor. Sometimes patients can't afford, sometimes patients, we send them for NACT, they talk to the oncologist and then they do not come back. So we have seen that the uptake of NACT is quite less. There is some evidence regarding IC versus orthotopic neobladder. A recent review from MSKCC 2020, although orthotopic diversion offers several advantages, only 20% of patients nationally receive this diversion, with decreasing utilization over time. So 20% in US. Ileal conduit versus orthotopic neobladder. So this was a retrospective study, comparison of post-operative complications. Long-term complications were significantly higher in the orthotopic neobladder with a significance of 0.04. Patients that receive neobladder should be informed of the increased risk of reoperations compared to an ileal conduit. Comparison of health-related quality of life, 2,500 patients. I'm just going to wind up. I just got 2 more slides. So 2,500 patients from 26 studies. Neobladder patients more likely to have post-operative urinary symptoms than ICD patients, than IC patients with a P0001. Ileal condi versus orthotopic, this was a stringent criteria to select study. They selected only 4 studies. They demonstrated better urinary function and urinary bother scores in ileal condi patients. This was a propensity score matched analysis using SEER database. 5,480 patients from 2004 to 15. I think 93% of the patients underwent ileal condi in this. About NACT, this was again a SEER data analysis. NACT has increased from 9% in 2003 to 19% in 2019, and it is 26% now. This is the SEER data from US. NACT 4,169, this is again another real world data from SEER. 39% patient NACT, 61% adjuvant chemotherapy. So this is an article come out in February 2023. E24, N1 to N3, no significant difference in overall survival between the 2 groups. In stage 3-4, where you have T34 plus or minus N plus, NAC shares similar treatment efficacy compared to adjuvant chemotherapy. NAC probably scores with better prognosis in stage 2 T2N0 patients. Thank you.
Thank you, Dr. Prashant, for a very crisp talk, and we now realize that you're doing excellent work in Bhubaneswar.
Thank you.
Since we are short of time, I think questions can be at personal interaction. Thank you.
May I now invite Dr. Meenakshi Rao to speak upon prostatic urethral carcinoma diagnostic dilemma.
Thank you, sir. Thanks to the organizers. I'll be speaking on the diagnostic dilemmas caused by prostatic urothelial carcinomas. Prostatic involvement is seen in 15 to 48% of cases undergoing cystoprostatectomy for bladder carcinoma. However, direct invasion of the prostate gland by an invasive bladder carcinoma is not considered to constitute a primary prostatic tumor. So what are prostatic urothelial carcinomas? These are tumors in which the urothelial carcinoma is arising from the urothelium of the prostatic urethra or the proximal portions of the prostatic ducts, which are also lined by urothelial epithelium. They are relatively rare, comprise just 1 to 4% of all the prostatic malignant tumors, and they were first described way back in 1952 when the patient also had a concurrent bladder urothelial carcinoma, and in 1963 when the patient had primary independent prostatic urothelial carcinomas. Clinical features are those of conventional prostatic adenocarcinoma as well as of urinary bladder tumors, and it's very important to diagnose these patients because the prognosis is very different from primary prostatic conventional adenocarcinomas, with a 5-year survival of just 7% to 52%. Also, the staging system is separate for these tumors. We stage them according to the prostatic urethra tumors rather than primary prostatic carcinomas. Apart from the clinical features, the PSA levels in these patients can be normal or they can be mildly elevated whenever the normal prostatic glands are destroyed by the invasive tumor. And these cases, not only on clinical features, on morphology also, they can be quite challenging, as will be highlighted by a couple of cases that I'll be showing. So this case was a 53-year male with the symptoms of lower urinary tract obstruction and enlarged prostate. PSA was 2 nanograms per ml. TURP performed elsewhere showed adenocarcinoma with a Gleason score of 5+1. However, the patient's symptoms were not relieved and he still had persistent dysuria, hematuria, following which he was referred to Aiims Jodhpur. So the TURP chips were reviewed at our institute, and all of us can see that there is definitely nests of tumor within the prostatic stroma. Low power view shows these are the normal prostatic acini, and in the stroma we can see separate discrete nests of tumor which on low power appear very blue in appearance compared to the normal prostatic acini. On high power view, we can see that the cells are markedly pleomorphic, very prominent nucleoli, 2 to 3 nucleoli, and very brisk mitosis, 3 to 4 mitosis per high power field. Very high grade tumor, so it was a high grade carcinoma, and since the nuclear features were very high grade, we did suspect whether it could be a urothelial carcinoma or maybe a high-grade prostatic carcinoma. So we put up a panel of IHC markers. PSA was negative in the tumor cells. These are normal prostatic acini which act as internal control for PSA. The tumor itself is negative. The tumor cells were positive for GATA3. Nice nuclear positivity seen. They were strongly positive for CK7 and also showed positivity for CK20. So this was a tumor which was high grade. It was expressing both CK720. It was negative for PSA and positive for GATA3. So a diagnosis of high grade urothelial carcinoma was given on the review blocks. Urine cytology also showed cells with markedly high NC ratio. NC ratio approaching almost 1 to 2. Very hyperchromatic nuclei and irregular nuclear membrane. So this was positive for high grade urothelial carcinoma. Following the biopsy and the cytology report, whole body PET scan showed increased uptake in the prostate, and at this time patient also had a metastatic lesion in the left ischium. Second case, this is of a 70-year male, similar obstructive symptoms for 1 year. PSA was 5.73 nanograms per deciliter. Again, TURP was performed and it was reported as adenocarcinoma with a Gleason score of 5+4. Blocks were reviewed and again we can see very discrete nests of tumor cells in the prostatic stroma. Lobar view also showed central comedo type of necrosis within the tumor cells. And hyper again show a very high nuclear pure morphism with very brisk bizarre mitosis are seen. Again, it was a high-grade tumor and we put up markers of both prostatic and urothelial origin. So this was negative for, these are the tumor nests, negative for NKX 3.1, negative for PSA, again normal prostatic acini are staining positive but the tumor nests are negative. P63 was also positive in the tumor cells which is not shown here. So this was also a case of high-grade urothelial carcinoma and it was a primary prostatic mass with no tumor in the bladder. So both these cases highlight what are the features which we should be alert for, we should look for, which leads us to suspect that these cases can be urothelial carcinoma. So whenever we are seeing discrete nests or sheets of cells with very high nuclear grade, because conventional prostatic adenocarcinomas, even if they are high grade, WHO grade 5, the nuclear features are low grade, mitosis is not very high. So whenever we are seeing high nuclear grade or mitosis, we should suspect urothelial carcinoma of the prostate and presence of necrosis, which is relatively less common in prostatic carcinomas. So just to show a comparison of this is a prostatic adenocarcinoma, this is urothelial carcinoma. Low par it appears more blue because of the high NC ratio. Again, these are appearing pale pink in appearance, this is appearing blue on low par. And a very high nuclear grade, urothelial carcinoma, and this is the prostatic. Even high grade tumors have a very round, regular, uniform nuclei compared to these urothelial tumors and very high mitosis seen in the urothelial tumors. Another case, difficult to say whether it is prostatic or urothelial carcinoma. And in these cases, IHC is very helpful and we put up a panel of markers, urothelial markers, P63, GATA3, high molecular weight cytokeratins, which can be CK56 or 34 beta E12. CK7, CK20, not primarily urothelial markers, but co-expression of these two markers is very specific for urothelial carcinoma. We also put up prostate-specific markers, PSA and NKX 3.1. So instead of putting up one marker, we always put up a panel of markers because as the tumor progresses in grade, there is loss of one or more of these markers. So we always move ahead with a panel of markers. A bit about role of a marker in such cases. A marker is not at all organ specific. It is positive in prostatic carcinomas, urothelial carcinomas, positive also in colorectal carcinomas. So it does not have much of a role. So that was the case which was positive for CK720, so it was a urothelial carcinoma. And this is prostatic adenocarcinoma, nice positivity for PSA and NKX 3.1. Cytology also, similar features, high nuclear grade features lead us to suspect urothelial carcinomas and very round uniform nuclei, this is a prostatic adenocarcinoma. So this is just a summary of the differences between the two which I have just discussed. So just to take home messages that prostatic urothelial carcinomas are very rare tumors. We need to have a very high index of suspicion both clinically and morphologically, and we should judiciously use a panel of IHC markers for the correct diagnosis because the management protocols and prognosis is different for these patients. Thank you.
Thank you, doctor. Any questions from the audience?
I'll be happy to answer any questions. The initial case had metastasis, so was referred for chemotherapy to the Department of Medical Oncology. Second, I am sorry the patient was lost to follow-up.
Thank you, ma'am. I think we come to the end of this session. Thank you, Dr. Arjun Sandhu and Team Urology for having us on stage.
A big thanks to all the chairpersons and the speakers. I request all of them to please move towards the right side of the auditorium for mementos and for a group photograph. Next, we have a panel discussion on bladder preservation for MIBC. Who are the ideal candidates and what are the options? For this, I would like to invite Dr. Swapan Sood, consultant urologist at Patel Hospital in Jalandhar, to moderate this session and invite his panelists.
Announcement? You have done the announcement? Good morning to all of you, and I think all of you must be in a hurry to catch your flights. So I'll request Dr. Umesh Sharma, Dr. Sanjay Surekha, Dr. R.K. Vyas, Dr. Pramod Kumar, and Dr. Harish Kasman to kindly join me on stage so that I can mitigate some of the pressure of the secretary and the organizing secretary of the conference, that I can finish the things early. Okay, so I think just to introduce this session, there is something you already know, that 30% of the first presentation carcinomas are going to be muscle invasive, and 1/5 of the early stages will progress to muscle invasive stage. And it is highly fatal, and if untreated, more than 85% of the patients die within 2 years of the diagnosis. The male-female ratio is 3:1. It's the 4th most common cancer in males. And 6 to 8 decade is the commonest of these things. And let me start off with making the statement for today is that the gold standard for treatment of MIBC is a radical cystectomy. Would any of the panelists like to debate that? Dr. Vyas, what would you say if I told you that Dr. Vyas is a radiation oncologist? He is the professor at Aiims Jodhpur, and I'd like your comment on this statement to start off.
Yeah, you are very right. The gold standard is still cystectomy. But two set of patients. One is that the patient is have a medical contraindication, or patient is not willing. So in a tumor board, the patient should be told in detail what are the consequences. And then if they are ready, surgery is the gold standard. If they are not willing, we can preserve the bladder, and the results are quite good. Only problem with radiation-based treatment is the patient has to undergo a repeated cystoscopy every 3 or 4 months. And there is the slightest doubt, then we can go ahead with the... And if we supplement these results with salvage cystectomy or proper cystectomy, they are comparable.
Okay, great. Then what exactly, for Dr. Pramod Kumar, who is an assistant professor in medical oncology, would be the need for BSP or bladder salvage protocols in this case? What would you assess? Since I've got your 5-year survival rates over here for PT2 and whatever is the all of them, would you consider in these results, would you consider any role for bladder salvage protocols when you are talking to the patient?
Yes, regarding bladder preservation protocol, since bladder preservation is often desired by the patient, and among the patient, there is a need of well selection of the patient. So in a well selected patient, the bladder preservation protocol can reproduce the result of radical cystectomy. In our settings, what is required in bladder preservation protocol is that there should be node negative tumor less than T3, and there is minimal or no the carcinoma in situ. So we have to select the patient, and in well selected patient, in many of the studies, the bladder preservation as protocol has reproduced the result as good as the radical cystectomy.
I think one of the important reasons why you have to consider bladder salvage protocols is also that there is a lot of morbidity which is attached to the radical cystectomy operation. Here's a list of all the things which we can expect as the negative side of the
there are a lot
radical cystectomy.
of morbidity with the radical cystectomy, but till today the standard of treatment is radical cystectomy. We have to accept this fact also.
Yeah, we agree. So that is why the need is there for whether there can be an alternate protocol, especially in those patients who may not want to
get
undergo this morbidity, or who cannot undergo this morbidity. So when we come for bladder sparing therapies, so Dr. Umesh, I have a list over here. What would you have a comment on this? What are the various kinds of therapy which you have, individual options? So now you see one of the situations which is conspiring is that you have very good results with radical cystectomy, but you also have a good morbidity, and somehow you have become in the position to counsel the patient regarding bladder salvage and take a risk regarding the future of the patient, or what is going to be his course through his life as vis-a-vis his disease process. So here, Umesh, can I
So there are various opportunities and various options are there to preserve the bladder. It starts with the monotherapy, then bimodal therapy and trimodal therapy, and following we can do the partial cystectomies also, plus minus with a new adjuvant treatment given and adjuvant settings. These all settings, monotherapy, bimodal therapy and trimodal therapy, the maximum closest survival rate with radical cystectomy is found in cases of trimodal therapy. If we give along with the concurrent radiotherapy.
We'll come to trimodal therapy. We'll discuss one
we have
of
lot of options,
one.
but we have to choose accordingly.
Yeah, so the decision is intensely personal. So you have to see the patient and you have to diagnose, and then you have to take a call on whether a kind of a personal treatment will work, whether bladder salvage protocol will work, considering that you have already a gold standard against which you want to fight. So Dr. Harish Kaswan, this is a case, you can see the details, T2, G2, and radiologically N0, 76 years old gentleman with an ECOG of 0, is perfectly non-smoker, is there, and he is negative presented with this kind of a tumor. Would you consider TURBT to be one of the monotherapy options? Would you offer him anything besides that? He's 76 years old, he doesn't have any problem. There's a small tumor, histopath turns out to be MIBC.
So in this patient, we can give option for repeat cystoscopy and as and when needed TURBT, and to biopsy from other sides also to rule out any deep muscle invasion.
Yes, Sanjay.
I just want to make one comment in the histopathological findings, T2, G2. So this is very, very, very unusual. I won't take the report very easily. I will take it with a pinch of salt. T1, G2 is sometimes possible, but T2, G1 or G2 is very unlikely. So you must review the slide with the uropathologist. Just one comment about the.
Okay, so let me say, how would the grade impact your decision to do TURBT alone? Or a patient doesn't want to be doing anything else. And how many of you have had a patient with a small tumor and you counseled him for, it turned out to be MIBC, and then you counseled him for a radical cystectomy and he never came back again? He never came back to you again. How many of you have had a patient? Let us say, Umesh, do you have?
Yeah, we have one or two patients, couple of patients in which it was very small tumor. We did a TURBT and it came out to be a muscle invasive, low grade disease. So it was hard to counsel the patient that we are removing a bladder for such a small tumor. So definitely after proper counseling, some patients agree for that, but most of the patients, they seek other opinion and they run away from the center. They come back later on when something has worsened, or in that scenario, basically. But I have one patient who is, I did maximum TURBT and the patient was a Rixa puller, and he begged that don't remove my bladder. I did it, and finally after radiotherapy he is doing well.
So TURBT alone is an option in highly selected cases.
Yes.
So one of these studies has also reported a 76% cancer survival even at 10 years, cancer-specific survival, out of a study of 99 patients. It is there with her. It has to have an accessible tumor location. There has to be a complete resection. There is a negative TURBT biopsy. Tumor size is small. These are the cases which will where you can consider TURBT alone. No, I'm not saying that it is an option to a gold standard or it is comparable to a gold standard. You should not go ahead with it. But then if the patient is requesting a bladder salvage protocol and he is not willing for any treatment, then perhaps in your mind you could consider a redo TURBT and surveillance for this patient. Okay, so Sanjay, I haven't had a question with you. What about partial cystectomy?
Yeah, partial cystectomy is a part of bladder preservation therapy, but you have to be again that well-selected patient. The location
as a monotherapy, we are talking as a monotherapy. Is partial cystectomy an option?
To my understanding, I won't offer a patient as a partial cystectomy as a sole option. So whenever the patient is suitable for partial nephrectomy, I always add the patient with chemotherapy in a muscle invasive bladder cancer, with a neoadjuvant setting or adjuvant setting, whatever setting it is. But only partial cystectomy, as of my current understanding, it is not a sole option.
So this is an 85-year-old gentleman, PT3, and there is a diverticulum with a big tumor. Cystoscopy is not showing any intravesical masses, and the CIS is negative for the patient. What are the options with you over here? पेशेंट doesn't know ये मैं तो ठीक मुझे बिल्कुल मेरे साथ सारी उम्र निकल गई है ये ब्लीडिंग बंद कर दो किसी तरह से.
So in this setting, I won't say it is a curative partial cystectomy. I would say it's a palliative partial cystectomy, and patient is fit for any further treatment. Then chemotherapy, radiotherapy, whatever he is willing for, I will offer. If not willing, then just I will call it a palliative. It's not a definitive treatment.
I agree with you. Bladder salvage protocols are going to have their consequences, and many of the patients are going to need further treatment, and we should keep that in mind. But there are a certain group of patients where you could consider just a partial cystectomy. For example, we did that in this case, and we removed the tumor. Patient is doing.
We have to understand this is this is not a standard of care. It is an inferior treatment for as compared to standard. But in a specific situation, you have to consider overall situation, age, the patient's comorbidity, fitness. So you can offer any treatment as per the suitable for that patient. So that cannot be a standard of care. But yeah, in a specific patient you can offer.
So we said the standard of care is radical cystectomy, and still we want to go ahead with the bladder salvage protocols. That is the consideration. We are trying to select some candidates, and we are going to offer them certain options. So in a partial cystectomy may be possible where there is a solitary lesion which is less than 3 to 4 centimeter in size, 2 to 3 centimeter margin is feasible. There is no carcinoma in situ, no need for ureteric implantation, and there is no overactive bladder. Obviously, there is going to be a shrinkage in the capacity of the bladder. And the 5-year overall survival and CSS 55 and 70% in these selected cases. Although you can see the recurrence rate, like Sanjay was saying, almost 38 to 49%. And ultimately, almost 1/3 of them, they required a radical cystectomy to complete the treatment. One of the common conditions, again, Dr. Pramod Kumar, we give patient neoadjuvant chemotherapy. Patient comes back with R0, the radiologically R0 disease is there. And this is a good percentage of the patient, almost 30 to 40% of the patients if you go as per the literature, although I believe it is not as common in our subgroup of patients as the Indian patients, but I don't know what your experience is regarding this. What are your thoughts about just giving chemotherapy in this case?
Well, in my experience, I spent 3 years in Rishikesh, and there are a lot of bladder cancer patients coming there. There is a reduction, a partial response was as seen with the neoadjuvant chemotherapy. Complete response were very few patients who had complete response with NACT. However, if patient have NACT, have complete response with the NACT and it fits into the criteria which are laid down for bladder preservation, and patient is willing and patient understand the consequences of bladder preservation, the recurrence risk and the potential recurrence around and the potential that patient may underwent radical cystectomy later on, around 20 to 30% patient require this. So if patient understand, then definitely we can offer him bladder preservation in this setting.
So you see in this case about 5 years OS was around 64% and there was a 64% relapse rate. Obviously the bladder is still there and it was a carcinomatous bladder to start off with, the relapse is going to be there, but only 38% were actually muscle invasive and could have proceeded to radical prostatectomy, although the study did not elaborate what they did with these patients, those patients who had a superficial recurrence or what they had with the recurrence, but I took it as a good study to demonstrate that yes, NAC can lead to a
Yes,
R0.
Downstaging with NAC may have a role, but right now, with our experience, we have not seen patient responding so beautifully with NAC.
Yeah, we are just arming you with information for those patients who are not going to undergo further radical cystectomy. So you see another study by Maza et al. Again, relapse rate is around 48% and the muscle invasive was 23%. The point is that the rate of muscle invasion has gone down. Although they did not elaborate what they did with these patients and what happened to them subsequently. But this is a possibility what we can do. So if you are going to use chemotherapy alone, then you better have a patient who has a low risk disease, CT2 disease, solitary less than 5 centimeter, no adenomyosis, no CIS. It's not the gold standard, Sanjay, but yes, it is one of the options in certain group of patients.
And so one more, the bladder neck involvement is contraindication for bladder preservation.
Okay, great. So Dr. Vyas, what about radiotherapy as a monotherapy?
In our patients, most of the time it's not monotherapy, it is trimodality. Against surgery is involved in the form of TURBT, and TURBT should be as complete as possible.
Yes.
If we want to get good results of radiation. And if we are given neoadjuvant, it's okay. Otherwise, I will recommend it's not a monotherapy, it should be substituted with the concurrent chemotherapy.
So typically frail individuals who cannot undergo any other kind of disease, you, for lack of any other treatment modality, you offer them radiotherapy.
So if we are giving radiotherapy, it should be substituted with the at least concurrent chemoradiation.
Yeah, okay. So coming to the talk of the day, which is the trimodal. Yeah, you wanted to say anything? Okay. So we'll go fast through the trimodal therapy. What is, Umesh, can you specify, is there are they the same terms calling the same person by different names or are they different? Can you just
for maximum TURBT, it should be the maximum TURBT where we can see the fat. The obvious fat we need to see, we remove all the muscles behind that. Radical is same term, staging TURBT and complete TURBT, maybe it's a re-stage TURBT where we go and do the re-resection, the tumor, the bed tumor, re-resect it for the muscle yield. And
so essentially,
more or less they are same terms, they are used.
They are interchangeable terms. Even your staging TURBT as far as possible should be complete treatment. You should not take only a small.
Essence is to remove the complete bladder.
Yes, the goal is to remove all visible disease without compromising the safety. Complete it. The removal will. Yeah, Sanjoy, you want to say?
Actually, the maximal TURBT and radical TURBT is probably a little different. Radical TURBT, what Umesh said is absolutely right. You do radical, you go till the fat. Maximal TURBT is what you can do maximum. It's not always not possible to do the maximum. You cannot go beyond the fat. You can remove maybe all the visible tumor.
So one of
whatever best possible you can do. So that is
essentialities of a TMT is that you have to have a maximal TURBT, maximum reduction in the tumor volume before you start any other process. What would you say in TMT? Now, Sanjay, you are one of the experts of TMT. What about neoadjuvant, concurrent adjuvant chemotherapy, and what are the agents which you are going to sort of propose?
So there are many TMT protocols. So currently, of late, the protocols which has been followed in different recent studies like SPURS studies and all. So they have given 2 to 3 cycle of neoadjuvant chemotherapy, and then they have assessed. And that includes cisplatin and gemcitabine. This is unifocal. This is unanomalously it is cisplatin and gemcitabine in neoadjuvant setting. And subsequently, they have done cystoscopy, and if there is good response, that patient has been taken for maybe bladder preservation protocol, which include radiotherapy and again cisplatin and gemcitabine in adjuvant setting. And radiosensitizer, they have some of the studies use radiosensitizer, which include 5-fluorouracil or 5-FU. So these are the.
You would agree with that assessment?
For radiosensitization, drug is have largest data is regarding is for cisplatin.
And if patient has some contraindication for cisplatin, then we go for mitomycin 5-FU or single agent gemcitabine.
So there is no such thing as neoadjuvant chemotherapy in TMT? You are already doing the TURBT?
We are doing the TURBT. After TURBT, in a concurrent chemotherapy, we have to start the chemotherapy as well as radiotherapy. If you are not doing the radiotherapy, then it is considered to be a neoadjuvant. So for concurrent means you have to start the chemo along with radio.
Okay, so between neoadjuvant and the radiotherapy, will you do a restaging TURBT?
Between chemotherapy and
you did
before
a TURBT,
starting the radiotherapy.
You did a TURBT.
Yes.
You did the neoadjuvant chemotherapy. Now in the TMT you are planning for a radiotherapy. Before radiotherapy, will you do a restaging TURBT?
So this radiotherapy can also be given in two stepwise approach. You can give in whole radiation in one approach where you do the recheck cystoscopy after 3 to 4 weeks. And if you are splitting the radiation therapy in consolidation and induction phase, then after induction, 4 to 6 weeks you can recheck, reassess whether you are getting the favorable response or not, and then give the remaining dose of radiotherapy.
Yes, Sanjay, you want to?
Most of the protocol, as you said, you will do.
When is the second TURBT done? Before the radiotherapy or after the radiotherapy?
Before, most of the setup or studies have done before the radiotherapy. Neoadjuvant, TURBT, neoadjuvant followed by cystoscopy or a TURBT, then radiotherapy. Accordingly, they have taken the call.
Okay, fine. What about the radiotherapy? I'll quickly go through that, sir. Can you just elaborate what is the radiotherapy protocol for these patients?
Because most of the centers have the ultra-modern machines, facility for IGRT, so now we are reducing the time. So most of the protocols, they are 55 grain, 20 fractions. So treatment is finished within 4 weeks. So that is the standard now, if we have the ultimate facility for the organ at risk.
Yeah, just about the focused radiotherapy, only in that portion of the bladder where the tumor is there?
Yeah, if it is, we are taking the full radiation, means that we have to include the nodes also. And if it is properly staged, and we are very sure that it is N0 sometimes, and it's a T2 disease, we can only irradiate the bladder. So,
right. So regarding this, there is no upfront randomized control trial between TMT versus the RC protocols. The only trial which was started was the SPARE trial, and in the SPARE trial they tried to randomize patients into the RC arm and into the selective bladder preservation arm. Would Sanjay, you are familiar with this SPARE trial? Would you like to elaborate?
Basically, this was a when the trial was started, it was lots of, it's going to be a very big trial and all. It was NHS funded trial, it was an UK group trial. But what happened, they had such a poor accrual. They tried a lot to have a good accrual and complete the trial, but I think only 40 or 45 odd patient has finally included in the trial, and because the inclusion criteria and all are very strong, and it was, but patients, problem was the patient were not declined for going into the trial. So ultimately the trial was closed, but whatever they could gather from this information, I think 25 or 20 patients in 2 arms, it was a non-inferiority trial. They just wanted to prove that probably neoadjuvant plus what we discussed, TURBT, neoadjuvant followed by cystoscopy, then they randomized into 2 arms. So they found it's almost equivalent. It's not in.
So there were three takeaways from the trial. That the initial bladder preservation rate was higher, was very good in the SBP, and you could actually filter out those patients who would not improve, who would respond only to radical cystectomy in almost 90% of the cases. Also, it was an intensely personal decision between the physician, and he was not able to control. The main person was not able to control what kind of patients they should be able to select. So the bladder sparing protocols, they had good results. When you start comparing with the other groups, we'll just finish in a minute. They had good results as compared to radical cystectomy. But how it was assessed was basically on quality of life, recurrence, salvage RC, and cost. And as Dr. Pramod, how do you compare the results? Let us say QOL, the recurrence rate, what about the salvage RC, and then the cost? I just presented the slide to you.
The bladder preservation has good, it's shown to be better for quality of life.
Obviously.
And it's so obvious. However, we have to see, you should consider the recurrence part, because if the patient recur, then he'll be very symptomatic, and the subsequent options are very difficult to handle. So we should keep the fact that if we can reduce the recurrence risk by by selecting good patient for this protocol, then definitely the bladder preservation will be a better option in future.
Right. So in future now, new things which are coming up with tetramodal therapy, where you do a partial cystectomy of that area, where you use biomarkers to determine which patients will respond to bladder sparing protocols, and immune checkpoint inhibitors are just coming in. All these are in the studies and in the cooking up phase right now. So if you have a selection criteria for trimodal therapy, would you agree with this assessment, Dr. Vyas or Dr. Moh?
Yeah, that list is quite ideal. And as you mentioned, this coming time, I have also read a few articles where you just address the nodes surgically and preserve the bladder. So that may also be a
part you do the radiotherapy, but you do a lymphadenectomy.
So you preserve the bladder and address the nodes.
Preserve the bladder.
So the radiotherapy volume will also be lessened.
Right. So the conclusion is that the current standard TMT with prompt salvage cystectomy is equivalent to RC. But one of the points which I need to point out is when the RC trials have been taken, they have been taken across the board, and the BSP is only for selected patients. So the results may or may not be comparable. Sanjay, you have a comment?
I just want to make one comment finally. If you are including the patient for trimodal therapy and bladder preservation, the patient should be highly motivated, because there are substantial amount of patient. We have maybe 30 to 40% patient who came with a bad recurrence, and they lost in follow-up, and finally they came with the metastasis. So that's and operating those patients after radiotherapy is again a daunting task. So we have to understand all those when you will include those patients into the trimodal therapy. Thank you.
Right, so before all of you go, I'll just leave you with a question which you can think about as you go. This is an 87 years old gentleman. You tell me what to do with this patient. Creatinine is 4. Thank you very much for a patient hearing everything.
Nephrosis, and that is a contraindication for bladder preservation.
It's not a contraindication for radical cystectomy, right?
Thank you so much, sir. I would request all the chairpersons to please move towards the right of the auditorium for a group photograph and mementos. The last session for the day is a panel discussion on upper tract urothelial carcinoma. Details regarding kidney preservation, lymphadenectomy, neoadjuvant chemotherapy, adjuvant chemotherapy, and bladder cuff management. And for that, I would like to call upon stage Dr. Tushar Aditya Narayan, consultant uro-oncologist and robotic surgeon at Max Saket, to moderate the discussion and call the panelists.
Hi, good afternoon, everyone, and thank you to the organizing team for giving me this opportunity to hold this panel discussion. We are running very late, and I was in two minds whether we should go ahead or not. Dr. Gautam assured me that the Delhi flight will not leave without Elawat sir, so I'm happy I won't miss my flight. Sir is still here with us, and he is one of my panelists. I'll call the panelist on stage. My first panelist is Dr. Rajesh Elawat. He is the group chairman at Medanta, the Medicity. My second panelist is Professor S.P. Yadav. Sir is here. He is the managing director at Pushpanjali Hospital and is the former head of department of PGI Rohtak. Dr. Puneet Parekh, he is not here. We'll go ahead. He was supposed to join us. He's an additional professor from radiation oncology at Aiims Jodhpur. Dr. Saurabh Patil, he is a consultant urologist and robotic surgeon at Fortis Hospital in Mulund in Mumbai. And my last panelist, Dr. Harkirat Singh Talwar, he is a consultant in urology at Medanta, the Medicity, Gurgaon. So it was supposed to be for 30 minutes, but I'll try to wrap it up in 10 to 15 minutes. So let's start with the first case. It's a 70-year-old gentleman, smoker, no comorbidities, good performance status, had hematuria, was evaluated, had a CT scan, and the CT scan showed this, basically a right upper tract TCC, 3 centimeter renal pelvic mass, and the urine for malignant cytology was positive. The bladder was normal. So starting with the diagnostic workup, I had a few questions on all of these, but I will try to rush in through. All of us will get a CT urogram, I'm sure. Urine for malignant cytology, all of us, all 4 panelists agree, we'll get a urine for malignant cytology looking at that picture. Cystoscopy, yes, to rule out any lesion in the bladder. Now comes the tricky question, how many of us will do a flexible ureteroscopy and a biopsy? Would anyone do a flexible ureteroscopy and a biopsy in this patient when the CT is positive and the urine for malignant cytology is positive?
Now here the main thing is to re-stratify this patient.
Okay.
If you follow EAU guidelines, it clearly states that even if you do flexible ureteroscopy, you don't need to take the biopsy. Just imaging and cytology is enough to re-stratify and plan for the treatment. But if you want to prove it, you can go ahead, but preferably without biopsy.
So would anyone want to prove it, or we should go ahead with treatment?
Sir, if the CT scan and the cystoscopy are showing without doubt that this is a UTUC, I would skip a uterinoscopy. And also that there are studies which show that doing a flexible uterinoscopy would increase the chances of bladder difference later on.
Yes, there are a few studies which have stated that if you do a uterinoscopy, that might increase the chance of recurrence later in the bladder. I'm not sure how well powered those studies were, but there are studies. So the panel agrees that we can do without a uterinoscopy. Go ahead with the treatment with the CT scan and the malignant cytology. Perfect. How about FDG PET scan?
Not required.
Not required,
That's
sir.
not
Allow
part
us,
of
sir.
any recommendation by any society.
Yes, but would you in your practice, sir, get a PET scan done? If a patient comes to you in Gurgaon, would you get a PET scan done?
Not sir.
He'll get advice for this from somewhere, but
From
we
somewhere.
always dissuade them
Right,
that
sir.
it's not needed.
So it's not in the advice, but right, sir. We'll finish. So yeah, so he's given me the timing to finish. Yeah. So it's not in the guidelines, but I think a lot of us have moved on to getting a FDG PET scan done, probably even in bladder cancer and upper tract TCC cancers. So these are the EAU recommendations. Perform a cystoscopy, obviously it's a strong recommendation, CT urogram, and use diagnostic ureteroscopy and biopsy if the imaging and cytology are not sufficient for the diagnosis and or for risk stratification of the tumor, as Dr. Patil clearly mentioned it. And for FDG and MRI, it's a weak recommendation. So let's proceed with this case. So we'll talk about management of upper tract TCCs. We've already spoken about risk stratification. So EAU gives us something called as a low risk and something called as a high risk. Low risk are unifocal tumors, tumors less than 2 centimeters, negative cytology, and low grade on biopsy. And all the rest are high grade TCCs. So role of neoadjuvant chemotherapy in upper tract TCC. I wanted to go into depth of it, but I will not. So any one of you from the 4 panelists has experience with neoadjuvant for T3, T4 upper tract TCCs? Have your medical oncologist given any patient neoadjuvant? Allow it, sir.
No, I think we haven't had experience, but there is enough of logic and the suggestions that this is like bladder tumor, this is what should work.
Right.
And the only problem is that, staging. So staging is in upper tract urothelial cancer is incomplete without pathology.
Right.
So you have to base your decision on clinical staging.
Right.
But if the clinical stage is high or the grade is high, and if it is obviously renal involvement, fat involvement, and T3 disease, then certainly, because after removal of the kidney, application of adjuvant chemotherapy is so poor because of the poor renal function.
Yes,
so this would be the right time to do neoadjuvant.
So probably T3, T4 N positive disease on imaging and non-metastatic, probably we can consider neoadjuvant chemotherapy because adjuvant would be difficult because of the following GFR. There are no randomized controlled trials, only retrospective studies. There are 2 studies which I have picked up which have shown that there is an overall survival benefit with neoadjuvant chemotherapy, and it's logical as extrapolated from bladder cancers. So now coming to the surgery. We would do a radical nephroureterectomy with a bladder cuff excision for this patient for the right 3 centimeter upper tract TCC. Now let's talk about the surgery. We can either do an open laparoscopic or a robotic radical nephroureterectomy depending on the facilities available. We will do a cystoscopy if not done earlier. Everyone would agree on that during the surgery. Now coming to the excision of the bladder cuff. Let's talk about that because that's an important aspect. That's the critical point in this surgery. How do we deal with the bladder cuff? I'll start with Dr. Patil. How would you deal with, you would do a robotic nephroureterectomy?
So even if you do open or robotic or laparoscopic, the idea is to have a good bladder cuff and all
Complete
this
bladder
technique-
cuff, yeah.
Right, correct. And all these technique are, I mean, interception and plug technique are
What,
not that
what
good.
do you do generally?
Yeah, correct. So we usually do extravesical bladder.
Complete extravesical.
Extravesical.
So-
And there is report in recent, I think 2022 Journal of Urology, where they have mentioned that there are two risk factors for intravesical recurrence. One is like doctor said, biopsy of, and second is intravesical bladder cuff management. So extravesical is better to
Okay,
prevent
so
it.
complete extravesical, you will just do a cystoscopy. If not done earlier, you won't do any cutting around the ureter, do completely extravesical. After taking the ureter, do you close it with sutures or you leave it there?
Sorry?
Once you've taken the cuff extravesically, do you suture it up, the bladder, and then do a litmus? Perfect. So that's the complete extravesical approach. Professor Yadav, what about you? How would you handle this?
I agree. A complete extravasation with closure.
Of the bladder.
Closure
right.
of the bladder.
Elavad sir, similar technique?
I think we have moved along, We started with plug technique 15 years ago.
Right.
Then we started using a hemolog on the plugged ureter.
Yes.
Before, because there could be spillage in the retroperitoneum when you are handling the kidney, because that was the first part. And then moved on to extra vesicle techniques once the robotic thing came up. And since then, probably even with laparoscopy, we always do, if we are forced to do a laparoscopic lower end dealing, we try and remove the cuff extravesically and close it primarily.
Dr. Talwar?
In my previous institute, we used to core the orifice before doing the
You would
complete
core the orifice
but
before,
here at Vedanta,
okay.
we do a complete extravesical and close the
senior panelist, do you feel it would help us if we core the ureter and then do the complete extravesical later and then suture it up?
It doesn't help much.
Doesn't help much. Okay, so a complete extravesical is
Yes,
what the
it's
panelists
good
agree
enough.
on.
It's
Perfect.
good enough.
So completely extravesical. Okay, so let's come to lymphadenectomy. 3 questions: when to do a lymphadenectomy, what template to follow, and what are the numbers which the studies quote is adequate. When would you do a lymphadenectomy? For this patient, 3 centimeter tumor filling the renal pelvis, would you do a lymphadenectomy for this patient?
Yes, definitely. This is in high risk category, so all high risk patients should undergo a template-based complete lymphadenectomy. Even if the grade is low grade, EAV has clearly mentioned that you should perform, whenever you are subjecting a patient for radical nephrectomy, you should perform a complete template-based lymphadenectomy.
Right.
About the number, more than the number, important is the completeness of the template.
Right.
And the complete template-based lymphadenectomy.
Professor Yadav?
In this case, I agree.
You'll do a lymphadenectomy?
In this
yes.
case,
I love it.
In addition to that, there are studies which show that minimum number of lymph nodes that has to be removed is 8.
8, right? Perfect, sir. Yes. So I was just coming to that study. Harkirat, anything to add, or you would do a
I would agree
lymphadenectomy?
with every radical nephrectomy.
And not just the highlight, but a complete
Template-based
Perfect. So yes, the panelists agree. We should do in all high-risk cases. That was the next question, when to do a lymphadenectomy. High-risk cases as per the EAU risk stratification. Obviously, all T3, T4, N-positive disease, large tumors, sessile tumors, because they would be high-grade. This was a systematic review, which has been summarized by all my panelists already. So we don't do just a hilar node, it should be a complete template-based lymph node dissection. These are the 3 pictures for upper, mid, and lower ureter TCC. This paper was published in the European Urology in 2009 and again supports a template-based lymph node dissection, and the minimum node required was 8 in most of the papers. This paper said 4, but most of the papers said 8 nodes should be removed on a template-based lymph node dissection. Coming to role of post-operative mitomycin, we have done a radical nephroureterectomy for this patient. Now how about putting single dose of mitomycin? Does it help? Start again with Dr. Patil. Would you in your practice put mitomycin?
Yeah, correct. It helps in reducing the recurrence in bladder in the first year of nephroureterectomy.
Right. So all patients of radical nephroureterectomy, after closing the bladder, doing a leak test, you would do
either in the same sitting or maybe after within 2 to 10 days of
2 to 10 days. So what do you generally do in your practice?
Usually 2 to 10 days.
2 to 10. So you send the patient home and then call back.
They are usually
in the hospital. Okay. Professor Yadav?
I agree. It should be definitely used within first 2 weeks.
Right.
But a lot of literature now says that
then we use the same time, same setting also.
Right, sir. Elawat, sir, what would you say?
I think well, now that we close the bladder primarily, we can use it within first 24 hours.
Right. Harkirat?
Yes, the guidelines also say that EAU says within 10 days, Campbell says within 7 days, but nowadays immediate post-op also we can perform a cystogram and then
Right. So yes, it should be used. Timing, I feel as soon as possible that it can be placed should be most beneficial. And as sir said, now we've done a leak test. There's no leak from the bladder. I think there are studies which have come up. This was an interesting study, which I'll skip the other ones, which said the timing intraoperative versus postoperative. So this group has done the mitomycin installation during the procedure. So it was quite interesting. They've done a leak test, there's no leak, and on table they've put mitomycin and they showed that it had, the recurrence rate was 16% in intraoperative versus 33% which was in the post-operative period. So this was something good, and probably we will move to intraoperative because we've made sure that there's no leak in the bladder. Adjuvant chemotherapy. This patient, the histopathology, final histopathology was PT3, N0, there were no nodes. So for PT3, T4 or N plus tumors, what's the role of adjuvant chemotherapy?
The definitive role, and it has a survival benefit if you use this platinum-based chemotherapies. The main problem is the nephron loss after nephrorectomy.
Right.
But if patient is eligible, definitely.
Gemcitabine, cisplatin-based chemotherapy. Professor Yadav, you agree with this? Perfect.
P3 patient, high risk patient, I agree with it.
Okay. Elawat sir, you also?
I think, yeah, the POUT trial has in no doubt, leaves no doubts that these patients need adjuvant.
So skipping the thing, T3, T4, N plus high-risk patients, adjuvant chemotherapy has a survival benefit for these patients. And POUT said it should be given within 93 months from the date of surgery. Right. There was another, right, okay. I have 5 minutes more. 10 minutes, right? Okay, perfect, thank you. So this was a systematic analysis, a systematic review and meta-analysis for neoadjuvant and adjuvant chemotherapy. And they said that both neoadjuvant and adjuvant has improvement in overall survival, the cancer-specific survival, but the data for neoadjuvant, as we discussed, is not so robust as it's for adjuvant chemotherapy. So POUT trial has established adjuvant chemotherapy. We probably need another trial, something like POUT, to establish neoadjuvant chemotherapy in upper tract TCCs, as now it has been established for bladder cancers. I don't have the radiotherapist on my panel today, so I had the question for him, a role of any adjuvant radiotherapy for these cancers. The literature does not support the role of any adjuvant radiotherapy for upper tract TCCs. So coming to finally the recommendations, we should perform a radical nephrorectomy in patients with high-risk non-metastatic upper tract cancers. It should be probably preferably an open when it's a non-organ confined disease. We should do a template-based lymphadenectomy just so that we get all the lymph nodes out. And we should offer post-operative systemic platinum-based, gemcitabine cisplatin-based chemotherapy to patients with high-risk non-metastatic upper tract urothelial cancers. And obviously, we should give a single dose of intravesical mitomycin. So for the renal preservation strategies, I had 3 patients which I want to discuss. I'll just have to briefly discuss 3 cases. The first patient is a 65-year-old gentleman, CKD, hypertensive, diabetic, and has a 1.5 centimeter tumor in the right renal pelvis. Rest of the upper tract and the bladders are normal. The cytology is negative, and his creatinine is 2.5. He's CKD, hypertensive, diabetic, with a 1.5 centimeter renal pelvis tumor. So what would be the treatment options for the 4 panelists? I'll start from Dr. Patil.
This is already CKD and low risk, fortunately low risk category patient. We can try ureteroscopic removal of tumor and hope for the best.
Ureteroscopic removal of the tumor. Okay, right.
Yeah, I agree. I agree looking at the CKD patient.
Right.
Ureteroscopic
removal, not cardiac nephrectomy.
Can be tried.
Right. Elawat, sir?
I think the suggestion would be the same, that they'll have 2 options, either to go after this, because even transplant would not be a close option in future. So this is under supervision, it could be. But I'm sure you would come to adjuvant
installations in these cases.
Right.
So they would have a definite role, now that mitogel has come.
Mitogel, yes.
And that even, those impregnated stents have come.
Right.
With the gemcitabine impregnated stents, self-resolving stents are there. So they would have a good role in these cases if they...
Right. So you would also prefer a renal preservation strategy and do just the tumor removal, flexible ureteroscopic tumor removal, and then probably installation of some chemotherapeutic agent inside the renal tumor. Dr. Harkit, you have similar views or something else?
So do a kidney sparing surgery, either a ureteroscopic approach or a percutaneous approach.
Percutaneous approach, okay. Yes, we can also have a percutaneous approach on this.
Any role of BCG irrigation after putting ureteric catheter?
Dr. Ailavat, would you advise BCG irrigation from, if you have done a percutaneous approach?
No, with BCG there has been no literature support of use of BCG in upper tract. It has never worked because it's because of the impact time that the BCG stays in the upper tract.
Right. Has anyone in the audience used BCG for upper tract TCCs through a percutaneous approach? I can't see any hands. No one has. Oh, I see 2 hands. Okay. Okay. Dr. Sachin, how was the response? No? Okay. Okay. Thank you. So most of us have not used BCGs for the upper tract. Coming to the second patient, she's a 60-year-old lady, hypertensive and diabetic. She has a filling defect in the lower left ureter, imaging suggestive of growth in the ureter. Urine for malignant cytology is positive for high-grade malignant cells, normal creatinine. It's a growth in the lower ureter, paravesical growth. So what are our treatment options? Would we offer a radical nephrourectomy to this patient, or would we do a distal ureterectomy and then reimplant the ureter onto the bladder?
Cytology positive means high risk. So
yes.
Ideally, we should go for radical nephrectomy along with lymph node dissection.
Right.
If she doesn't.
That's the standard textbook suggestion if we have to do that. Right. Would any one of us offer distal ureterectomy and a ureteric reimplantation for her? Considering she is hypertensive, she is diabetic, although her creatinine is normal.
Unless and until it's a low-grade disease or the patient has a high risk for surgery.
Right.
Right. After nephrourectomy.
Yeah. Okay.
The standard of treatment would be radical
nephrourectomy. So all the 4 panelists agree it would be, okay, Professor Yadav also agrees, Harkit, yes?
But the guidelines clearly now say that there are equivalent results between segmental high-risk distal tumors in the ureter. You can.
It's not in the guidelines. Probably some studies have shown that the results are same, but I don't think it's in the guideline. Would still say that it's radical nephrourectomy should be the first option. But there are studies which have done a distal urectomy, ureteric implantation, and the results have been the same. That's why I wanted to discuss. So 3 of my panelists would do a radical nephrourectomy, and 1 panelist would do a distal urectomy and a ureteric reimplantation. How many in the audience would do a distal urectomy? Can you have a raise of hands, please? Distal urectomy? Anyone? No. So everyone agrees it should be a radical nephrourectomy. Okay. Fair enough. The third and the last case is a 45-year-old gentleman, no comorbidities, has a right exophytic renal mass 10 into 8 centimeters on CT suggestive of renal cell carcinoma. And on the left side, there's a lower ureteric filling defect. A ureteroscopic biopsy was done, which was high-grade PT1, and UFMC was positive, and the right renal mass was also biopsied, which was RCC. So he has a right large renal RCC and left lower ureteric tumor. The UFMC is positive, similar to the previous patient, creatinine is normal. Now what are our treatment options?
Now, Dr. Tushar, you have left us no option but to do one-sided radical nephrectomy.
Yes, so for the right side, we have to remove the kidney.
Correct.
What about the left side? Because again, it's the
Left
similar
side is
tumor.
No option, distal ureterectomy and ureteric reimplant maybe. Or maybe if he comes to you, you can perform exopitic mass, you can perform partial nephrectomy in one side. And maximum nephrons can be saved.
Probably for a 10 centimeter mass, if we can do a nephron sparing, we should attempt, yes. But I remember the patient, it was a huge mass which was completely replacing the whole of the kidney. So
then we have no option but
radical
on one side.
nephrectomy. Okay. And left side, ureteric reimplantation.
We have to, yeah, because otherwise putting him on dialysis would be a very morbid option.
Okay. Professor Yadav, similar views or do you?
No option in this case.
Right.
There's
So
no
you would
option.
not remove the left kidney, you will just remove the distal ureter and
Yes,
let the left kidney and put him on surveillance.
Right nephrourectomy.
Elavat sir?
and it's fully justified with low-grade tumor on the lower ureter. You could have different views in this previous patient, but not in this one.
Right, so Harpreet, you also agree? Same. So right side we'll do a, perfect, thank you sir. Right side we'll do a radical nephrectomy, left side we'll do a lower ureter implantation. And that I think is the last slide. Let me see. Yeah, thank you. Thank you sir.
I thank all the chairpersons and the speaker. Kindly proceed to the right of the auditorium for the group photograph and mementos.
Dear delegates, please stay back. We are starting with the validatory function within 5 minutes. And I will request everybody to stay back, and after that we will have lunch, and then we can all board our flights back to our home destination.
Without further ado, I would now like to invite to the stage President North Zone of USI, Dr. Vijay Bora, Secretary North Zone USI, Dr. Kamaljeet Singh, President-elect North Zone USI, Dr. P.P. Singh, Organizing Chairman, Professor A.S. Sandhu, Organizing Secretary, Dr. Gautam Ram Chaudhary. Kindly give a big round of applause for everyone, please. I would request now Dr. Bora, sir, to give his brief remarks.
I'll not take much time. First of all, I congratulate Dr. Sandhu and Dr. Gautam for a nice, wonderful workshop, midterm CME, and it was full of academic feast and grand gala dinner. And they have actually set the bar for the midterm CUE, and I hope in future everyone will try to cope up with this bar. Thank you very much.
I would now request Dr. Kamaljeet Singh, sir, for his comments.
Respected dignitaries on the dais and esteemed urologists in the August gathering. I'm very sorry, my speech is not going to be that brief, but because I have to cover the protocol, every part is. Let's be very honest, as everybody in this gathering agrees to this CME has been very seamlessly conducted. Now, whenever you do a program which is almost flawless, the appreciation goes to the whole team. It was led very ably by Professor Sandhu, executed very well by Dr. Gautam and his team. Now, I will be using the team Jodhpur because this includes all the persons who are involved in the organization. right starting from the top till your OT staff, the postgraduate students, the auditorium staff, everybody is. Let's be very honest, is everything went smoothly moment we landed in Jodhpur. We were very cordially, everything was arranged, our hotel stay was very well managed. In fact, before we landed, we were all given a very warm welcome and we had what next we are supposed to do. All scientific sessions were conducted well in time, and apart from today, which we are just 30 minutes late, usually in the conference we go a couple of hours late, everything went very well. I must congratulate all the invited faculty and thank them from the core of the heart and on the behalf of the North Zone Council for giving demonstrating excellent operative skills followed by excellent deliberations throughout the day. The support, you can say the departments, that from the microbiology, nuclear medicine, pathology, and the radiology and the radiotherapy department of the Aiims faculty, I'm very thankful to them. Today's one lecture, which really was what we normally face by Dr. Meenakshi Roy, is one what really touched me the most, that we do have a very good talent at Aiims Jodhpur. I do agree to what Dr. Vijay Bora sir said, is that Gautam has raised the bar. Actually, Gautam has, or the team Jodhpur has really, is not what we are seeing, is there is immense talent which is there in North Zone is. And I am very thankful to Team Jodhpur for such a lovely show. This is the start of the academic feast for the year 2022 and 23, and what a secretary North Zone would not like to have such a big opening. So our opening stand has been an excellent one, and I would like to thank Team Jodhpur from the core of the heart, and I take all the blame for any shortcomings if there is. Gautam has done lovely work. Thank you.
Thank you, sir. I would now request Professor A.S. Sandhu to say a few words.
Good afternoon, everyone. So, first of all, I'd like to thank the North Zone Council and USI for supporting us in organizing this event at a very short notice, that too in March, which is very difficult to do after UCCon. And I want to thank our esteemed guests and all seniors, teachers, delegates, and also the young colleagues and residents who have come from far and wide, from all corners of the country. They have come almost to attend, and in great number, and have participated very wholeheartedly and with lot of enthusiasm. So your enthusiasm gives us a lot of energy to do things, and I hope that in future we will get opportunity to organize even bigger conferences. And I want to thank, from the bottom of my heart, my urology department and all the faculty in urology department, and especially Gautam, Shivcharan, Mahendra, Rahul Jena, who is not here, but he is in UK, and also he gave a lot of valuable suggestions, and Deepak. And my team in the urology department, that is the office team, headed by Mr. Tikam Dadij. They have worked tirelessly day and night without any complaint, and even gone beyond what we expected them to do. And as you saw yesterday, the OT was conducted flawlessly. It was because of the people who are working behind the scene. Not only the operating surgeons, but people working behind the scenes, especially if you start the nursing officers, they worked very enthusiastically. The ward staff, the ward boys, ward ladies, the housekeepers, the security staff, transport, and all this we could do because administration of Aiims was behind us. Our executive director, Dr. Kar, was behind us, and we could achieve this all because of their support. The trade also was very supportive and at very short notice, like I mentioned earlier. And this is the fag end of financial year, but they still came out in large numbers and supported very enthusiastically. Actually, initially, when we were discussing in Delhi during UCCon, it seemed like almost impossible task. But it has become a reality, and it is all because of your enthusiasm and blessings. So thank you very much. We wish you a very safe journey back home and look forward to seeing you again sometime. Thank you very much.
I request any interested member from the audience to kindly come forward and to say a few words. Yeah, that's fine.
No, on behalf of all the people who have gathered here, I must convey our sincere thanks for a wonderful conference, for a best academic bonanza, for the unparalleled hospitality. And from all the people out here, I convey our sincere thanks to you, and we pray that in the days to come, you will have a much more bigger show to express to the whole of the country. Thank you very much.
I would like to just add one thing. Registration fees was very good and very minimal, and that was expected. Thank you.
I have one small complaint. It is not very fair not to leave any opportunity for complaining. That is not very good. Thank you very much.
Thank you, everyone. Moving to presentation of mementos, I request Professor A.S. Sandhu to present a memento to Dr. Vijay Bora, President, North Zone, USI. I request Dr. Professor A.S. Sandhu to present a memento to Dr. P.P. Singh, President-elect, North Zone, USI. I request Dr. Gautam Ram Chaudhary to present a memento to Kamaljeet Singh Sir, the Secretary of North Zone, USI. I request Dr. Vijay Bora Sir to present a memento to Professor A.S. Sandhu, Organizing Chairman.
Now it's the time for the North Zone to appreciate token of appreciation to the organizing team, and I will take this opportunity to grab the mic. Now may I request Dr. P.P. Singh and Dr. Vijay Bora to kindly come forward and present a memento to Dr. A.S. Sandhu sir. Now I request Dr. Bora and Dr. P.P. Singh to kindly present a memento to the organizing secretary, Dr. Gautam. वो फोटो खींच रहे थे, फोटो खींच रहे थे. Now, sir, please stay back. There are a lot of mementos to be given. Dr. Shiv, kindly come. Dr. Shiv is a joint organizing secretary for the CME. Dr. Dharamveer Singh. Then Dr. Prakash Chaudhary, please. Dr. Prakash is not here. May I request Dr. Mahendra to kindly come and collect? Dr. Deepak, sir. Now I'm going to call the crowd, all the postgraduates of Aiims Jodhpur, on stage right now. Medical College and the Singh department, please come forward. जल्दी जल्दी आओ. अगर फ्लाइट छूटी तो हम यहाँ तुम्हारे साथ रहेंगे सारे. झेलना मुश्किल है हमें. May I request Professor Sandhu, Dr. Vijay Bora and Dr. P.P. Singh to kindly stay back. We need to express our sincere thanks to the backbone of the North Zone, in fact of the Urological Society of India. He is none other than Mr. Navneet Arora. Actually, his better half is down with some injuries, but he still managed, he braved everything and came for our society. There were two competitions which were held. I will request Dr. Bora and Dr. P.P. Singh to kindly stay back. We had a postgraduate quiz and a poster presentations which were assessed by the judges. We have the results. The home team gets the first prize in the quiz competition. Dr. Vikram Singh. The second name is very familiar to me because this chap also got a lot of prizes at Bikaner. Dr. Umang Agarwal. Anybody from Aiims Rishikesh? Anybody? Any faculty member from Aiims Rishikesh? No. So we'll send it. The third prize is now shared between the two, Dr. Suman Sahu and Dr. Deepak Dubey. The certificates for these things will be, all the competitions will be sent to you by email. We are awaiting the CDF format of the certificate and we will send it ASAP to you. In case you don't get it, you can contact me anytime. Suman, stay back. Suman, stay back. Suman has been a regular prize winner for us, and then poster this time he took the first prize. He's from Aiims Bhubaneswar. Now the home batsman again did wonders. Dr. Karthik Sharma from Aiims Jodhpur. Now the third prize is again shared, and this is from my favorite, the field, that is the Army, Indian Army, RNR Colonel Rajat Prabhakar. Sir. And it is again a shared prize with the home team, that is from the Medical College Jodhpur, Dr. Chetan. No, Dr. Chetan, their second shared prize, and this is one of Dr. Chetan. Now I hand over the mic to the host back for the final part of the valedictory function.
I request Dr. Gautam Ram Chaudhary to give vote of thanks.
Okay. Good afternoon, all dignitaries on dais and all guests sitting in hall. I thank you very much for coming, and first of all, thanks to North Zone for giving the opportunity and the Aiims administration for providing all facility for conducting such a huge, I should say that it's a midterm, but it was a huge conference in the term of the live operative surgeries and the panel discussion and contents of the topic. So it was huge in my view. For that, those who all involved, so already Sandhu sir has mentioned their name, but I will add some names to make it complete and to cut my short this speech. So I would like to add name of the anesthetist, and I would like to add the name of the auditorium team, those who are sitting backstage, mainly the residents. Those are working very hard and they are calling all faculties, all speakers on time, and they are checking the time. And those sitting person here, because of them, the live streaming was very perfect and on time. And other team, those I would like to add name, or I would like to take name again, is the OR team. So as sir mentioned, when we talk of the team, then from the top, Sandhu sir, to bottom, those who work in the OR, all are involved, and in ward, the nursing officers and the seniors, those who are taking care of the patients. So thanks to all of them, and then thanks to the Jodhpur Urology Forum and the residents from the SNMC. They also actively involved, and they were one of the force which made the conference very successful. And of course the sponsored, they came forward for the generous support, and in support in the form of the sponsorship, and in personal, like in some work in physical form also they were available, and because of them we could our job was bit easy. Then also I would like to thanks to the media in form of the digital and the print media. Those support was immense, and they covered very well our conference. And thank you once again those who visited here, and I feel we could serve what we wanted to. Thanks. Thank you. Please proceed for the lunch, and then please. Sorry. Oh, sorry. National anthem.
I request everyone to kindly stand up for national anthem.
जनगणमन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड उत्कल बंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे.
It has been a fantastic experience hosting this show, but all good things must come to an end. Wishing everyone a safe journey and looking forward to meeting all of you once again. Jeena and Priyank signing off. Thank you.